Good morning. Good morning, respected and dear all. Good morning, respected and dear all. Honorable, respected Head of the Department of Pharmacology and Therapeutics, Professor R.K. Dixit sir, esteemed faculty members, dear delegates and speakers, a very warm and gracious welcome to you all. On behalf of organizing committee, I, Dr. Rashmi Chandra,
and myself, Dr. Alisha, Senior Resident, Department of Pharmacology, extend our heartfelt greetings to distinguished gathering assembled for the National CME Program on Systematic Review and Meta-Analysis, organized under the aegis of Association of Community Pharmacotherapeutics with its guiding motto, From Rational Drugs to Responsible Society. ACP is affiliated with the Department of Pharmacology and Therapeutics at the prestigious King George's Medical University and was founded with a clear and powerful philosophy that scientific knowledge must not remain confined to lecture hall and conferences, but should translate into meaningful impact and community. Through awareness programs, rational therapeutics education, safe medication practices, ACP strives to protect community from myth, malpractices, and misinformation. We believe in joining ACP not for personal benefit, but to serve society, educate communities, and eradicate myth, and ultimately save lives.
in today's era of information explosion, thousands of studies are published every year, yet not all evidence holds the equal value. Systematic review and meta-analysis stand at the highest of the evidence hierarchy. This CME has been organized to strengthen the research methodology, promote high-quality evidence synthesis, encourage young researchers to undertake systematic reviews, and support evidence-based medicine. Before we proceed further, I would like to request all participants that pre-test link has been shared in official CME WhatsApp group. Kindly complete the pre-test. The post-test link and feedback form will be shared at the end of the CME. Completion of both is mandatory for certification. Before we begin with the academic session, I would like to invite our respected HOD sir to share his valuable insights on Association of Community Pharmacotherapeutics. Sir, please guide us with your words.
Thank you. So good morning all, and I welcome you all, those who are offline as well as who are connected with the online. So it's our pleasure to have a first CME under the aegis of Association of Community Pharmacotherapeutics, which is a newly born but having a highest potential to be, utilized in the community. So this association has been framed in our department, and this association aims for the rational therapeutics and breaking the myths, and ultimately whatever knowledge we are having in we get in institutions, that is useless till it is utilized in the community. That is the basic purpose of this association. So we talk lots of advancement. Unfortunately, these advancements have nothing to do in the community. We talk lots of recent drugs. They have nothing to do with the community, because community needs something different than the advancement. And that's how we thought that this association should be created. And this association has a motto that each and every individual in the community, remote and remote, must get the proper treatment and the rational treatment, and should not be being misused by the quacks and other persons. So that is how we are starting our journey. I congratulate the team which is organizing the first CME, and that is very pertinent. Why it is very pertinent? Because This is regarding the evidence. The era is era of evidence. If you say that God exists, everybody will ask, where is the evidence? So that's how the quotation is. Everything needs evidence except the God. And that's how the first CME has been actually designed. And this designing of the CME has been under the leadership of Professor Rahul Kumar. Professor Rahul Kumar took the lead, and I congratulate you. And I am, and whole team which is devoted. I am seeing that this is the work is being done. I mean, 24 hours under his guidance, and ultimately it will give the shape which will be able to deliver something to the audience, because everything is not needed to you, everything is not required to you, everything is not possible to be delivered in one CME. So at least after this CME and workshop, you will be having at least something, primarily basic knowledge about the meta-analysis and the systematic review. Now these two things are the crisp of the modern era, because you don't need anything for these things. You need only the brain, a laptop, a high internet, and your common sense. And you can do wonders. Those who are online, I am suggesting you, please focus over these type of research, because these research, they are strengthening whatever research has been done previously. And these are the research which can be done at any center, anywhere. If you don't have animal house, you can do. If you don't have animal any facility, you can do. And that's how you can, add in your CV as well as add to the society. So with these words, I congratulate again and welcome you all for this wonderful CME, and I am sure that at the end of the day, you will be remembering crisp points regarding the basics of systematic review and the meta-analysis. Thank you all.
Thank you, sir. Now, without further delay, let us embark on this academic journey. To lay the groundwork, I invite Dr. Rahul Kumar sir to deliver opening lecture on introduction of systematic review and meta-analysis.
A very good morning to our respected head sir, dear seniors, delegates and dear students. The first lecture Good morning. Okay. So today's first lecture is on introduction and steps in systematic review and meta-analysis. So what is systematic review and what is meta-analysis, and what is the difference between these two? First of all, it is systematic review, not systemic review. So there is a confusion whether it is a systematic or systemic. And what is systematic review? Systematic review, in this we search certain articles. If it is international SRMA, then we search for certain RCTs, and we have to do it systematically. We have to identify it systematically, we have to select, we have to critically appraise it systematically. That's why it is called systematically. And at the last, we have to extract the data, analyze the data and present it. Then what is meta-analysis? Is it synonymous with the systematic review, or there is little difference? There is a little difference. When we extract data in systematic review, and if there is very less heterogeneity, then we can club the data of the included RCTs and mix it in one, and what we get at the end, it is systematic, it is meta-analysis. Means when we apply statistics on the data we obtain from the systematic review, it is meta-analysis. So it will be more clear by the example of potato and orange. Suppose you are planning to make a soup. So you went to the market, you are planning something, it is your protocol, it is your planning. You went to the market, you only got there some vegetables. Then you can mix vegetables, you can make a soup. Means you can club the data and you can make the meta-analysis, you can apply statistics. Suppose in other case, your plan was to make the soup, vegetable soup. You went to the market, you were able to got only potato. And the other thing you were able to got, it is orange. Can you make vegetable soup in this case? No. You can define what is potato. You can describe the characteristic of the potato. Separately, separately you can mention the characteristics of orange, but you cannot club these two, potato and oranges, to make the soup. In that case you are able to perform only systematic review. Okay, so this is the difference between systematic review and the meta-analysis. If you are able only to plan, you make a protocol. Sometimes you may not be able to get vegetable in the market, you may not be able to get any RCTs, then your process stops here. You just write your protocol, you cannot move further to write the systematic review. Suppose you are able to write systematic review but not able to club the RCTs, then you have to stop here without performing meta-analysis. So there are three things: first, writing just protocol; second, just perform systematic review; and the third one is the meta-analysis. Is it clear to everyone? So just to summarize, systematic review is the comprehensive analysis, all the relevant data. Meta-analysis, when you apply statistics. Systematic review, you just need to summarize the evidence in a structured way. In meta-analysis, you have to one single estimate of all the effect, means average or sum of all the included RCTs. So in the last, all systematic reviews may not have meta-analysis. Some may be without meta-analysis if there is lot of heterogeneity. As in the case of potato and orange, there is lot of heterogeneity. And in meta-analysis, if you are able to analyze, you are able to perform the meta-analysis, then at the last it allows you to analyze quantitative of the findings in a systematic review. Now, why do we need a systematic review? What is the need? To keep us update, to keep the society update, to keep the clinicians update about the recent findings, to introduce new treatment, to discontinue the older treatment. You have to prove continuously what is better, what is not. So for this, you need to perform systematic review and meta-analysis. And the most important part of systematic review and meta-analysis is in drafting guidelines. Most of the guidelines by WHO, these systematic review and meta-analysis have a role. So types of systematic review and meta-analysis, in short I will call it SRMA. So types of SRMA, it can be according to the purpose or according to the included studies. If our purpose is interventional studies, to analyze the interventional studies, then the SRMA may be of interventional systematic reviews meta-analysis. If our purpose is to know which diagnostic test is better than the other, then we perform DTA, diagnostic test accuracy, SRMA. If our purpose is to know the association between the exposure and the outcome, then we have to perform this etiology or risk factor, SRMA. And if our purpose is to calculate, to know about the incidence and the prevalence, then we have to perform descriptive epidemiology, SRMA. So there are lots of types of systematic review. It's not only about the interventional studies. Then according to the type of included RCTs, if we are including only RCTs, then RCT SRMA. If we are including only observational studies, yes, we can also perform SRMA on observational studies, then observational. Then again, we can perform systematic review and meta-analysis on the animal data also. So it is preclinical or animal SRMA. And there may be mixed design. Mixed design means we can include any type of article. It may be RCT, it may be observational study, it may be cross-sectional studies, it may be animal studies. Then It is mixed design SRMA. So application of SRMA, where we can use it? It can be used in the thesis, in dissertation, in research purposes, and for our academic growth, for promotion. In year 2021, 76% of new WHO guidelines were framed on the basis of the data generated by Cochrane reviews. So you can see the application, 76% guidelines just by Cochrane reviews. Then what is Cochrane reviews? Cochrane was started on the name of Scottish medical researcher Archie Cochrane. His full name is Archibald Lemon Cochrane, but commonly known as Archie Cochrane. He strongly advocated for evidence-based medicine and for RCTs. So in his name, this Cochrane collaboration was started in 1993 after 5 years of his death. So first director of Cochrane collaboration is Dr. Ian Geoffrey Chalmers, and the current CEO is Carla Soers-Weser. Earlier there was a post of director, but now there is only post of CEO. So this Cochrane is mainly involved in systematic review and meta-analysis. So one is the Cochrane reviews. Are there other kinds of reviews, systematic reviews? Yes. One is Cochrane reviews and other is non-Cochrane reviews. So what is the difference between, which one is more common? Systematic review. First systematic review was written in the year 1905, but not in the name of systematic review and meta-analysis, but the structure was similar. The first systematic review and meta-analysis was written in 1993, and the data is available from 1993 to 2022. So there is approximately 2.5 lakh systematic reviews and meta-analysis between this duration, and 94% are non-Cochrane systematic reviews, only 6% are Cochrane reviews. Even 6% are Cochrane reviews, and they are very commonly, very extensively used for drafting the guidelines. So you can know the power of Cochrane reviews. And of the Cochrane reviews, 1/3 of all the Cochrane reviews are from one country, means UK, because it started in the UK. And if you include the 5 basic English speaking countries like UK, USA, Australia, Canada, so then its data becomes 2/3. So 2/3 of Cochrane reviews are from these 5 countries. And next comes the China, around 10 to 14% systematic review and meta-analysis. I am speaking about the Cochrane. They comes from China. So to sum up, the difference between the Cochrane and the non-Cochrane systematic review and meta-analysis, global recognition is very high for Cochrane reviews. So you start with non-Cochrane meta-analysis, and later on you have to come to the Cochrane systematic review and meta-analysis, because the methodological rigor is very high, very standardized in Cochrane reviews. In non-Cochrane reviews, it totally depends on the author. उसे कितना strong rigor रखना है methods, कितना relax करना है, it totally depends on the author. Okay, there is no fixed rule for non-Cochrane SRMA. Topic coverage, very structured program in Cochrane reviews. Cochrane reviews has certain groups, Cochrane review groups, CRGs. So what is the topic? They have to allow us, we have to take their permission, only then we can proceed with the Cochrane systematic reviews. But in case of non-Cochrane systematic reviews, whatever we decide, we choose topic by ourselves and we can start it just by registering in the Prospero. Using guidelines, Cochrane reviews are extensively used in formation of the guidelines, in WHO guidelines. Non-Cochrane systematic reviews are also used in making guidelines, but not too much to that extent as Cochrane reviews. Now getting started, SRMA, how to start it with? So it starts with the idea, with a research question, which is a hypothesis. If you have a research question, then next step is formation of team. So how much members, minimum number of authors required to start the Cochrane review, systematic review? 1, 2, 3. Why not 1? Even one author can do everything. There are systematic review and meta-analysis that are performed only by one author. Okay, but it is not standard. So minimum you should have 3 authors. Why 3 authors? The aim of the systematic review and meta-analysis is to present the evidence of higher level without any bias. And if only one author is performing SRMA, then there is chance of lot of bias. So to remove the bias, there should be more than two, more than one. Okay, suppose there are two authors in a review, then suppose मैंने कहा no, yes, this study can be included, this study cannot be included by the other author, then there is a confusion. Who will decide? The third person. So that's why there should be minimum 3 persons, 3 authors for writing SRMA to solve any confusion, to solve any conflict. So this is a standard minimum 3. It can be more than 3. Ideally 6 to 8. What is the maximum number? No limit. Okay. This Cochrane review, see the number of authors in this, 41 authors. So there is no upper limit. And in one Cochrane review, the number of authors is around 1500. Why such a large number? They included, suppose they included 15 RCTs or 20 RCTs, and there are 15 authors per RCT. Then they include all the authors of all the RCTs as authors of their systematic review. So that's why 1500 authors. And in one non-medical review related to the physics, there were around 5000 authors. So I am just showing these examples. There is no upper limit, but ideally it should be 6 to 8, and minimum number is 3, more than 3. Now protocol. So before starting systematic review and meta-analysis, you have to make a protocol. Protocol is a must. Protocol is a priori statement which help you throughout the SRMA. Whenever there is a confusion, you have any doubt, you have to refer again your protocol. What kind of studies we have to include? What is our Pico? What studies we have to exclude? So a very large discussion, very detailed discussion needed while you are drafting your protocol. Only then you can perform your or write your SRMA in a good way. So protocol for systematic review. I am not going into detail how to write a protocol for Cochrane systematic review, but I will show you in short how it looks. So this is a protocol for review. Title is Interventions for Smoking Cessation in Patient Psychiatric Setting, just to show you. So these are the contents of a protocol: abstract, background, objective, methods, acknowledgement, differences, appendices, contribution of author, declaration of interest, sources of new. Nothing new. You all know about it very well. Then abstract of a protocol. Yes, there should be abstract in protocol also, but in Cochrane protocol we mention only about the objectives. There is no need to write full abstract. But in the case of non-Cochrane abstract, there is a fixed structure. It should include objective, introduction, eligibility criteria, methods. In eligibility criteria, what to mention, what is the Pico, what to include, what to exclude. In methods, how will we perform our search strategy, how will perform the risk of bias. So all the details you have to provide in this. Now the background. In Cochrane reviews protocol, we have to mention the background or introduction under 4 headings. What is the disease, what is the description, what is the condition we are taking about. Then next, what is the intervention. Then how the intervention we are taking might work in the condition, and why it is important for doctors, for clinicians, for the society. What is the importance of doing this systematic review and meta-analysis. Then objective may be primary and the secondary. Then the methods. So method, why there is difference between Cochrane review and the non-Cochrane review. The method part of Cochrane review is very strict, very rigor. So these are the subheadings for writing the protocol of a Cochrane review. So criteria for considering the studies for the review, types of studies you want to include, you want to exclude, types of participant, inclusion, exclusion, types of the outcome, inclusion, exclusion, type of the intervention with inclusion and the exclusion. Now search methods for identification of the studies. आपको पहले डिस्क्राइब करना पड़ेगा कि I will search for minimum 2 databases. Minimum 2 are required, ideally 3 or more than 3. Okay. So how will you search databases and search other resources? Suppose all the thesis, all the data, all the articles are not given in the databases. So for that you have to search in libraries. Then methods, data collection and the analysis. This is the most strict part of this Cochrane reviews. How to select the studies, how will you extract your data, how will you manage your data, how will you assess the risk of bias, whether it is by ROB1 or ROB2, there are tools. So earlier it was used by ROB1, now ROB2 is commonly used. Now measure of the treatment of effect, how will you do it, whether you are performing the ITT, intention to treat, or as per protocol, whether your data will be in the dichotomous form or it is a continuous form. So this is related to the measure of treatment effect. Then unit of analysis issue, means whether a single person, single subject is the unit of analysis or cluster RCTs. In cluster RCTs, a group is considered. Then in this case, your unit of analysis is a cluster, is a group of patients. Then how will you deal with the missing data? Suppose you find a paper in the PubMed, but all data is not given in that article. Then you have to contact the authors personally, write email to them and ask them, please provide more data. We want more tables. Okay. Then assessment of the heterogeneity. You suppose there are 4 papers, 5 papers which you included, then you have to perform the heterogeneity among these included papers. If it is less than 20%, low heterogeneity. If it is between 2 to 50, moderate heterogeneity. If it is between 50 to 70%, high. And more than 90%, very high heterogeneity. In this case, you cannot perform meta-analysis. Then assessment of the reporting bias. What is reporting bias? Publication bias. To check this reporting bias or publication bias, we have to make a funnel plot. So if funnel plot is inverted and symmetric, means there is no reporting bias, there is no publication bias, otherwise there is publication bias. Then data synthesis. Data synthesis, you can use RevMan. Then subgroup analysis and investigation of the heterogeneity. What is subgroup analysis? Suppose आप मार्केट गए, वहाँ पे रेड एप्पल थे, ग्रीन एप्पल थे, तो आप चेक करेंगे कि रेड एप्पल और ग्रीन एप्पल, हमने एप्पल्स अलग ले लिए, ऑरेंजेस अलग ले लिए. एप्पल के अंदर भी फिर डिफरेंस तो नहीं था, क्या ग्रीन एप्पल ज़्यादा मीठे थे, रेड एप्पल ज़्यादा मीठे थे, या दोनों कॉमन थे. तो अगर हम सब ग्रुप एनालिसिस करेंगे, अलग रिजल्ट मिलता है, मीन्स आवर डेटा इज वीक. और अगर सबको सेम आ रहा है, यानी कि मीन्स सारे एप्पल्स ही मीठे होते हैं. देन सेंसिटिविटी एनालिसिस. सेंसिटिविटी एनालिसिस, अगर एक स्टडी बाकी स्टडी से बड़ा डिफर कर रहा है, there is so much heterogeneity in one paper, then we remove this particular one paper and do the data synthesis again on the remaining paper. If again our final estimate is the same, then our evidence is good, otherwise it is weak. Then summary of the findings. At the last of the systematic reviews, we have to provide the summary of findings for each outcome in a simple language. Which drug is effective, in how much patient they were tested, how many RCTs we included to generate this effect. So all this information is provided in the summary of finding. So this slide differs a Cochrane review from the non-Cochrane review. So my suggestion, if you are writing a Cochrane review or a non-Cochrane review, you should follow the guidelines of a Cochrane review so that you can maintain the standard of your non-Cochrane review much higher. Now methods, again very common. Acknowledgement, references, appendices. In appendices, you have to give detail of everything, that how will you search in the PubMed, how will you search in the Embase, how will you search in the Scopus, and what were your mesh, what were your keywords, how many articles we were able to got. Suppose we just typing EXP explode smoking cessation in PubMed, there were around 32,665 articles. So you have to keep the data of each and every step. Now methods, in the last you have to, not in the last, in the protocol itself you have to mention what role each author will play. Okay. Now declaration of interest and the sources of support. Sources of support may be internal sources, external sources. Now key platform for protocol registration. Prospero is very common, other is Cochrane, and other is Open Science Framework, OSF. So in the last of this session, there is a separate lecture by Dr. Kirti about how to register your title in Prospero. So these are the steps of conducting SRMA. So it starts with getting a idea, getting a plan, a research question, research hypothesis, then develop your research hypothesis in Pico, Pico, patients, intervention, control and outcome. It will help you in preliminary research in PubMed, Scholar, Embase. Then you have to decide what to include, what to exclude according to your Pico. Next is search strategy. And after your search, you have to arrange your references by the reference manager. So here we will demonstrate to you how to use Zotero for organize your references. Next is the protocol writing and register your title. So this protocol writing is here. Next is the screening of the article. Suppose you got 1,000 papers. So you have to finalize few. So first step is to screen on the basis of title, on the basis of abstract. Suppose your aim is to include RCTs. So just looking at a title, if there is a title, it is mentioned, it is an animal study, you can remove it easily. Just looking at the title. If there is word mentioned, it is observational studies, you can include it just by looking at the title. Then suppose by this title and abstract screening, you reduced your RCTs from thousands to 100. Now you have to read all these 100 articles in full. This is called full text screening. The screening part will be covered by Dr. Annie. Okay, will be covered by Dr. Annie in the later lecture. Now after that, we need data extraction in the Covidence, but Covidence is paid, so we will not be able to demonstrate how to use this Covidence. But if the data is small, we can directly put this data into the RevMan. The next step is the quality assessment by ROB2, risk of bias by tool ROB2. Suppose we included 4 articles. Finally, we got only 4 articles. We have to analyze the biases. How many kinds of biases are there in our included RCTs? So we have to grading them. The next part is the statistical analysis. We will extract the data from our final 4 RCTs and we will put in the RevMan. RevMan will help us to generate the forest plot. Next step is grade for evidence certainty. Again, ROB2 is not enough to tell us what is the evidence, what is the certainty of our evidence. So to this, we again need GradePro approach by the software GradePro GDT. And in the last, manuscript writing. For manuscript writing, there are certain headlines. So these headline writing guidelines are given in the Prisma. And Prisma also help us how to make a flow chart. Now challenges in SRMA. All the databases are not freely available. We all can search in PubMed, but not in Scopus, not in Cochrane, because in our institute we don't have free access to these databases. So all databases are not free. Again, in the case of tools, all tools are not free. Just like Covidence, it's not very cheap. And again, expertise and the training. One training is not enough. So you have to continuously improve yourself. You have to continuously gain the knowledge how to perform these systematic reviews. So it is really hard work. It needs so many time. But what is the purpose? How it's help? If you are doing a lot of work, you are making the work of a physician, of a clinician very easy. Now you are giving a clinician only one document, means guideline, with the help of your systematic review and meta-analysis. Government also provide grants, ICMR provide grant for systematic reviews, and the amount varies from 5 lakh to 6 lakh for purchase tools, to access the databases, and also for training purposes. But the eligibility for these grants, there is eligibility, you have at least 2 systematic reviews as first author or corresponding author. So this is the link if you want to know further about these grants. By the end of this CME, if you understand SRMA immediately, क्या लगते हैं, समझ में आ जाएगा सबको? Congratulations. And if you don't, वेलकम टू द क्लब। ओके, अब शाम को आप डिसाइड करेंगे कि आप लेफ्ट वाले ग्रुप में हैं या राइट वाले ग्रुप में हैं। ओके, तो दैट्स ऑल फॉर दिस लेक्चर। Any queries, any question? Or we can continue with question answer session in the last of the.
Thank you, sir. Thank you, sir, for the comprehensive and insightful session. Now we have gained a clear understanding of what a systematic review and meta-analysis truly means. Your explanation has laid a strong foundation for these sessions ahead.
Moving further, I would like to invite Dr. Fatima Rani to guide us how to effectively frame a focused research question.
Good morning, respected and dear all. The topic for this session is framing research question using Pico framework. Now before I start this session, I would like to ask you all a question. Imagine if someone asks you to order something, what will be your reaction? Naturally, there will be many questions in your mind. First being, what do I need to order? Now if they say order clothes, so what will your reaction be? Something like this. So many questions in your mind. What do I need to order? For which occasion? For what size? What color? So what you are essentially trying to do, you are asking so many questions in order to get the right answer, so that there is clarity in your mind and you can make an impressive choice. Research also works in the same way. In order to get appropriate and structured research, you need to have an appropriate question so that you can get impressive results. Now coming to the topic, a research question is a clear, focused and answerable question which addresses any specific gap in the knowledge. It is usually framed at the beginning of the study. So this topic will cover these 3 steps in our today's SRMA workflow. So as mentioned, the research question is foundation of any study. So it will determine the study methodology, it will determine the study design, data collection, analysis of outcomes. So let us understand this with an example. Imagine, like I want to study the effect of use of mobile phone on sleep. So I frame a question. Does the use of mobile phone affect sleep? Now how many of you think this question is a appropriate researchable question? Is it or is it not? Yes or no? No. Why? Because it is too vague. What does use of mobile phone mean? Does it mean talking on the phone? या फ़ोन पे मैसेजेस करते रहना, सोशल मीडिया यूज़ करना? तो वेग टॉपिक हो गया. अब हमने उसको थोड़ा क्लैरिफाई किया, नया क्वेश्चन फ्रेम किया, rather reframe किया. Does the use of social media on mobile phone affect sleep? Is it better? Yes, maybe. But is it appropriate? Yes or no? Still no. Why? It's still too broad. It does not include use of mobile phone or social media by whom? Children, adolescents, adults or elderly. So I rephrase this again. I'll say, does the use of social media on mobile phone affect sleep in adults? Now I have framed this question, but it is still not appropriate. Why? It lacks a clearly defined comparison. How? use of social media in adults compared to adults who do not use social media, and the outcome is also not specified. What does sleep exactly mean? Does it mean sleep quality? Does it mean sleep duration? If it means sleep quality, what index is used to measure it? So if we do not use all these points to frame the right question, our topic won't be researchable, and ultimately it will lead to rejection by the either ethics committee, और कैसे भी करके अगर हमने रिसर्च कंप्लीट कर भी ली तो पब्लिकेशन में भी दिक्कत होगी. Then so there is a criteria for framing a good research question. Does anyone know that criteria? No guesses are wrong. कोई बता सकता है criteria for a good research question? So the criteria is FINER, FINER. It is an acronym. Now, does anyone know the full form of this acronym? Feasible. F is for feasible. So feasible मतलब study कितनी realistically possible है. Do we have appropriate resources? Can we recruit right amount of patients? Can we do it in right amount of time? So suppose I want to do a study of effect of a drug on a rare genetic condition, लेकिन मैं patients कहाँ पे ढूंढ रही हूँ? मैं PHC या छोटे से clinic में ढूंढ रही हूँ. Will I be able to recruit right amount of patients? Do you think so? No. So the study won't be feasible. Then next comes, I say interesting. Interesting not only to you as a researcher, but to the community, the scientific community where your results will be displayed. Then comes novel. Novel मतलब कुछ नया ऐड करना है, या तो रिसर्च गैप को कुछ एड्रेस करना है, या कुछ नया पुरानी रिसर्च में हम ऐड कर रहे हैं. Then ethical. Ethical per se is involved with the concerned with the safety of human participants or animals involved in the study. So in SRMA, since we are doing review, so it is not that relevant as the ethics part is already covered by the investigators who did the study. Then comes relevance. Suppose अभी कोई COVID-19 पे स्टडी करता है, तो COVID-19 पे स्टडी इज इट as relevant as it was in 2019, 20 or early 20s? It is not that relevant. तो relevance भी एक criteria है. Now coming to frameworks, क्या क्या commonly use होते हैं. So एक framework तो बता ही दिया गया है. It is in my title, Pico. I hope everyone is familiar with the full form: population, intervention, comparison and outcome. So it is used for most commonly for framing research question of a interventional study. Then PEO is for population, exposure and outcome for observational study. The next, SPIDER, sample, phenomena of interest, design, evaluation and research type, is for qualitative or mixed method study. Then comes PIRD, population, index test, standard test, reference or standard test. Then diagnosis is used for diagnostic studies. So our main focus today here is on Pico. There are certain variants of Pico. They are not essentially used for like framing the research question, but if they are defined beforehand, they will certainly help in making our research easier. So they are Pico S, that is includes study design, Pico T includes the time duration, and Pico C includes the context. Context matlab whether the study is set in done in urban nations or developing nations or developed nations, urban setting or rural setting. So our main topic of interest here is Pico, P-I-C-O. I hope now everyone remembers the full form of this: population, intervention, comparison and outcome. So what is population here? You need to define the age, the disease interventional studies. It resembles the interventional drug, but therapeutic effect इसका कुछ नहीं होता है, ठीक है. So comparison आम में standard treatment भी ले सकते हैं, कोई दूसरी treatment भी ले सकते हैं, या no treatment at all. जैसे for example people who practice yoga versus people who do not practice yoga, तो ये भी हो सकता है, no treatment at all. Then outcome are very important to be defined beforehand. Why? दूसरों के लिए या अपने लिए. As a researcher हमारी research को हमें focused रखना है. Whenever you will conduct a study, you will get lots and lots of outcomes. तो हमें deviate नहीं होना है अपने main point से. अगर outcome पहले से define है, so we know we have to look for this thing only. तो हम उसको define करके चलते हैं पहले से. So it should be clinically measurable. जैसे BP, blood sugar level, HbA1c, ये सब easily measurable है और clinically meaningful outcomes है. अब primary versus secondary outcomes भी होता है. Primary is the main result we are interested in. Secondary which we hope to find along the course of the study. Now ये तो हो गया हमारा main PICO का क्या definition है ये हर component का. Now how it is acting as backbone of SRMA. तो ये सिर्फ research question frame करने के काम नहीं आता है. PICO will serve in next subsequent lectures, you will see it will serve as like backbone for foundation for search strategy in data extraction, framing inclusion and exclusion criteria, and hence synthesis of results and meta-analysis. So Cochrane handbook ने 3 लेवल पे PICO को डिफाइन किया है. दैट इज फर्स्ट इज रिव्यू PICO. रिव्यू PICO मतलब जो हमारा मेटा एनालिसिस या SRMA जो हमें करना होगा उसका क्वेश्चन जो है वो रिव्यू PICO से आएगा, विच इज़ प्लान एट द प्रोटोकॉल स्टेज. देन PICO फॉर ईच सिंथेसिस. अब जब आप सब्सिक्वेंट लेक्चर्स में देखेंगे तो जब डेटा सिंथेसिस मतलब कि रिजल्ट्स जब हम मेटा एनालिसिस के सिंथेसाइज कर रहे होते हैं तो कुछ ऐप्स सॉफ्टवेयर्स हैं उसमें आउटकम हमें अलग अलग डालना पड़ता है. क्यों? अलग अलग फॉरेस्ट प्लॉट का अलग अलग PICO होता है, आउटकम अलग अलग होगा. तो अगर आपने जो PDF शेयर हुए हैं उसमें मेटा एनालिसिस में देखा होगा उसमें कई सारे फॉरेस्ट प्लॉट्स हैं, तो हर आउटकम का अपना एक अलग फॉरेस्ट प्लॉट बनेगा. देन PICO ऑफ इंक्लूडेड स्टडीज. व्हाट डज दिस मीन? You need not worry about this because the PICO of included studies has already been defined by the investigators who performed those studies. तो ये हो गया and it can vary slightly between the studies. Now today's focus is our SRMA PICO. So I would request you all to kindly open the PDF SRMA semaglutide which has been shared. The title is Efficacy and Safety of Semaglutide for Weight Loss in Obesity Without Diabetes, a Systematic Review and Meta-Analysis. So let us try to define the PICO in this meta-analysis. So if you go to the methodology section, उसमें पार्टिसिपेंट्स आपको पॉपुलेशन डिफाइन की गई है. तो कैन एनीवन टेल मी दैट बाय लुकिंग एट द मेथोडोलॉजी सेक्शन? सो सबसे पहले एडल्ट्स हैं मोर देन 18 ईयर्स. देन
Ma'am, the population we are considering is adult patient that is greater than 18 years age, and secondly that should be obese. the criteria given is that the BMI should be either greater than 30 or it should be BMI greater than 27 with one or more comorbidities.
Yes, absolutely correct. So adults with obesity, which is defined by BMI criteria. Then they have also mentioned that patients should be without diabetes mellitus. Now why do I need to define? सिर्फ अकेले ये क्यों नहीं बोल दिया कि obese patients को लेंगे? They defined adults, age group. Then they defined it according to the BMI criteria, ठीक है, कट ऑफ्स के अकॉर्डिंग. और एक्सक्लूजन भी इम्पॉर्टेंट है यहाँ पे, क्योंकि कंफाउंडिंग क्रिएट कर सकता है. जितना अच्छे से डिफाइन करेंगे उतना हमारा सर्च रिजल्ट नैरो होता जाएगा, हमारे लिए ईजियर होता जाएगा. देन कम्स इंटरवेंशन. नाउ kindly go through the methodology section itself. The intervention is mentioned. Even in the title it is mentioned. So would anyone like to answer? Dr. Himanshi?
Once weekly, subcutaneous.
Subcutaneous semaglutide. Please sit down. So they have mentioned subcutaneous semaglutide. They have not mentioned any dosing regimen or duration. But if you have gone through all the 4 articles which were shared beforehand 2 days before, तो उसमें हम देखते हैं कि चारों स्टडीज़ में डोज एस्केलेटेड रेजिमेंट चला है. देन इंटरवेंशन ग्रुप में चारों स्टडीज़ में कुछ लाइफस्टाइल इंटरवेंशन प्रोवाइड किया गया है. तो दे कुड हैव इंक्लूडेड दिस एज वेल. They could have included this as well in order to narrow down the topic. Now why do I say that intervention needs to be defined? To avoid oversimplification. Oversimplification matlab intervention is not just the name of the drug alone. Route, frequency, dose needs to be specified. Kyun? Because it will affect the eligibility criteria of the study, heterogeneity. Now I would request you to kindly refer to the article, SRMA article, table 1 of the article. Please do. वहाँ पे चारों स्टडीज़ जो हैं उसके बारे में इंटरवेंशन कॉलम में जाना है. So intervention column पहुँच गए. फर्स्ट स्टडी इज ओनील, राइट? सबने कैच कर लिया उसको. ओनील है. ओनील में इंटरवेंशन में देखेंगे तो सबक्यूटेनियस सेमाग्लूटाइड दी गई है वंस डेली. ओके. रेस्ट ऑफ द स्टडीज में सबक्यूटेनियस सेमाग्लूटाइड दी गई है वंस वीकली. Okay, we will continue later on.
Good morning, respected and dear all. Honorable Dean, Faculty of Medical Sciences, respected Head of the Department, Professor R.K. Dixit Sir, esteemed faculty members, speakers and dear delegates. A very warm and gracious welcome to you all. On behalf of organizing committee, I extend my heartfelt greetings to this distinguished gathering assembled for the National CME Program on Systematic Review and Meta-Analysis. With profound respect, I acknowledge the gracious presence of our esteemed Dean, Faculty of Medical Sciences, Professor Virendra Atam Sir, whose visionary leadership continues to strengthen the foundation of excellence in our institution. Sir, your presence today adds immense value and dignity to this academic gathering. Thank you, sir, for your guidance and blessings. To invoke divine blessings and mark the auspicious beginning of this academic event, I now request respected Dean Sir, HOD Sir and faculty members to kindly come forward for the ceremonial lighting of the lamp.
तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता.
Thank you, sir, for illuminating this occasion with wisdom and grace. Now, I would like to invite our respected Dean, Faculty of Medical Sciences, to share his valuable insights. Sir, please guide us through your valuable words.
Good morning. Good morning. Hello, Department, Dr. Dikshit, a very eminent personality of our college, faculty of Department of Pharmacology, residents and students. I'm really delighted to be a part of this CME. I'm a clinician and Department of Pharmacology is very important for me because as a clinician, I have got a gun, but the bullets are from the Department of Pharmacology. Because without bullet, I can't do anything. So all the medicines and evidence-based medicines which we have taught, which they have taught us to us, I am applying on a patient. So this is the way how we work. Because it is a time of evidence-based medicines. It's not an individual experience that I'm doing this and my patient is done this and it's very good drug. So it's an evidence-based medicine. And when there is evidence-based medicine, then we have to follow few protocols. Such CMEs on meta-analysis and systemic reviews are very, very important because they reduce the bias, they give us a robust, critical appraisal of our literature to arrive to a conclusion. Because when we treat a patient, we have to make our protocols, we have to make our SOPs, these are based on this. So such methodologies are very important for us as a researchers, as a clinicians, as a student also. We should learn all these things. And I'm very happy that this department is going to have such very important systemic review and meta-analysis CMEs, which is on hybrid mode. I congratulate Hello Department, the faculty members and the residents for this wonderful event, inviting me for this. Thank you very much.
Thank you, sir, for your valuable words. Now, I would like to request our HOD, sir, to felicitate our Dean Academics. Thank you, sir.
Good morning, all. Good morning, those who are present and those who are connected through the internet. So, welcome you all, and this is a prestigious moment for the department, and we have actually one association in the name of Association of Community Pharmacotherapeutics. So actually what we teach in our lecture hall and what we teach in day-to-day life, that usually doesn't get transferred to the community. So for that we have actually framed an association, and all the members of the faculty members, they are members and officiating this association. And this association, under this association, this is the first CME. And that CME is to create the awareness that not by the personal experience, not by one particular advice, you have to go. We have to go with the crisp evidences. And the evidences are generated by the science. And the science works by the systematic one. And that's how they have designed this systematic review and meta-analysis. And this is the first of its own kind, and it is a beginning, and there will be many more. I am sure that you will be not getting the much as per the expectations, because you expected that one day I will start doing meta-analysis. It is not. It is not. The first day, if you know the difference only between the normal review, that is narrative review, systematic review, and the meta-analysis, that is more than sufficient. More than sufficient. If you can remember this and you know the methodologies, you know the steps, that is more than sufficient. Because once you utilize those steps, naturally then you will be, go into the deeper and deeper, and then you will be able to do the meta-analysis and the systematic review. So I just, to reduce the confusion, I'll give an example. If you are coming from outside the Lucknow, you ask somebody, and this example has been quoted by somebody else, and I am respecting him because he actually taught me that this is the difference. And you ask that I want to have यहाँ का क्या फेमस है? लखनऊ का kebab. I want to have kebab. Now which kebab I should buy? Now suppose you ask from me, because I am vegetarian, so I will give any name and just say बहुत अच्छा है, बहुत अच्छा, because and I don't have any evidence, nothing, but because I have heard from somebody and कि जो बगल वाली दुकान है उसका बहुत अच्छा, so I will give just, and 3-4 other people they will give, and then he will make an impression. Now this particular branch or this particular shop is the best for kebab. Unfortunately, when he reaches to that shop, he gets the worst kebab. Now this is the narrative review. I created a narrative, he added, and ultimately he landed up into the worst one. The second is, we have to think that I will ask from these persons. That is in a system. That is, I will ask from those who are non-vegetarian, those who are having this, those who are having experience in this field, those who are having good reputation, they are not false selling, they are not, they will tell the truth whether it is good or bad. Now this will be a systematic review. But if I analyze through the data, I collect the data of all the shops and the shops which are similar, from the tunde kebab and other, and then I think, then I get some conclusion. Now that is the meta-analysis. So meta-analysis and systematic analysis, they are much more advanced than the narrative analysis. So narrative analysis is just by narration. One paper you read, this is the wonderful drug, and you can get into the conclusion. Systematic review and meta-analysis gets into the conclusion by analysis. And that's how this is the difference. And there are complicated process. And mind you, I am again re-emphasizing, you are not going to start meta-analysis after this end of the CME. 100%. If you start doing meta-analysis today onward, means you are superhuman. You will not. You will have to attend multiple conferences, multiple CMEs, multiple, interactions with the experts. Then only you will be able to do the meta-analysis and systematic review. But this is the beginning, and one step forward means you are in the right track. And ultimately, my thank to Honorable Dean Sir, who is very cooperative every time. And when he entered in the department, he blessed बस by saying लगे रहो, इस तरह से लगे रहो, आगे जर्नी बहुत अच्छी है. So I am thankful, sir, for your gracious presence, and I am thankful to all the faculty members of our department, all the residents and the participants who are coming from different city, different institutes, and they are connected to the net. So with these words, I am really indebted to the event which is being organized by under the leadership of Dr. Rahul. He took the lead, and ultimately the whole department is cooperating for this particular success. And once again, thanks, sir. Your presence has added the value to this CME. So thank you once again. Thanks a lot. So just a token of affection and token of love and respect. So we will have added the value, and we are fortunate to have you, and we'll be having much more interaction with you.
So I'll say thank you very much. It's a wonderful program. Please enjoy this. This is a very good feast of knowledge. And this is the first step. You learn from there, and there are many, many other CMEs. I hope this department is going to do very well. Best wishes. Good luck. Thank you very much.
Thank you everyone. Let us begin with our academic session. I would like to call Dr. Fatima.
So thank you, Dr. Rashmi. Let us continue with the previous slide. So the intervention was subcutaneous semaglutide. I mentioned, as mentioned, that they could have added dose escalated regimen as well, and along with lifestyle advice. So why does intervention need to be defined? In order to avoid oversimplification, intervention just does not mean the name of the drug alone. Route, frequency, dose, everything needs to be specified in order to determine the eligibility criteria of the study, and then heterogeneity. So I requested you all to go through the table 1 of the meta-analysis. So in that, first study was O'Neill, who have given intervention once daily, subcutaneous semaglutide once daily. Then rest all the studies, they gave subcutaneous semaglutide once weekly. So अब can we compare once daily dosing with once weekly dosing? It is very tough to compare, right? तो ये क्यों इंक्लूड हुई? क्योंकि हम लोगों ने ये नहीं डिफाइन किया था कि वंस वीकली सेमाग्लूटाइड देना है. जस्ट ये बोला था मेटा एनालिसिस में, they mentioned that subcutaneous semaglutide without mentioning the dosing regimen. तो इससे क्या होता है, अगर वो और नहीं डिफाइन करते, जैसे ओनली सेमाग्लूटाइड मेंशन कर देते हैं, तो सबक्यूटेनियस के कोई भी रूट एक्सेप्टेबल होता. सो दिस विल लीड टू वाइड वेराइटी ऑफ रिजल्ट्स, मेकिंग स्टडीज डिफरेंट फ्रॉम ईच अदर. तो इसी को हेट्रोजेनिटी बोलते हैं, मतलब एक दूसरे से कितना डिफर कर रही हैं. थोड़ी हेट्रोजेनिटी हुई तो मेटा एनालिसिस पॉसिबल होगा, और ज़्यादा हुई तो पॉसिबल तो होगा बट रिजल्ट्स एक्सेप्टेबल नहीं होंगे, उतने रिलायबल नहीं होंगे, और मोर देन 90% तो मेटा एनालिसिस ही नहीं कंडक्ट कर सकते. देन अगर हेट्रोजेनिटी बढ़ रही है, सो द रिसर्चर्स आर फोर्स टू डू सब ग्रुप एनालिसिस. लो डोज को हाई डोज से कंपेयर करना पड़ेगा, वंस डेली डोजिंग को वंस वीकली डोजिंग से कंपेयर करना पड़ेगा. दिस ऑल वर्क नीड्स टू बी डन इन ऑर्डर टू मेक आवर रिजल्ट्स मोर reliable, more generalizable. Now coming to comparator, can anyone tell me what the comparator here is? Okay, very good, please sit down. So the comparator here mentioned is placebo. So they could have added one more thing, that similar lifestyle advice could be provided to the placebo group as well. Now they have mentioned exclusion of studies comparing semaglutide with other active anti-obesity drugs, right? Everyone is following till now, right? Then coming to outcome, please go through the methodology endpoint section. The outcome is mentioned. Can anyone tell me the outcome? Yes, right, absolutely correct. So the primary outcome is percentage change in body weight from baseline. Now the secondary outcome has also been mentioned as GI adverse event, discontinuation due to adverse event, and serious adverse events. So today in meta-analysis we will be mainly in subsequent lecture when we will synthesize the results, we will be focusing on one outcome only in order to achieve our forest plot. Now why outcomes have been defined here? They drive the effect measures and meta-analysis model. अब ये terms कुछ tough हो गया, तो effect measure and no need to worry, it will be explained in detail in the next lectures, but I'll give you just a normal idea, generalized idea. Effect measure बस हम जब synthesis कर रहे होते हैं result में, तो एक effect measure बस ये बताता है कि दो groups में कितना difference है, तो हमें कौन सा measure लेना है उस group के difference को define करने के लिए. तो suppose हमारे पास continuous variable, जैसे हमने primary outcome क्या है, percentage change in body weight from baseline, ठीक है, तो वो हो गया continuous variable. तो यहाँ पे हम effect measure क्या use कर सकते हैं, mean difference और standardized mean difference. अगर हम प्राइमरी आउटकम जीआई एडवर्स इवेंट ले रहे होते हैं तो एडवर्स इवेंट क्या तो प्रेजेंट है या नहीं है, तो ये किस टाइप के वेरिएबल हो गए, डाइकोटमस वेरिएबल है, तो उसका इफेक्ट मेजर हो गया OR RR। इतना आइडिया अभी आपको लेना ज़रूरी है। देन मेटा एनालिसिस मॉडल क्या है? जितनी हेट्रोजेनस स्टडीज़ आपके उस स्टडी में आ रही हैं मेटा एनालिसिस में सर्च के टाइम पे, तो उतना हमें मेटा एनालिसिस मॉडल को डिफ्रेंशिएट करना पड़ेगा। रैंडम इफेक्ट मॉडल इज़ फॉर हेट्रोजेनस स्टडीज़ एंड फिक्स मॉडल जहाँ पे स्टडीज़ उतनी हेट्रोजेनस नहीं होती हैं, सिमिलर होती हैं। देन ऑब्वियसली आउटकम विल डिफाइन द इंटरप्रिटेशन ऑफ रिजल्ट्स। अगर हम परसेंटेज बॉडी वेट सिर्फ देख रहे हैं तो एफिकेसी, और अगर हम सेफ्टी आउटकम्स देख रहे हैं तो सेफ्टी ऑफ द ड्रग। नाउ as I told you कि it is Pico is the backbone of SRMA, not only research question but it will also define inclusion and exclusion criteria. So अभी Pico के सारे terms define हो गए। inclusion exclusion criteria क्या हो सकता है Pico according? obese adults, right? तो adults obesity का criteria defined है BMI more than 30 और BMI more than 27 with at least one weight related comorbidity। और exclude क्या किया? patients without diabetes P में हमने define किया था, not us, they have defined, so they define with patient without diabetes, तो वो exclusion criteria में non obese individual भी हो गए। then intervention क्या है? अब आई थिंक सबको आइडिया है इंटरवेंशन इस मेटा एनालिसिस में क्या है। समवन से सबक्यूटेनियस सेमाग्लूटाइड, तो ड्रग्स अदर देन सबक्यूटेनियस सेमाग्लूटाइड विल बी स्टडीज जो उस ड्रग्स पे होंगी तो एक्सक्लूड हो जाएंगी। द कंपैरेटर वाज प्लेसिबो, तो स्टडीज जो कुछ और कंपैरेटर ले रही हैं वो एक्सक्लूड हो गई। देन आउटकम इज परसेंटेज वेट लॉस एंड सेफ्टी आउटकम्स, तो रिलेवेंट आउटकम्स अगर स्टडी में नहीं मिल रहे हैं वो एक्सक्लूड हो गई। देन आई डिफाइन वेरिएंट्स ऑफ पीको। डज एनीवन रिमेंबर दैट? कोई बता सकता है वेरिएंट्स ऑफ पीको? पीको टी टाइम, पीको सी इज कॉन्टेक्स्ट एंड पीको एस इज स्टडी डिजाइन। सो if you go through the methodology section, they have also defined inclusion criteria में कि S का component, that is study design, तो they are including only RCTs, that is randomized control trials, and excluding other study design. So ये हमारा inclusion exclusion criteria हो गया है। It will be you can, if you want you can take this picture because it will be used in further lectures as well, or note it down somewhere. So अब इट इज़ सेफ टू अज्यूम नाउ कि हम सबको अब पता चल गया ये एक बहुत ही पुअरली फ्रेम्ड क्वेश्चन है। क्यों? सेमाग्लूटाइड सिर्फ देयर इज नो रूट मेंशन, सबक्यूटेनियस सेमाग्लूटाइड नहीं मेंशन है, पॉपुलेशन इज नॉट मेंशन, कंपैरेटर इज नॉट मेंशन, इवन द आउटकम ओनली वन आउटकम इज मेंशन। तो अब इसको अगर हमें अच्छे से फ्रेम करना है, हम इस तरह से कुछ पहुंचेंगे। कैसे पहुंचे? बाय पुटिंग ऑल द कंपोनेंट्स ऑफ पीको टुगेदर। सो इन एडल्ट्स विद ओबेसिटी विदाउट डायबिटीज mellitus, that is P, the subcutaneous semaglutide I compared with placebo, that is C, lead to greater weight loss and acceptable safety outcomes, that is O. So this is a well defined research question. अब हमारा ये टॉपिक आज के इस सेशन का यहाँ तक लाके हमें ख़त्म एंड करता है। नाउ एज आई मेंशन पीको विल बी यूज्ड, तो नेक्स्ट सब्सिक्वेंट लेक्चर में इट विल एक्ट एज द फाउंडेशन ऑफ सर्च स्ट्रैटेजी। सो द टेक होम मैसेज विद दिस स्लाइड इज Pico transforms a vague idea into an answerable question. It will act as a backbone of SRMA, and if it is poorly defined, the results will be unclear. It will lead to weaker conclusions. So I hope by the end of this session we won't be making the same mistake as her. It is better to stress out and even cry a little while framing the Pico and research question, rather than crying at the end while doing the research. With this note, I thank you all.
Thank you, Dr. Fatima, for simplifying the art of asking the right question. We now understand that a well-structured Pico question is the backbone of high-quality systematic review. So by this, with the completion of these enriching topic, now we take a quick break for tea and snacks, and it has been arranged in new LT. And we'll then reassemble in 10 minutes as we resume our practical learning segment.
Good morning, everyone. Good morning, everyone. So आज CME तो है ही, साथ में कुछ और भी खास है. Any guesses? क्या है आज? So sir, आज हमारे गुरु जी का हैप्पी बर्थडे है. हैप्पी बर्थडे सर. Now I invite sir for the cake cutting.
So this birthday is, madam आजा. This birthday is not of HOD. This birthday is not of a person. This birthday is of the first CME. First CME organized under the aegis of Dr. Rahul. So, बैठो. So this is the real birthday, and this birthday is to be celebrated by all, and this is how we actually manage. And आज जो birthday हुआ है इस CME का, now this will remain endless. That is our prayer. Thank you very much. Bye bye. Long live Dixit sir. Long live Department of Pharmacology, and long live this community pharmacotherapy.
Welcome back everyone. Now we move to one of the most crucial component of systematic review and meta-analysis, the search strategy. In this session, we will learn how to systematically search database using appropriate keywords. And for this important session, I would like to call a young and dynamic head of the department, Professor R.K. Dixit sir. Sir. Yes, sir.
तो कहाँ गई वो निधि? हाँ. So लगाओ. Now I told you in the morning that everything is based upon data. Everything is based upon the search. Everything is based upon your common sense. If you take the data from the wrong place, naturally your study will be wrong. The interpretation will be wrong. Now, the most crucial part, the first crucial part is to make the question. Because if you have a wrong question, naturally you will can never get the right answer. if you have a wrong question, you will never get a right answer. The first is question. Now, what is your research question? What is your objective? What is your Pico? That is the first important. Second most important comes from where you will get the data, from where you will actually collect the evidences to get any conclusion. Now, if you are not good in selecting the studies, naturally the selection will lead, the wrong selection of the study will lead to the wrong interpretation. And wrong interpretation leads to the wrong clinical judgment. So ultimately everything will become wrong. Now that is how the second most crucial part becomes how you select the studies, how you go for the selecting the research from where you will take the data and for further study. So that is how the second is database research. Now database research, because we are living in a era which is era of big data. If you write big data, you will see what is the definition of big data. Now big data means innumerous data, and so many data that you are confused. Now out of these studies, which study you have to select? Now that is the topic, and how you are going to search different databases. Can anybody tell any database which you know? Any database? PubMed, and so there are many databases which actually they keep the data with them. They actually circulate them. They take the ownership of those data. They circulate them, and they maintain those data basically. And ultimately, to get into those databases is very tricky, because every study which you publish is not likely to get the place in the database, the real databases. So that databases which are actually real and which are actually authentic one, now they has to be taken. Now out of all, how the study will be selected, what will be the mesh word, what will be the word to be put so that your study gets selected. If you put the wrong word, wrong keyword, naturally the wrong study will be selected. So that is how, so Dr. Nidhi will be, elaborating all the things. So just by briefing the session, that the data search is the second most important step in doing any analysis or any research. So over to Dr. Nidhi.
Good morning, respected and dear all. Today I am going to discuss about database search strategy for SRMA. So let's see first how it is fitting in the SRMA workflow, which we will be seeing in all the presentation. Search strategy. It is like the backbone of the meta-analysis. Why? Because if we do not do the search properly, we may miss out on some important articles, and we can also consider some vague articles which can lead to bias. So search strategy could be considered as the backbone of any study. A perfect search strategy is very, very important. So what are the steps to the perfect search? सबसे पहले हमें एक Pico question formulate करना है. As we have already studied in detail in the previous lecture कि हमें Pico question कैसे formulate करना है. When we have formulated the Pico question, with that we will know the keywords. Like for example, हमने last lecture में semaglutide and obesity, semaglutide intervention था, और हमने देखा था कि how it is affecting in obese patient. तो we automatically got to know the keywords कि हमको क्या keywords डालने हैं जिससे हमें relevant articles मिल जाएं. तो we will formulate the Pico question, then identify the keywords, plan the search strategy, execute the search. How we would be executing the search, we will also have the demo for it. Then we will refine the results, review the literature and access the evidence. तो सबसे पहले कि database search, most of us know about PubMed, Google Scholar. But PubMed and Google Scholar is not the end of the world. There are many platforms जहाँ पे हम database searching कर सकते हैं. For example, Embase. Embase is rich in European literature and also has very good content about pharmacovigilance. If we are doing systemic review and we have not searched on Cochrane, then we are missing out on something. Then comes the clinicaltrials.gov. In this, we can see many clinical trials that are undergoing and are not published. And if we want to see the globally, where centraltrials.gov is US based. But अगर हमें globally देखना है, in European countries, in India, then we can see from WHO, ICTRP. Then there is one thing called medRxiv. medRxiv का बहुत ज़्यादा significance आया कोविड के टाइम में. क्यों? क्योंकि कोविड के टाइम में when the medRxiv became very significant during the COVID era. Why? It is because that time many studies were going on and all were not published. But with the unpublished data also we could read and it was not peer reviewed. So we have to be very careful that whatever is written in those papers should not be correct. We have to peer review it and use it. For historical papers from 1900, we can use Web of Science. So these are some of the database searching platforms we use. Now comes a very important concept, PubMed, PubMed Central and PubMed Medline. Anyone can tell me the difference between PubMed and PubMed Central?
PubMed Central is like a library which has the storage of all the articles, full articles, whereas PubMed is just a search engine to access the articles of PubMed Central.
Thank you. So basically, if we consider the same example, there is a library which has many books, and also in all the libraries there is a catalog where all the books present in the library are present. So the PubMed is that catalog from where we can see which books or articles are present. We can go to their abstract. But if we want to read the free full text, then we need to go to the PubMed Central. The third one comes Medline. Medline is the NLM Journal Citation Database. तो Medline में क्या हो रहा है? Medline में index journals हैं. So we can also conclude that everything present in Medline we can get from PubMed, but everything present on PubMed may or may not be indexed. So it will not be present in Medline. Some of it will be present, but not all. So now we have an idea about PubMed, PubMed Central and Medline. Now coming to the meta-analysis study we are going to discuss. So the title of the study is Efficacy and Safety of Semaglutide for Weight Loss in Obesity Without Diabetes. So with this, how can we frame the Pico question? We have already studied. So what would be the P? Anyone? P refers to patient or the participant or the problem or the population. So what are we considering? Who are the participant in this study? Adult patient who are obese but not diabetic. Now we will also learn about the Boolean operators just after it, that how are we going to put these three things together. Coming to the, here P refers to adult patient with obesity without diabetes. We all know the intervention was semaglutide. Then coming to the C, that is placebo, and in this paper it was also mentioned as GLP-1 agonist. Then coming to the O, that is the outcome. So here what it is? Efficacy and safety in weight loss. So now we will understand it with the help of Boolean operators. There are three types of Boolean operators. The first one is AND, second one is OR, and third one is NOT. So AND refers to, we will again take the example of semaglutide in obesity. Suppose हमने PubMed में डाला semaglutide and obesity. So what will come? All the articles which have semaglutide also and obesity also. So हमारी जो सर्च हुई वो क्या हो गई? वो स्पेसिफिक हो गई, क्योंकि हमें एग्जैक्टली जो आर्टिकल्स चाहिए semaglutide and obesity के they came. But if we put semaglutide or obesity, now the search became very vast. It will show the articles which is having just semaglutide, and it will also show the article which is having just obesity. Now this is not that specific. Coming to the third one, not. Not is used to exclude. For example, here we want obese patients who are adults, but we do not want them to be diabetic. So now what we have put, adult and obese, not diabetic. I hope now we know how we have formulated the P of this Pico. Then coming to the intervention, we want semaglutide. So I is semaglutide, C again placebo or GLP-1 receptor agonist. Then comes the O, outcome. We want to know the efficacy and safety in weight loss. So now we know how the Boolean operators are working. So now I will request you all to open PubMed in your laptop, so that we can do side by side the same search things. Please open PubMed so that we can search together.
This is the most crucial part. If you are not able to search the right article, you will never give the right conclusion. So go very slow, step by step, what she is telling, remember. And what are the Booleans operator? And, or, and not. They have importance. They have importance. Right? If you want more and more article in the particular topic, more and more, जितने ज़्यादा हो सके उतने ज़्यादा, so क्या लगाओगे? And, or, ये या ये, then ये and ये, it will be reduced. ये और ये नहीं. So all these three, they have very important, connotation. And they have, and if you use the wrong one, like R की जगह अगर आपने and लगा दिया, now you will get the wrong article. If you have put the R in the place of not, you will get the wrong article. So if you have, laptop, so start with the exercise by yourself.
So I hope now we all have opened the home page of PubMed, right? Can we continue? Yes. So first of all, we can see this place where I have highlighted with this box, the login. We have to first log in. Now, when we press on login, we get all these things. The best one, as per me, is Orchid. Why Orchid? What exactly is Orchid? Anyone? Orchid refers to, anyone? Orchid refers to Open Researcher and Contributor ID. Now this is a 16-digit code, unique ID. For example, my name is Dr. Nidhi. I am working in Department of Pharmacology in KGMC. Suppose there is another Dr. Nidhi with the same name in the same department. Now we both write a paper. So how will you differentiate which Dr. Nidhi has written that paper? So we need a unique ID. So Orchid helps us in doing that. And also it is unpaid, it is free. So
Orchid is nothing but an Aadhaar card in a medical science. Just remember, the Aadhaar card can't be same of two person. Like this, the Orchid ID can't be same of two person. Maybe the name may be same, the last name may be same, the place may be same, but the Aadhaar card will not be same. Like here, the Orchid number will not be same.
So now, when we will press on that Orchid, then such page will open. I hope all of you also have the Orchid IDs registered. Otherwise, you can log in with the Google ID also.
If you don't have Arcade ID, please you can sign it with the Google ID, and it is recommended that please you prepare your Arcade ID as soon as possible, because in medical science, if you have to remain in medical science, you have to have one ID, unique ID. Like if you want to remain in India, naturally we want Aadhaar card. So like that, if we are in medical science, naturally we have to be have an Arcade ID. Okay. If you don't have, please apply, and it will be generated very quickly. In evening you can do. Okay.
Now we have logged in our PubMed account. So let's start the search process. So can we see this advanced option here? Please respond with yes or no. Yes, we can see the advanced option. Here we can use that Boolean operators which we studied, and, or not. So now we will click on this advanced. So something like this will open. Has it opened? So what we want all fields. Now we have to enter the search term. So what was our study about? Semaglutide in obese patient. So first of all, the search term I will put is semaglutide. Then I want to see its work in obese patient. So what we will use? And Boolean operator or Boolean operator. Which one we will be using? And. Because we want papers where semaglutide and obesity both are mentioned. So we will put the search term semaglutide, then use the Boolean operator and, then put obesity, and then we will start the search. Right? Everybody is able to search it? Shall we continue? So a page like this will open. Now, since the study since the meta-analysis study we are referring in all the presentation happened in 2021. So we have to use this filter that it should include the studies till 2021, right? So we can go to the side option here and go that we want studies up to 2021. Has everyone done that? Has everyone done that? Here we will put the year, the last limit will be 2021, since that study happened in 2021. Okay, after doing that we will see that there are 175 results. Everybody can see 175 results, right? Please respond with yes or no so that we can have an interactive session. Yes, we can see 175 results. Now for working on it, we want that we should get a collection, that every time if we are referring to some papers in this, we don't need to go to PubMed again, then do the same search. We want that all these 175 results, we make a collection. So now what will happen, you can see this option, send to, all can see. So when we will click on it, something like this will appear. Clipboard, my bibliography, collection and citation manager. All can see it. So what we want to make a collection. So we will click on collections, right? Everybody had clicked on collections. So now a window has popped up something like this, right? Here in the selection, two options would be showing, that all results in first page or all results. So we want all the 175 results, so we want the all results option. So click on all results. Has everybody done that? Then we want to create a new collection. I have clicked on create a new collection. Then the name your collection. So since we are studying on semaglutide and obesity, we will just name it as semaglutide and obesity, right? So just put a name to your collection and then press on add. When you are done, please respond with yes. Yes. So we have now created a collection. But now what we want,
onward, you will say yes, then she will start. So when you finish, just say yes. Just say, wonderful. Now you can.
Okay, now we have a collection, right? Now we want to see where is that collection. So again we will go to the previous page, and now where we have logged in, when we will click there, then there would be the option of dashboard, because all the collections we save we can see in our dashboard. So click on that and then click on dashboard. When you are done, please reply with yes. Yes. Okay. Now something like this had appeared. So we can see in our collections, we have got this file, semaglutide and obesity with 175 items from PubMed, right? Now we have this.
Everybody got this?
Yes. So now we can see that we have 175 results. We have saved it in the collection. But now after the search strategy, we need to use the same in our citation manager and other apps. For that we want bib file. Okay. So now we will want to convert it into a bib file. So let's see how are we going to convert in bib file. So again we will go to the previous page and we will again click on send to, but this time we will not click on collections, but we will click on citation manager. So please click on citation manager. Okay. Yes. Now something like this is popped up, right? So now again all results and create file. Has everybody done this? Yes. So now this will be saved in our downloads. For example, now I can see the same file in my downloads. Everybody can see this bib file, right? Now what we have to do with the bib file would be discussed by the next speaker, who will be discussing about the citation manager. So now we know how are we going to do the advanced search in PubMed, how are we going to make the collection, how are we going to make the bib file in PubMed. So now
anybody can interrupt anytime. Okay? If you are not getting the page which she is telling, if you are not getting the word which she is telling, please interrupt. Don't hesitate in clarifying the things. Okay? So if you are not having anything which is being told here in your laptop, so please interrupt, because this is a very crucial. If you are done with this exercise, means you are 10 steps forward in the direction of meta-analysis and systematic review.
Okay. So are we clear about search strategy in PubMed? If anyone is having some query, we can ask. So bib file is so for citation manager, for example, we want to use this collection in Zotero for the citation as well as to remove the duplicate files. So now when we have saved it in our download section, we can directly go to Zotero and import it from our downloads, and we will have all the 175 files saved in our Zotero. So that is why we convert it into bib file, so that we can use it later in other apps. Yes. Sir, again we have went to this send to option. Now when we click on this 4 appeared. Now from citation, earlier we were clicking on collection to make a collection, but now we will click on citation manager. So when we will click on citation manager, this page will appear, right? So after that we will click on all results, because we want all the 175 results, and create file. As soon as we click on create file, the file will be downloaded in our PC. So now coming to another very important platform, Google Scholar. Okay, so first open Google Scholar in your laptops, then we will continue with Google Scholar. When you are done, please respond with yes. Yes, we have opened Google Scholar. So first of all, let's have a brief intro about what Google Scholar search is about. First and foremost thing, it is not case sensitive. Like if we type semaglutide in capital or in sentence case or in small letter, this will not be affecting our search. So it is not case sensitive. Then if we are looking for some specific phrase, for example, here we want the papers in which weight reduction should be there. So in that case, we can put the phrase in quotation marks. Then to exclude, we can use minus sign before the term. To include, we can use plus sign before the term, right? And then there comes two things, in title and author. What do we mean by in title? Anyone? In title means whatever I am searching, I want that term to be in the title of the articles. For example, I am searching obesity. So if I will put in title, the command like this, then we will get all the articles with obesity in their title. Same applies to the author. Suppose we want to see the work of some specific author. So if we put author and put the name, we will get all the articles related to that author on Google Scholar. So this is brief about, but now we will see how we are going to search on it, right? So everybody is ready? So when we open Google Scholar, inside we can see this 3 lines, right? Click on it. Done? So can you see something like this? Yes. So here is an option of advanced search. Please click on advanced search. Okay? Yes? Okay. When we click on advanced search, something like this pops up, right? Okay. So we will have to fill it according to what we want. Suppose again we are working on what? Semaglutide and obesity. So now with all of the words, which words we must want in our article? So it is semaglutide in obese. So please fill with all of the words semaglutide in obese. When you are done, say yes, then we will move to the second one. Okay? Then with the exact phrase. So our outcome was that we want to see how it is working on weight reduction. So the exact phrase what we want is weight reduction. So please fill weight reduction. Okay? Now coming to the third one with at least one of the word, right? So what word we exactly want? At least one word if we want. We are studying on semaglutide, so obviously we want semaglutide. So we will fill semaglutide. Okay? Then without the word, there is no certain specification that we don't want this word. Then comes where my word occur. Now we have two options. Anywhere in the article or in the title of the article. So are we specific that we want this in the title or we want this in the paper because we want to study about it, right? So we want it anywhere in the paper. So please click on anywhere in the article. Okay? Now coming to written articles dated between. So as I mentioned that this study happened in which year? 2021, right? So we know that we want papers up to 2021, okay? But then the question arises, what should be from when, right? Everybody had reached to this? Okay. So semaglutide was introduced in 2016. So we want the clinical trials from that time to this study happened, that is 2016 to 2021. So please fill 2016 to 2021. Okay? Okay. So now what we will do? We will search and we will get certain results. Okay?
Many of you are confused that why she is emphasizing 16 to 21. Why? 16 तो समझ में आ रहा है कि the drug was being launched or the first trial was then done. Why 21? Huh? Why not 26? Why not 25? This is a recreation of the thing, that how the paper authors, they actually worked to get that work published. So that is how, because the paper was published in 21, so we will go just like that, those real authors they went. Okay? And that's how we are restricting our study, our search to 21 only, 21st only. Okay? So that is the clarification, because you might be wondering why not 25. So this is just a recreation of the event. Again, how they search, how they might have searched, how they might have reached to the conclusion. So that is how she is teaching. Okay.
So okay, now we have put all the inputs. Okay, then search. Are we seeing the result? Yes. Yes. But now, जैसे हमने PubMed में bib file बनाई थी, the same way we want bibtext file in Google Scholar also, so that we can use it in Zotero or other citation manager, right? So now we will see how we can put the command so that we get the bibtext files also with the result. So again, we will see the three options, like here there was 3 lines. When we clicked on it, we saw advanced search, and below it was settings, right? Now we will click on settings. Everybody has clicked on settings? Yes. So now we can see something like this. Bibliography manager, don't show any citation import links, show links to import citation into. Can we see this? Yes. So now we have selected that now we want bibtext file. Okay. So when we do this and save, now something like this appears, right? Yes. So now with every article, we have an option, import into bibtext. Okay. Everybody is following? Yes. So now there, यहाँ पे Google Scholar की एक बहुत बड़ी shortcoming है. When we were using PubMed, so what we did, we saved all the 175 files together in a bib file, right? But here you don't get the option to select all. You have to do one by one. Like first you have to click on this, then this file would be imported into bibtext. If you click on this, then this file would be, we cannot do it together. Okay? So now what we will do, we will save the articles we want together in our library. Okay? So go to this point and click on save. 2, 3, 4 articles for example. Okay? Click on it. Here, save. Can we see the save option? Save. Then something like this would be appearing, save to my library, right? So now we will put one name, suppose meta-analysis. Please put a name, meta-analysis. Done? You can take your time, I'll wait. When you are done, then please reply with a yes. Yes? So now we have saved it in a folder. We have made a folder named as meta-analysis. Again, go back, again save another paper in the same meta-analysis. Please do it again. Yes. Again we will go, now we will save another paper. Again save in the same article, that meta-analysis folder, we will save another one. Done that? Right? Everybody has done that? You have created a folder named meta-analysis. We want to save 3-4 papers in the same folder, meta-analysis folder. Okay? Okay. So now, when we will open my library, we can see all those papers we have saved there. Can you see? Please reply with a good yes, so that we can feel that the session is interactive. Okay? All can see? Now we have a good thing. Now we have an option, export all. So there was shortcoming that we could not convert together into bibtext, but from here we can export all the collection in the bibtext form, right? Can everybody see it? Yes. So this is how we can create bibtext file in Google Scholar. Okay? So now we know how we are doing it on PubMed, how we are doing it on Google Scholar. Now, if we are discussing Google Scholar and we are not discussing about grey literature, are we there?
Yes, yes, yes.
Okay. If we are discussing about Google Scholar and we are not discussing about grey literature, then it is injustice, because this is one of the advantage of Google Scholar, because From PubMed we cannot see grey literature, but from Google Scholar we can see grey literature. But the first question is, what is grey literature? Anyone?
What is when you use gray? Huh? When it is black, then you say black. When it is white, when you say white. When it is not clear whether it is black or white, then the area becomes gray. So here the literature, those which are not being authenticated by the certain agencies like PubMed and all, so those literature will be remaining in the Google Scholar, because this is a little bit flexible one. That doesn't have much rigidity in involving the data, and that's how you can go through this to the gray literature. So gray means you don't have neither white nor black. You are in doubt, and that's how your doubt can be also included to clarify the first doubt.
So unpublished data which we cannot access from PubMed, we can see in the grey literature. So what is the best advantage of it? It reduces publication bias. Suppose we are thinking to publish something, we thought this is very innovative, but someone else had also worked on it, but it is not published. So now we exactly know how many of the people have already worked on it, and it is present somewhere on the internet. So it helps in reducing the publication bias, right? So we have an idea about grey literature. Now coming to recent update, we all are aware of PubMed, Google Scholar, etc., etc. But then comes Ovid. How many of you heard it before? No one. So okay, I would have showed the demo also of Ovid, but the thing is it is paid. So we don't have free access to it, but we will know about what exactly is Ovid. So first of all, how Ovid is different from PubMed. So first thing I told that PubMed is free, Ovid is paid. PubMed is developed by NLM. What is NLM, by the way? Yes, National Library of Medicine. So, and Ovid is developed by Walters Kluwer. Now database focus. Here comes the best thing. PubMed focuses on what? Medline. Yes, we know about Medline. We studied about it, right? But here Ovid has access to Medline also, Embase, PsycInfo, Cochrane databases, full text journals and books. So we have lots of information we can get directly from Ovid, right? So that is for the same reason that Ovid is best for systemic reviews. So if you are planning to do some systemic review or meta-analysis, the best one is Ovid, because we will get a lot of data there. Also coming to the proximity operators. अब ये proximity operator क्या है जो PubMed में नहीं है? Suppose we have put a command semaglutide. Since we are already discussing about semaglutide obesity again and again, we will take the same example. अब हमने command दिया. Also we will know this adjunct का जो word हम use करते हैं ADJ. Okay? So if we put the command semaglutide ADJ 3 obesity, ठीक है? Getting? तो अब हमारे रिजल्ट्स में ऐसे आर्टिकल्स आएंगे जहां पे 3 वर्ड के डिफरेंट में सीमाग्लूटाइड एंड ओबेसिटी दोनों रहेगा. यानी अब प्रॉक्सिमिटी जो है वो हम खुद डिसाइड कर रहे हैं, राइट? दिस इज प्रॉक्सिमिटी ऑपरेटर एंड हियर ओविड इज हैविंग अ लार्जर इफेक्ट, राइट? सिर्फ प्रॉक्सिमिटी ऑपरेटर्स. सपोज हमारे पास सीमाग्लूटाइड है, ओबेसिटी है. हम ऐसे आर्टिकल्स, we want articles in which we want that these 2 words should be present in one sentence. Suppose at a distance of 3 words, right? Getting till here? Now what we will put? We would put semaglutide, this ADJ, we want between 3 words. So what we will put? ADJ 3 and then obesity. Now what it will do? It will search semaglutide and obesity in articles where they are at the distance of 3 words. So now we have decided the proximity, okay? So this is the advantage of Ovid. Why Ovid matters in medical research? The best reason is it has structured search history in Ovid. For example, every search you perform here becomes a numbered step automatically. While in PubMed, we don't see such thing. For example, again, we have searched semaglutide, we have searched obesity, then we have searched 1 and 2. Now this is already numbered. First one is semaglutide, second one is obesity, third one is 1 and 2. So now what does this mean? Now step 1 will search all articles indexed under semaglutide. Then step 2, it will search all articles indexed under obesity. And then step 3, because now we want the articles in which both semaglutide and obesity is present. So now it will combine both articles that contain both the concepts. For example, in step 1 we got 1000 articles. In step 2 we got 500 articles. But in step 3 we got only 80 articles, right? So when we are doing meta-analysis, we need to know exact search strategy which can be reproduced again also. Again also, if we put in the same order, we will get the same result. So why Ovid is important in research? Because it has advanced mesh exclusion and mapping, structured reproducible search history, access to Embase, proximity searching which we just discussed, and hence it is preferred in systemic reviews and also in pharmaceutical industries. So with this I conclude. Now Dr. Snehashish will continue with Citation Manager. Thank you. If anyone is having some query.
This is the CME which is different from the others because you are not listening, you are interacting. So interacting is tenfold more impactful than listening. So if you have any doubt, please ask without any hesitation because it is the beginning and during the beginning the mistakes has to be there and one step you will learn. Okay. So if any confusion, please. Very nice. Younger brains are very nice.
Ma'am, when we were saving the data from the Google Scholar, then it was coming in a notepad form. So how do we turn it into a PDF and export it into Zotero?
This we will learn in the next lecture in Citation Manager. This the same thing Zotero will help us in doing.
Thank you, ma'am.
Anyone? Anyone? Dr. Paz, yes.
Please, can you tell that do we have the access of Ovid database through our institution?
No.
No. Thank you.
We have through the university and you will have to be registered with that computer and you will get the pass through the library.
Okay. Thank you. Thank you, sir.
So don't hesitate because these are the things which are having technical terms. We are not familiar with the technical terms. We just know Word file, we just know PDF, we just know PPT, finished. So there will be new nomenclature, this particular file, this particular file, this particular software, and these software we are not supposed to go in depth into the software, how it works. But what it works is matters for us. So thank you, Dr. Nidhi, for a wonderful session. And I hope that at least you know that what to search means what to think. What to think means the right question, right Pico. Then how to search under those Picos, and then the step by step you will get to the material, and that material or the data will be analyzed, and ultimately you will get some conclusion. So thank you, Dr. Nidhi. Wonderful lecture. Thank you.
By this session, we learned that and narrows the field, or expands our options, and not helps us avoid unwanted guests in our search results. Thank you, sir, and Dr. Nidhi, for making search strategy simple and enjoyable.
After understanding how to search, it is equally important to manage it efficiently because collecting research and organizing it smartly is an art. And to understand this, with the help of Zotero, I would like to invite Dr. Sneha Singha to guide us through.
So good morning, respected and dear all. I am Dr. Sneha Singha, junior resident of this department, and I will be discussing about Zotero, a reference management software. So what is Zotero? It's a reference management software. Referencing is a very big task if we are planning to write our own research work. So it manages very efficiently. So why Zotero is needed? Let me ask you honestly, have anyone of you done manual referencing before? Or initially, in initial steps? Thank you, Dr. Hassan. Anyone else? Manually copy pasting from PubMed? Right? Thank you so much. So basically you have copy and pasted the citations from PubMed and entered into and copy and pasted into the Microsoft Word. And after that you will adjust the italics, putting some brackets, mention the author name, then date, year, volume, issue. Somehow you manage to do something, right? And you will submit your article into a good journal. And after that, what will happen? The reviewer will comment, you have to change your citation style. You have to change it into Vancouver or any other citation style. Now you are doomed. You have formatted almost 70 references in this way. Now you have to do this again. So what is the solution of it? The solution of it is using any reference management software. So we are talking about Zotero today. So before we go further into Zotero, let me clarify three different terms. I am sure all of you must have already known about these terms, that is citation, reference and bibliography, right? But the first time listeners, this can be a little confusing. So what is citation? Anyone, what is citation? If you have gone through different journals or different articles, you must have seen this kind of para. After one sentence, what you can see? Something is written inside the bracket, some numericals. Or instead of numericals, what we can see is some author name and the dates are mentioned. So this is exactly what citation is. Citation is nothing but giving acknowledgement when you use someone else's data, results or anything, right? So this is what citation is. Now coming to reference list. In one article or your manuscript or your thesis, you can add multiple citations. You can refer to multiple articles to write your own research work, be it in 20, 30, 40, you are dealing with SRMA, so the reference list will be go up around above 50. If you are writing a thesis, it will come around 100. So it's not possible for us to manually manage everything. And on top of it, if you want to add one more citation in the middle, you have to manually change the sequential pattern again. You have to renumber it again. So it's not possible manually, you have to use some management software. So, but at the end of the text, when it's visible. So at the end of your article, when you list down all the citations which are mentioned in the text, that becomes the reference list. So this is the reference list. Okay. Now how it is different from bibliography? Bibliography is similar to reference list, but the thing is here, it's not needed, it's not compulsory to be mentioned inside the text. You might have consulted any book, you might have consulted any YouTube video, you might have consulted any website, and you want to list all these references here. So that is what is called bibliography. So far, I think it's clear what is reference, what is citation, and what is bibliography. Coming back to our presentation, so we have already seen what is the difficulty of manual referencing. We have to copy and paste, we have to change the italics, change the number, we have to, preposition, supposition, we have to superscript and subscript all the things, and we will be in this vicious loop. So in this vicious loop of where should I put what, and we can't complete the work in this way, right? So for this, reference management software are there. Other than Zotero, have you heard about any other reference management software? Or you have used any other reference management software? Mendeley. Other than Mendeley? EndNote, anyone? Okay, so Mendeley and Zotero, most of you have used these two softwares. How many of you have used Zotero before? Or you have used Zotero for your research work? Thank you. Okay. And how many of you have used Mendeley? So the number of Mendeley is higher. And as I can see, there are many of you who have worked on both Zotero and Mendeley, right? So do you have any preference? Which one? Dr. Faiz, which one? Which one you would like? Zotero, right? Okay, so I am not here to promote Zotero, right? You can use any of Zotero or Mendeley. It's up to you. Both these softwares work altogether in similar pattern. All these softwares have similar functions. But yes, with my limited experience, I can say that Zotero Web Connector, if you have heard of it, Zotero Web Connector is very powerful. In simple terms, I can say if it is available in the internet, if you can search it in Google, you can make the reference out of it in Zotero. In Mendeley, it is little difficult. It can be done manually, but it is little difficult. So now let's see where Zotero fits in this framework, SRMA framework. We have already seen the Pico framework. Then we have seen how we can search the databases with Boolean operators and all efficiently. Now we'll see how can we manage the references. So today I will demonstrate the software Zotero. So I'll request everyone to please use your laptop accordingly, because in the same time we'll also demonstrate it. So hands-on, which was supposed to be happen later, I will cover the hands-on part also in the same time. So please use your laptop accordingly so you can follow the steps, because usually software demonstration sessions are boring if you don't follow it stepwise manner, right? So let's proceed. First, installation. You can go to Google and just search Zotero.org. You don't have to be just go in Google. You go to any search engine, be it in search engine in the sense Linux, Mac OS or anywhere. Just search Zotero.org. Right? So I will do it in the same time. As you can see, I will search Zotero.org. In the meantime, if you face any difficulty or might have facing any problem, our team is behind. You can just ask them for any help. Okay. So if you open Zotero.org here, like I have just mentioned, Zotero.org. So download Zotero connector. This page is coming up. Okay. So previously I have seen other page. If you enter the download button, you will land in this page, which says Zotero 8 for Windows and Zotero connector. Here, this thing will change if you are operating from OS, Mac OS, right? It will show Mac OS. It will show Mac OS. Now, not just this. Not just this, you have to download the connector also. What will happen if you download the connector? The moment you will download the connector, I have already downloaded it. So it is showing me that remove from Chrome. So for you, the step will be, you have to add to the Chrome. Can anyone see the option? Add to the Chrome. If you face any difficulty or any problem following all these steps, our team is behind. You can ask them. Dr. Amit, please assist if anyone asks you something. Our team will be happy to help you. If you face any difficulty, please ask them. So far we have covered. We have to open Zotero.org first. And once you open, you will land in this page which says just download. You have to press on this download button. Right? Dr. Amit, it's done. Open. So we are just proceeding. We'll follow up this matters later also. So once we download, we'll download this file. This file will download the .exe file of the Zotero software, right? And this Chrome connector will help you to download the connector for the search engine you are using, be it Safari, be it Chrome, be it Opera, be it Linux, anything. From here you can download the connector of it. Once you download the connector, it should show up in this extension. Can everyone follow? It will show up in this extension. Yes, you have downloaded some extension, and what you have to do, you have to pin it. See, there is the pin option here. You have to pin it. So this is the most powerful tool of Zotero. So please follow this step very carefully. So I am repeating again. Once you install the Chrome connector, it will direct you to this page where you will see key attached with your Chrome or install into your Chrome. Once you do it, it will come into your this part, that is Zotero connector. Everyone getting it? Okay, I am proceeding. So far we have downloaded the file, we have downloaded the connector. After that, for the first time users, we have to register for it. If you have already registered, you have to log in, but for the first time users, you have to register for it. For this, what you will do, you will just go to in this login page. It says login, and for the first time users, here it says register for a free account. You will open this. Like I have already registered, so this window is coming up. If you haven't registered for it, then you will get to show about this window. Which are the details it is asking? It is asking about username, mail, confirmation of mail, password, and confirmation of your password. This is the older version. Okay, the newer version will show like this. It says just the username, email ID, and password. So after putting your username, email ID, and password, you can register for it. And just one thing, remember this email ID, username or mail ID or password, because you will need this later. So far you have registered for it also, right? The PPT will be shared with you, so you can follow the steps accordingly. And now you have already registered for it. You have to remember that ID and password, put that username or mail ID and password, verify yourself, and log into Zotero, right? So far what we have done, we have downloaded the Zotero file, we have downloaded the Zotero connector. Now we have registered for the Zotero account, and with the credentials like mail ID and password, we have already entered in Zotero environment, right? Here how it will show in Zotero connector. You have to press this button of install connector. After that, add to Chrome, and following that, one Zotero connector icon will come up in Chrome like this, right? Okay. So now what we have to do, you have to open Zotero. Is it opening? Dr. Himanshi, is it opening? Okay. So if you are opening the Zotero software for the very first time, you will not see these options. I have added these articles, right? I will show you how can we add articles. I have already added these articles. So for the first time users, you won't get to see all these things. It will be blank. Okay. So for this, you have to press this button, this one, this circle wala thing. You have to press this button. Okay. For the first time users, you have to open this, and what it will ask, I will just show you. See, this is, I have opened Zotero. I have clicked this icon. I have already installed all these articles, so it is not showing in this way. But for the first time users, if you are opening it, if you are pressing this button, it will show like this one. You can see. These credentials it is asking. You have to enter your username, you have to enter your password, right? And with these credentials, you have to enter into Zotero. If it is synchronized, if you have entered your mail ID or username or password, then the final step will show like this. Your Zotero setup is complete. You have installed the web connector, you have installed the MS Word plugin, you have registered for it with your user ID or username, mail ID and password. And once you have completed all this process, so nowadays the latest MS Office automatically detect the plugin. So this Zotero comes with a Word plugin also. What does it look like? If you have covered until this step and now you open your MS Word, it will automatically detect a new plugin which you have already installed with your Zotero file. It will show like this. It says Zotero. Can everyone follow? Is it visible to the last? Okay. So you have downloaded the whole Zotero environment in your system. That says the Chrome connector, the Word plugin, the Zotero software, and you have registered for it. So thus your Zotero account setup is complete so far, right? Coming to the interface, it says Zotero software interface. If you open the Zotero, on the left side we have a column that says library and collections. Here, जी सर.
Anybody wants help? The volunteers are there to help. You want help? Okay. Volunteers are there to help. If anybody wants, please help. We are very weak in software, and this is the new one which we have to learn. So don't hesitate to ask for help. Zotero is new to everybody. Most of you are not using this in routine. So just ask. Like sir is asked, sir has asked, sir is getting help. Anybody else? You can see the chat box in the online. If there is also any help is needed, please respond. Okay.
So just want to mention one thing. If you complete all the processes perfectly, then this will show up. Welcome to Zotero, and you have logged in with your account. So if you face any difficulty reaching up to this level, please ask our volunteers. So now, if you have set up, so whatever it's done, it's fine. Rest we'll discuss later. So let's follow the further steps.
See, if you have done, it's very good. If you are not able to do, don't worry. During the lunch time, you can take more help. But come to the, topic again. Okay.
So now this is the Zotero software interface. On your left, if you open the Zotero, on your left you'll be having the library and collections, where you will store all your libraries, all your references, and inside each library you'll be having multiple articles. So this is the collection content. See, this is the collection content. And on your right you have the item metadata section. So this brings me on to new important thing. It says item metadata. We have heard about data. What do you mean by metadata? Today's CME topic is not analysis, right? It is meta-analysis. What is the difference between data and metadata? Can anyone say what's the difference between data and metadata? So let's go off the topic a bit. Let's say, how many of you use Facebook? This much? Okay. I believe almost everyone. How many of you use Instagram? Great. Okay. And you definitely also use Threads and Messenger also, right? What do you do in these platforms? You'll connect with more and more people. Not just this, you will upload different photographs also, videos, reels, right? Not just reels or photographs. You will tag it with the person you went, or the place you went, the food you had. Not just this, you will add some hashtags also. So what you are doing? You are uploading your data, right? You are sharing your data. So what are the platforms I have mentioned? Facebook, Instagram, Threads, Messenger, and I am sure 100% people use WhatsApp. So I mentioned 5 platforms. Can anyone say who is the owner of these 5 platforms? The owner of these 5 platforms is Meta. The owner of this Meta is Mark Zuckerberg. Okay, so Meta is nothing but it's data of data, structured data. So Meta doesn't just know your photograph you have just uploaded. It knows आप कब गए थे, किसके साथ गए थे, आपने क्या खाना खाया, कहाँ खाया, ठीक है? So हाँ मतलब sir anything and everything, ठीक है? So we are basically sharing all our details. Okay. So this is what metadata is. The structured format. In structured format, you are sharing all your details. The photo itself is a data, but when you are tagging with the location, the hashtags, the person you went, the location, it becomes the metadata, right? I am trying to correlate with Zotero here. Let's open Zotero. It's not showing me. So let's open Zotero. Here I have one PDF. What is this PDF about? PDF is about semaglutide and tirzepatide for weight loss in adults. This PDF is the data which has all the details. It has abstract, it has DOI, it has the author names, the journal name, and everything in details. Now what I will do, what is the power of Zotero? I just want to show you this thing. What I will do, I just drag and drop this PDF here in Zotero and wait for some time. See, this was the article. This, what did you mention? This is the item metadata section. I haven't done anything. I have just drag and drop the PDF inside Zotero. Zotero itself has detected all the metadata out of this PDF. You can see the journal article, it is showing the category, the title, all the authors, the date, abbreviation, URL of it, and the whole abstract also. Right? So how Zotero can extract the metadata from your simple PDF? So this is just the thing, how data and metadata is different. Metadata is very important. If metadata is incorrect, your reference is useless. That's it. Coming to the next part, that is how can we add references in Zotero. There are multiple tools, but like I have mentioned earlier, the most powerful tool is Zotero web connector, the browser connector. Other than that, we can add DOI. We can add DOI, PMID or PMCID. The difference is it is PubMed identifier and PubMed central identifier. ISBN for the books. ARXID, it is archive identifier. ADSB code is not related to biomedical research, it is related to NASA. Drag and drop, we can simply drag and drop the PDFs. We can import the BibTeX files from any other databases like Dr. Nidhi has just showed from Google Scholar or PubMed. We can manually enter the data. We can retrieve the metadata for PDF like I have just shown you. And from the Zotero web library, it has its own library itself. And lastly, the Google Scholar, like just demonstrated. Now, like I've already mentioned, if it is in the website, if it is in the Google, if it is in the internet, Zotero can extract the references out of it. So if any journal asks you, wherever available, you need to mention the URLs also. So it becomes very easy with Zotero. It is a little drawback for Mendeley. In Mendeley, it's not that easy, but with Zotero, you can get this benefit. You can automatically detect the URLs out of any references, be it any article, be it any YouTube video, be it any newsletter, be it anything. Okay. Now, how can we add references? Like I have already mentioned, DOI, PMID, PMCID, ISBN, like this. So let's add some article. How can we add article? If I have already entered the Zotero, just go to Google again or open the Chrome. And here I will open PubMed. Today's topic is about semaglutide obesity. We are learning SRMA out of it. So I will just search semaglutide. So first this article is coming up. So how can we integrate this article with Zotero? What are the steps? Well, just open this link. This link is totally opened up. So for this, there are two ways. I'll show you the difficult way first. The difficult way is you have to locate the dy first. Dy, the full form, anyone? Like a unique identification of all the articles, right? So we'll locate the dy first, we'll copy it, right? You will open Zotero. In Zotero, we have this taskbar where it says enter ISBN, DOI, PMID, archive identifier, ADS beep code. We'll simply paste it. So what we have done, we have opened Chrome, we have opened PubMed, we have searched new article, we located the DOI, copied it and pasted inside Zotero, and we'll press enter. Wait for some time. See, it's automatically entered here, right? So this is some tedious process. The easier process with Zotero is, I am doing it with another article. Let's open this article. The moment you will open this article, this connector is available. You will just press on this connector, okay? And it says where I want to store it. Suppose I have already created one library inside my account and want to store it there. So I will just enter. The moment I will enter, see, it's added. So which one is easier? Copy the PMID, DOIs, or this just clicking on the link? This is better, right? So this is how we can add some articles in our Zotero reference manager. We have seen the articles. Now how can we add the books? We can open the book links. How can you open the book link? The most ideal one is, the most easier, accurate one is, you have to open the Google again. Just here you want to refer any book. Which book, anyone? Any preference? Goodman Gilman. The latest edition, which one it is? Anyone? 14th, right? So I'll just open Goodman Gilman, 14th edition, and at the end I will mention Google Books. See, the first option, it will show up of Google Books. See, the edition you can check it from here, the 14th edition. Now you are getting two ISBN numbers. So this first ISBN number is a little smaller. This first ISBN number is of 10 digits and the next ISBN number is of 13 digits. So which one you should choose? First one is called ISBN 10 number. Second one, like here you can see, I opened Hadison's Internal Medicine. Here we are having two numbers. The first one is ISBN 10 number and second one is ISBN 13. So basically the difference is ISBN 10 is that unique identifier which books have been publishing on or before 2007. So the first edition came in 1999 and since then it is coming up newer editions. So in these cases you will get two different ISBNs. ISBN 10 for the previous ones, ISBN 13 for the latest ones. But the books which have been coming, the editions are coming after 2007, you will only get ISBN 13. So it's preferable to choose the ISBN 13 or the 13 digit wala number. How? In Google Books, we have opened the Goodman Gilman. We'll just copy the ISBN number from here. We'll open Zotero. Similarly, here it's mentioned enter ISBNs. So here I will paste it and wait for some time. See, it has automatically added. And when it has added, it will show all the details. Now for your workshop hands-on purpose, try to do the same with CAD-Zang latest version. Now our team is here. If you face any difficulty, ask them. Try to add CAD-Zang latest edition in your Zotero library. How? I will show you here. So inside Google, what you have to mention? KGMU, which is the latest edition of KGMU? 16th, right? So KGMU 16th edition, Google Books. See, here it is showing up the first link only. We'll go down, and here we are getting the ISBN numbers. From here, what we'll do, we'll just copy the 13-digit number from here. We'll open Zotero and manually we'll paste the number in Zotero library and enter. It will take some time and it's done. See, this is added. So this is how you can add books in your Zotero library. So we have seen how can we add articles, we have seen how can we add the books. Now for the YouTube videos, if you want to refer any YouTube video, like you want to take any lecture on material vigilance, right? Recently CDSCO has organized one workshop on medical device program. So let's open that platform. So what I'm just opening the CDSCO YouTube channel. So for your material vigilance wala PG teaching seminar or lecture, you want to add this reference in your PPT. So what we will do, you will just open this video. I'm just pausing it here. So the moment you will open this video, previously this connector was showing a Z-like thing. See, now it has changed. You can also open any video in YouTube, and the Zotero connector, if it is available in search engine, you can see that Z wala Zotero connector is changed to one webcam wala thing. Is it visible? Yes. So you need not to do anything, you need not to copy and paste it anywhere. Simply like this article, you will open and it will automatically save into the by default selected library. Enter it, you will go back to Zotero, see, it's automatically added. Not just this, it will add the title, the URLs and everything, and it will make a short abstract of it also. Okay. So it is all about data. Nowadays we are talking about artificial intelligence. It is nothing but what? It is nothing but machine learning, right? And the backbone of machine learning, of artificial intelligence is what? It is data science. The more refined the data is, the more efficient your work will be, in simple terms. So we have seen how can we add article, how can we add books, how can we add YouTube videos. Anything else you want to add? Websites, new GINA guidelines has come, AD has published new article, new news, or WHO has published new thing in their newsletter. How can we add that? We'll open Chrome again, we'll open the Google, we'll open ADA, just mention like this. So their website will open up, right? Now from here, relative to diabetes, you want to add any data from this website. If you just cite this, if you just refer this website, that is vague. So you have to precise that, right? So how you want to, let's say view all events. Suppose you want to add this link in Zotero or your PPT. How can you do so? You'll open this link, wait for some time so the link will open up. See, the link is open up, the board of directors will link. You just have to select on this thing. Previously it was Z, then it was converted into a webcam wala thing for YouTube video. Now it is back to a page wala thing. This is for the web pages. You click on it, wait for some time, press enter, and now if you open Zotero, see, it has also created references out of the web page also, which says meet our board directors. Here it has automatically generated the URL link and everything. So this is how you can add different things inside your library, be it article, be it YouTube video, be it book, be it web page, be it website, anything. So the thing is, if it is available in the internet, you can make the reference out of it in Zotero. Here I have mentioned how can we add Google Books. Write any book name, the latest edition or the particular edition you want to have. If you mention I want the Goodman Gilman 13th edition, it will show the ISBN details of the 13th edition only. The most preferable, the most ideal platform is the Google Books. Then the thing is, how can we organize the library? Organizing library is very simple in Zotero. How can we do so? We'll open the Zotero. Here I have already made some libraries, as you can see: fungal infection, Ozempic, SRMA, Zotero references, like this. How to add another library? How to add something in your library? You'll just right click on it, press new collection, and suppose you want to write your thesis. For that you have to manage at around 100, 120, 150 references, and it's very tedious if you just make one library of all the references. So you want to separate it, segregate it. So I want to make one library for ROL. So ROL, one thing is done. I want to add one new collection for where do you need your references most after ROL? Introduction, discussion, material methods. So for the next section, material methods. So I have created another collection also. So for your thesis purpose, you have created two libraries. First one is ROL. For review of literature, that particular references you want to use in your ROL. And this material methods, for that particular references you want to have for writing your material methods. Now how can you add references inside your library? Suppose I am just giving you an example. This is my complete library in which I am having around 300 references. Out of this, I want to use these 4 articles. I want to use these 4 articles for my ROL writing. I will select this first. I will just press it, drag and drop wala system. I will just copy it and take it to material methods. Done. I want to use this many articles in my ROL. What I will do, I will select it, copy it and paste in my ROL. Right? Let's see what happened. Those few articles which I had selected before are now added inside the ROL part, and that few articles which I had selected for material methods now inside your material methods for the library. So this makes your job much more easier. Now you don't have to search here and there where my references have gone and like this. So this is how you can organize the library. Other than that, here on top of it you have a status bar also. In the status bar,
till now, what you have learned about Zotero? Just one by one. Anybody? What is Zotero? It is a software which is for the help of referencing. Okay. Very nice, very nice, very nice. So, have you created your Zotero account? Huh? You are having that Zotero Z in the right side? Okay. So, you are getting the steps which he is telling? Okay. So, just keep your laptop in the table and do this. Hello? इतनी देर से जोटेरो हो रहा था, ठीक है, तो सारे के दिमाग में जोटेरो घुस गया. तो now you just relax, 2 minutes की breathing करो and then you come again to the topic. So deep breathe. Deep breathe. दूसरे की सांस नहीं, अपनी सांस लीजिए. चलो फिर से.
So we have seen how can we organize the library in Zotero. Now the most important part of Zotero, that is how you can cite. You can add citation in MS Word. So for this purpose, I have created one sample text for you. So this sample text is based on fungal infection and its pharmacology. See, you can see from this text, it is not cited, right? It is not cited. So far what we have added in our reference wala list, we have added Goodman-Gilman, we have added Katzung, right? So these two books have been added. You have added at least one article also. So minimum we are having 3 references right now in our Zotero library, right? Let's see how can we add citation. So if you open MS Word, the moment you downloaded Zotero, it will automatically detect the plugin it comes along with. And this is the plugin. As you can see, the Zotero plugin automatically is there. Now this is my sample text. You can write anything. Write anything. Your name, your father's name, your wife's name, anything. Just make one sentence, right? Done? You express anything. You have done? Chalo, okay. Then what are the next steps? Then you have to open, yes, the prerequisite is the Zotero software should run in the background. It doesn't work if this software is not running at the background. It should run on the background, right? So the first step is, even before opening the MS Word, is opening Zotero software. That is first step. The second step is you have to write something. Suppose let's say this is your manuscript, this is your thesis, this is your research paper. Now how can we add citation? So the first thing is you have to enter the cursor. You have to place the cursor after the full stop, the sentence which you want to cite. You have placed the cursor here. See, it is blinking, visible? Okay. After that, we'll go to Zotero tab. We'll go to add or edit citation. And in SRMA, I have collected this YouTube video, and there are different books also I have added. Let's see these things. So first one was YouTube video. I'll just click on it. And here you can see a plus button is there. You have to enter this one and done. See, the first citation you have created. Let's try to do your first citation. If you face any problem, ask our volunteers. Try to do your first citation. And please respond if you have done so. Anyone have done your first citation? Do you want me to repeat the steps again? Okay. Chalo, I am just deleting it. So this much is clear. A sample text. Sample text. This is clear. After this step, I'll open Zotero. Right? I opened it. I'll go to add and edit citation. This kind of window is coming up. Right? Dr. Arshad, any problem? It's coming up, right? So now I will select the first reference which I have recently added. I have added this reference, enter this plus button and this arrow button next, and it is added, right? Now I will do same with the next para also. I will go to add and edit citation. Katzung I have recently added this reference. I will add this and enter. See, the second citation has also been created. Let's do the last one. Same, what I am doing, I am placing my cursor which I want to cite. Then I am going to add and edit citation. I am selecting the book or the article, pressing the plus button and enter. Now it's done. So like I mentioned in the starting phase of my lecture, what are this? These are citations. I haven't created my reference list yet. What to do next? After my article, at the end of my writing, I will mention something like references and I will place my cursor there. After placing the cursor, I will not go for that add or edit citation because I have already cited my whole text. Now I want to add the bibliography of it. I will just go add or edit bibliography. It is visible, this option to everyone. I will just press on it, wait for some time, see 1, 2, 3, the citations are listed. So this citation list is called a reference list. Okay. Now you have submitted this article, you have written this manuscript, submitted it to any journal, and that journal has rejected your article for some purpose, asked for some query and rejected your article. Now you want to submit the same article to a different journal, but in different journal, what is the problem? The problem is the citation style is different. It is in Vancouver, but Vancouver itself has 49 different variants. I will show you 49 different variants. Like here, I am just giving you one example. So the first one you have submitted in IJPP, where the citation style is superscript third bracket, and your article got rejected. After that, you want to submit your article in IJBCP, a different journal, where it is asking without bracket, just superscript, and you want to submit your article into another journal at the same time. Here the citation style is no superscript or subscript, simple inside third bracket. So what will you do? Will you manually change everything? Like in this way, I will change the brackets like this. So is it a solution? No, right? So there must be some easier process behind it. Let's see. So what I will do? I will go to, we have already seen what is the role of add or edit citation. We have seen what is the role of add or edit bibliography. Now we will see the document preferences wala option. You have already added the citation. After that, if you want to change your citation style, you will go to document preferences. In document preferences, there are multiple options, right? And you are not satisfied with it because the general criteria is not matching with this given articles. So you go to manage styles. Here also you are not satisfied. You are not finding your article. You will go to additional styles. You will wait for some time. And here what will mention? Vancouver. Enter. See, I have already mentioned 49 different styles are there inside Vancouver only. Here you have to search which type of referencing is asked. So let's go for this one. This one. I will just click on it. Let's try it again. Let's try this one. Yes, I've added it. Let's close this one. I'll go to document preferences and see the latest I've added this one, right? I will just change it. Sorry, the previous one. Let me just do it. See, it's changed. Now it has become superscript in third bracket. So without much of hassle, you can change your whole citation style, be it 50, 100, 150 and so on. Right? So here we have seen how can we add citation, and previously what was there? This was our sample text. You have successfully created the citations here. After that you have created the bibliography and it should look like this way. So you can take a screenshot of it if you want to practice it later. What are the steps of adding references in MS Word? So you have to basically open the Word document, then go to Zotero tab. The PPT will be shared with you also and you can go through the steps. Right? Okay. So now if you remember Dr. Nidhi's lecture, at the end of Dr. Nidhi's lecture, she shared one file with me, right? That file, what is that file? It is filtered text file, bibliographic text file of 175 references which she got from PubMed. Now, what is my job? What is the job of Zotero in this case? You have to further filter it. You have to look for the duplicates. You have to look for the articles which had already been retracted by the author or the defective articles. How can you do so? So the file Dr. Nidhi had shared with me, I'll just open it. Let's see what are the steps. So it is about importing bibtext files in Zotero. SRMA is a team game, it's a teamwork. You alone cannot make a systematic review. You need a good team with you. So someone else has screened all the 175 articles. The next person will screen further. Will locate the duplicates, will locate the retracted articles or the defective articles. Let's see how we can do it. So we'll go to Zotero. Next step is try to follow the steps. So I haven't done anything yet. I've just opened Zotero. After this, I'll press this file button. Right? Here, what it is mentioned, different options are there. Out of this, we have to select the import option. Everyone can see inside file one import option is there. So this is the import option. You might have received the same file in your delegates for a WhatsApp group also. You can download it and check from there also. So here what it is asking you to select one file, one bibtext file. Bibtext is nothing but bibliographic text. It's a coded format. So bibliographic text. It doesn't work with any MS Word file or Excel file. It should be in specific format. So I look for that file. Inside Zotero, I have already saved it. That is PubMed semaglutide set.nbib. You have already received this file in your WhatsApp account. So this is the file Dr. Nidhi had shared with me. I will just open it. Don't have to change any option here and just press next. Wait for some time. And now it's done. What it is showing? 175 items in this view. But it is also showing that items in your database have been retracted. Can be retracted by your author or the publisher. So these two articles it can automatically detect. Manually, it's a very tedious work. You might not ever detect it. Zotero can easily detect which one because Zotero is continuously creating the web links also, right? So what you have to do? So remember the numbers. 175 I got. From here till now 2 I retracted, so 2 I am deleting. 2 article references I am deleting. So just enter. So how much left? 173 left. Now one more good thing about Zotero is we can locate the duplicate items also. So how to locate the duplicates? On your left column, after your library, you will see my publication and duplicate items. You just have to select this duplicate items, right? And in this date added tab also, if you notice, in this date added tab, you can arrange these articles in chronological manner. Today is 26th of February. I have recently added this 175 references. The time is 12:33. Here you can see all these details. Now this article is showing in the duplicate items. Let's see how many duplicates it is having. See, it is having 5 duplicates, right? It is showing 5 duplicates. So you want to delete it or merge it, because here you can see the creator, the author names are different. The same article with different author names, it is coming up in Zotero. So it is also detecting the duplicates of the same article. I will just merge it here, right? The second one, I'll just merge it, and now it's done. Right. So now, how many left? 168 references. If you go through your all 168 references once more, you will come down and you will see 2 article references which don't have any title. Here you can see not available, title not available. But the thing is, as you can see, it is continuously generating the web links. So even although the title is not available, you can check it in website. It's not in English, it in probably in Spanish or some other language. So here we can look at the article somehow, right? But so this is one such example. Another example is this Bernard. So here it cannot detect any web link. So this article is defective. So what we will do? We'll simply delete this one. And other articles are having the title and all the details, web links and everything. I have cross checked it, and at the end, how many articles I am having? 175 I got, 5 were duplicate. So remove the 5 articles from there. 2 were retracted by the author or the journal, and 1 was defective. How many are left? 167. See here, 167 items in this view. So this is not just, again I am saying SRMA is a teamwork. This is the part of work I have done. For the next speaker, Dr. Annie, she has to do the further screening of title and abstracts, right? So for that, like Dr. Nidhi has shared a file with me, I will share this filtered 167 references with Dr. Annie for further search. For this, I want to export the same. How can we export the same? Simply, we'll select the library here. After that, go to File, and one simple option is there, Export your library. We'll open this, and here you have to change the format, right? Because she might work it in EndNote, she might work it in Rayyan or Covidence or anywhere. Zotero RDF is not supported by all these platforms. What is supported by all the platforms? I mentioned the file type, BibTeX. So you have to select the BibTeX format. Don't ever try to change the Unicoding UTF-8 or BOM. This is byte order mark. You don't have to change any of these details, and just select OK. The moment we select OK, it will automatically create one file. I want to store it in desktop, mentioning 168 filtered reps, and it's done. See, it has come. So this link you can't open it, okay? But whenever someone is trying to integrate the same thing in Rayyan or Covidence, it can automatically integrate, and 167 references will show up, right? So this is how you can export your library. So importing BibTeX file, you have seen the steps. The first step is going for the import option. After that, just don't change anything. Proceed to next step, and you have to select the file you want to add. It will automatically be added. See, automatically be added, where you can see 175 references are there. After that, you have removed the duplicates, you have removed the retracted articles or the defective articles. You have merged it, you have removed it, and after that, you have got around 167 references which are filtered. So from 175, I have screened out and got 167 references. And these are the steps of exporting references. You have to select the export library option. After that, change the format to BibTeX, press OK, and your file is exported. So this is all about Zotero. Referencing used to be tedious, but with this reference management software, this makes you a seamless experience of writing your own article or research work. Thank you. Thank you so much.
Wonderful. So just give 2 names which are used for referencing, 2 softwares. Zotero and so Zotero में 5 चीजें बताओ जो तुमको कुछ समझ नहीं हो, एक एक करके. One thing, one point related to Zotero. How to copy and paste. Okay. Second, anything which you have learned. Okay. Third, anything. Duplicate file can be merged. Okay. Next. Means it is not much difficult. Only thing is that you have to do multiple times because it is being done first time, so it looks like जोते रहो ना, उसका खेत जोते रहो, ठीक है? तो खेत जोते रहो, अगर जोटेरो जोटेरे करते रहोगे तो खेत क्या हो जाएगा? जुत जाएगा, और जुत जाएगा तो क्या निकलेगा? फसल. So that is how you have to do the repetition of the things, and ultimately you will get the fruits. Thank you. Dr. Singha, you presented very well. You are Jyotirav. ठीक है? Very nice, very nice, very nice.
Thank you, Dr. Snehashish, for the comprehensive and insightful session.
Moving on to the next step, the study selection and reporting. As we have gathered the studies, now it's time to decide which ones deserve to stay and which one politely get screened out. For this important session, we have Dr. Annie Jacob with us. Thank you.
Good afternoon, respected faculty members and dear delegates. I am Dr. Annie Jacob and I will be speaking on this section on study screening. So where are we now? We have developed a research question. We have our inclusion exclusion criteria. We conducted a comprehensive literature search and we have finished this section. We have organized the references in Zotero. So this search phase is over. Now we will move on to the screening phase. As you can see it's between the search phase and the analysis phase. After this screening phase, we will come to the analysis phase. So after all this, screening comes. So imagine you are doing a PubMed search and you are getting 1000 articles. So, but actually around only 25 articles are needed relevant with your research question. How do you find those 25? This process is known as screening. So in our study, I hope you have read the SRMA sent it to you in the morning. In that study, there were 945 articles, total 945 articles. After the screening, how many articles were there? 167 was after the search phase and the organizing, Zotero organized references. After that, in the study, at the end, we have taken 4 articles. So the process of how we reached from 945 to 4, this process is called as screening. Hope you have read the 4 articles in your WhatsApp group. So screening is a systematic process of evaluating the retrieved records to determine their eligibility for the inclusion in a systematic review, and everything is based on our predefined inclusion exclusion criteria. So remember that before screening we should have our Pico, we should have our protocol ready, and based on this protocol only we will do the screening. So screening ensures relevance to the research question. It will minimize the selection bias and enhances transparency, reproducibility of the review. So how retrieve the full articles of the first stage, and then we will apply strict eligibility criteria, and we will read the entire article. That is an in-depth assessment to determine final eligibility. So in the morning we have heard that for screening we need at least 3 or more, for the SRMA we need 3 or more people, but in screening it should be conducted by at least 2 independent reviewers. And why we want to use reviewers? So if there is an individual judgment error, it can be reduced. And also it will reduce the selection bias and improve reliability. And suppose if there is disagreement between 2 reviewers, so the 2 reviewers will sit together, they will discuss about the topic. If the problem is not resolved, then it goes to the 3rd reviewer for the final decision. So when it comes to manual screening, 945 articles, if you manually screen, what will happen? Error can happen, and also it's time consuming. But these days, modern tools are there for screening, which incorporate artificial intelligence, and they use all these advanced technologies. So they will streamline the study, and they will improve the efficiency. They will reduce the workload, they will reduce the time consumption, etc. So we use tools for screening. So as I told, like we have 945 studies, they have taken 945 studies. Coming to the 4, if you are taking each article and reading the title and abstract, how long it would take? For me, it would be around 15 to 20 minutes it would take. So reading 945 articles, you can think about it. So, but these tools will help us as they are of advanced technology. These will help us to streamline the study. So, these are the most commonly used tools for screening. One is Covidence. Covidence is a Cochrane-based collaborated screening tool. It needs subscription, and also another advantage with Covidence is that it has the screening part, that is title and abstract screening, full text screening. Along with it, it has the data extraction integrated. So ROB is also integrated. So if you take Covidence, you can do it, the data extraction, ROB, everything in Covidence. And it's also subscription based paid platform. Next is the EPI reviewer. It's developed by evidence for practice and policy information review. It's a coordinating center in the University College London. This was developed by EPI reviewer was developed by the University College London, and this is a advanced systematic review management tool, and it's usually used by large universities or large projects. They use this EPI reviewer. Distiller SR is another comprehensive research screening tool, and the advantage is most commonly used in industry or engineering researchers. They mainly use this Distiller SR. And Rayyan QRI is the one we are going to use it. It's a free software. Right now you can, the link in the WhatsApp group, the link has been shared. You can go and connect it. Rayyan, we will use the screening tool because it's a free tool, and also it's a web-based screening tool, AI powered, and it's developed by the Qatar Computing Research Institute. And this one, Rayyan, is mainly used for title and abstract screening. And there is a blinded option if 2 reviewers are working. If the blinding mode is on, it would help us for the blinded screening. And it facilitates easy conflict resolution. As I told, if there is a disagreement between 2 reviewers, there is a conflict resolution option for conflict resolution. I will show you that. And also, as I told, this Rayyan incorporates artificial intelligence. We will give the inclusion exclusion criteria. Based on this inclusion exclusion criteria, AI as it is AI incorporated, that will detect the study selections, and they will highlight the relevant data. So there is also features like duplicate removal, filters and labels. Advantage with filters and labels are that we can organize the study. And Rayyan is the most commonly used for the academic purposes. This is the screening tool used, as it is simple and ease of use. Because of its ease of use, it's most commonly used, and also it's having an user-friendly interface. So we use Rayyan. Hope you are able to get into Rayyan. First thing. Then advantages include, as I told, it reduces the screening time. As I told, like if we manually screen an article, it would take around, single article would take around 15 to 20 minutes. But in this, it reduces the screening time significantly, and also reduces errors in study selection. It helps in collaboration. Multiple reviewers at the same time can review, and offline option is there for the mobile app. If you are not having the laptop, you can get in via mobile app, you can download. And also the free and paid versions are there. Limitation is that the free version, we are using the free version, it contains only 3 active reviews. And remember, it's mainly designed for screening, and it has a limited customization. In case of Covidence and Epi Reviewer, they have the source for customization. Here, the Rayyan is having limited source for customization. And also another disadvantage is that it requires internet for the full functionality. So how to use Rayyan? First, you have to create an account in Rayyan.ai. You can start along with me. So first you have to create an account, then it will show that to fill your details, your title, your organization, your country, etc. So you have to fill those details. Second step is to create new project. Second is we have to create new project. Then we will import the references from Zotero. We have that 167 articles. So from Zotero we will take this 167 articles, and then we will start screening. We will include, exclude, and we will undecided means maybe if we are not doubtful about anything, we will put it in undecided. And we will use the AI ranking filters, etc. to refine the results, and we can collaborate with the team members, and finally we will export the final decisions. So where are we now? We have the 167 articles. Hope you have that file shared in the WhatsApp group. So now we have 167 articles from the Zotero. Hope you are able to see this. Next is the create review. You can do along with it. If you have done the account details, next is the create review. In that you can click on it. So there are in the create review there are 3 steps. One is when we have to add the review info. Second is upload articles. Third is to invite members. So what was the review title? What was the review title? Efficacy and safety of semaglutide for weight loss. You can just type it, efficacy and safety of semaglutide, and it is asking for the review type. What we are doing a systematic review. It will ask what are the options mentioned. We are doing a systematic review. And review domain whether you are engineering, medical, what are the domain they will ask. So we have put biomedical. So you can put biomedical. And description you can write. We are doing SRMA, and the articles we selected is RCTs. We are comparing semaglutide with placebo, like that you can mention. So first step is we have to add our review info. So we have added everything, then we'll create review. Hope you are able to do it. Create review. Next is we have to upload the articles. So we have got articles from Zotero, and here they have shown the supported formats. Only these formats are allowed in the Rayyan. So we have got the file from Dr. Snehashish from Zotero, the 167 articles in BibTeX format. See, it's in your WhatsApp group. You can add it. So here we will upload the references. Then we will continue. Next is invite members. As I told, we need minimum 2 reviewers. So I have added. So they will ask for the user email, user role. You can add reviewer. As a reviewer, I am adding a person. Then what is the reason for adding? you can mention, as per our discussion, we are doing a SRMA and we need your help, like that we can mention. It's a message. Then we will invite the person. So mail will go to the person we are sending. Next is, we have our inclusion exclusion criteria. What was our inclusion criteria? What studies we will take? RCTs. And what was we comparing? What is the intervention? Semaglutide, placebo. And what was our outcome? Percentage weight reduction. We should set this before our screening. So we are going to enter this. So in the inclusion criteria, we will add inclusion criteria 1. We are going to take only RCTs. Inclusion criteria 2, we will use adults with obesity. Similarly, you can add the inclusion criteria. Exclusion criteria, what is the exclusion criteria here? We won't take, which one? Diabetes mellitus. So exclusion criteria, whatever you are having, you have to mention the exclusion criteria. Then you will reach the screening stage. We have entered our Pico, we have entered our inclusion exclusion criteria. Now we will reach the screening. Screening, you can see, we got 167 articles. We did a duplicate removal also option is there. After that, we have 163 articles. And you can see on the left side, all the articles will be shown. 163 articles will be shown. And here you can see the title and the abstract. See, this one is highlighted green. Why it's highlighted green? Because we have already given our inclusion exclusion criteria. Based on this, AI will detect and it automatically will highlight the whatever we have given. It automatically highlights the inclusion exclusion criteria. So it will automatically show it like this. And also another feature is, either you can go this way, like read the title, our semaglutide is there, then randomized trial, placebo is there, like that you can go, title and abstract. Or on the side you can see filters are there. Filters, keyword filters are there. It automatically will detect some keywords, like here as you can see, placebo. Out of this 163 studies, we have 40 articles containing the word placebo. Like that it will give keywords. And there are keywords for exclusion. See, now I have I added one keyword, that is semaglutide. So it's showing there are 139 articles. Among this 163, there are 139 articles having the keyword semaglutide. Similarly, so there is in the exclusion filter keyword, I have added reviews. So you can see there are 6 articles there are with the word reviews. So when you read the article, it's saying, in the abstract it's saying, the review word is highlighted in red color. So it's easy to see this. See, the whatever we want to exclude, it will show in red color. So we don't have to read the entire article. Simply reading that line, we can exclude this study. So this paper reviews data. We don't want reviews. We are taking only RCTs. So we will exclude this study. Like that, similar wise, we will read the title and abstract or use the filters and we will exclude the study. So if you are excluding one study, we should document it. Why? Why we should document it? Because in the Prisma flow diagram, we have to mention why we have excluded the studies. Here are they have automatically given few reasons for exclusion, that is wrong drug, wrong outcome, wrong population, etc. If you have anything to add, if you want to add, if the study duration is wrong, then you can write add wrong study duration. Like that you can add your whatever the keyword you want to add, you can add it. So after the free text title and abstract screening, from 163 articles, we have included 9 articles, and maybe in the maybe, that is undecided, we have put 5 articles, and rest we all excluded. For all exclusion, we have to mention how many we have excluded, and we have included 9 articles. So what is the next stage? After title and abstract screening, what is the next stage? Full text screening. So for the full text screening, we have 9 articles. All the 9 articles will appear. That time you have to, here there is an option for digital object identifier. With that you can we can get the link to the article, and you can attach the file. You can download the full PDF and attach the file. So the full text screening, the included articles are 4. We did the full text screening. Then what we will do is we will export it in the supported format. Here we will use CSV or RevMan, whichever is supported format, we will export it. And once we export it, it will go to the it will come to our mail, and the download link for the exported files, it will be appearing in the mail. So just I'll show you the here RCTs, we have included RCTs, adults with obesity, percentage weight change, and in exclusion criteria, diabetes mellitus, and adults with non-obese adults. Hope you have understood. Anything, I will clear it later. Okay, thank you.
Thank you, Dr. Annie. Your session guides us that collecting hundreds of studies is easy. Choosing the right one is where the real challenge begins, which we can screen out with the help of Rayyan. Now proceeding to पहले पेट पूजा, फिर काम दूजा.
Now we'll take a break for lunch. It has been arranged in NLT. Kindly proceed for lunch, and we'll reassemble in 30 minutes as we resume for the post-lunch sessions. Thank you. Good afternoon.
चलो डिप टैक्स का फुल फॉर्म बताओ। हैं? जिसको आता है वो नहीं बोलेगा, ठीक है? बैठो। डिप टैक्स का फुल फॉर्म बताओ। हाँ बोलो। बिब्लियोग्राफी टेक्स्ट, ठीक है। और दूसरा क्या है? जोटेरो का फुल फॉर्म बताओ। हैं? जोते रहो। जोते रहो, जोते रहो, ठीक, गुड। हाँ, पीको क्या है? पीको पॉपुलेशन इंटरवेंशन कंपैरिजन और आउटकम। पॉपुलेशन की जगह क्या लगाते हैं? पेशेंट, ठीक है, या पॉपुलेशन या कुछ भी। अच्छा, पीईओ क्या है? वेरी नाइस। दोनों में क्या अंतर है? पीको कब लगाते हैं, पीईओ कब लगाते हैं? हाँ, लड़का बड़ा तेज। हाँ वो है, हाँ, ऑब्जर्वेशनल स्टडीज में पीईओ। वेरी नाइस, वेरी नाइस। फाइनल एफ फॉर फिजिबिलिटी। सबसे पहले जब क्वेश्चन बनाते हैं तो ये देखते हैं कि फिजिबल है कि नहीं है, ठीक है? तो बहुत ज्यादा जो रिसर्चर फेल होते हैं वो बहुत हाई फाई क्वेश्चन बना लेते हैं। ये दवा देंगे आदमी कभी नहीं मरेगा। फेल होने के चांस क्या है? फेल होने के चांस क्या है? 100%, 100%, बिकॉज दिस इज नॉट feasible, this is not possible. So final का F feasible और I interesting, innovative और novel और ethical और relevant, relevant। फार्मा में हो अगर मान लो तो फार्मा से रिलेवेंट हो। ये नहीं कि कोई रिसर्च क्वेश्चन बना लिया कि राणा सांगा को या तुम क्या बताते थे, बाहुबली को किसने मारा, ठीक है? रिसर्च क्वेश्चन तुमने बना लिया बाहुबली को किसने मारा। नाउ दिस इज नॉट रिलेवेंट टू फार्माकोलॉजी, ठीक है? एंड पिक्चर में अगर मान लो वो लोग हैं उन्होंने रिसर्च क्वेश्चन बना लिया कि सीटाग्लूटिन acts by this particular method, so they will fail. So that is how that should be relevant to the situation, population and intervention. So final Pico, PEO, Zotero और क्या सीखा? बेप्टेक्स और साइटेशन, इंडेक्सिंग, बिब्लियोग्राफी, बहुत सारा सीख लिया, ठीक है? बहुत सारा सीख लिया। ताली बजाओ एक बार जोर से, ठीक।
Thank you, sir. Now we'll resume our CME proceedings with renewed energy. Now that we have done the hard work of selecting and searching, it's time to show how exactly we did it. For this, I would like to invite Dr. Karan Suneja to speak on Prisma Guidelines 2022.
Good afternoon, respected and dear all. I am Dr. Karan, and we have seen till now that we are going to make a protocol, we will identify the studies and we will screen the studies. So this all process will lead to ultimately can be summarized in the form of a flow diagram, which will be easier that how many studies or articles we searched and at last how many articles were included in the study, basis on the defining on the basis of inclusion as well as exclusion criteria. So what is Prisma? So Prisma is basically So we'll start with what is Prisma, that we will see in this how we got ultimately to the number of studies we have to select for final destination. So Prisma is preferred reporting items for systematic reviews and meta-analysis. So let's go back to the history. So Prisma was published in 2009. So why it was published? To make, okay, so SRMA and Prisma. SRMA is conducting a systematic review and Prisma is a reporting guideline. So it was first published in 2009, but in 2009 it was just a basic structure having only simple flowchart and only option of adding databases for the study. So it got updated in 2013 first, and then the latest update is 2020. So what is the difference between the two updates? The difference came due to because we recognized more bias, we included more number of sources for adding these studies. For example, database were there, but database, registers, citations, organizations and government reports. Now they are all included in the study. So where Prisma fits in SRMA workflow. So it is running parallel to the SRMA, running parallel to the SRMA workflow. So we will see step by step what is Prisma and how it is done. So it is published in 2009 and the latest update came due to for identifying, selecting, assessing and synthesizing the new studies. There are a number of various checklists. We will see that what is the relevance of that checklist. So this is a checklist. So checklist means that, for example, before the pilot, before flying a plane, he ensures that all the relevant items like landing gears, flaps, all systems working are checked. And similarly in the systematic review it is also like that. We will see that these items are checked or not. For example, the title which we want, the study title which we have chosen or on which we have to study basis on the forming of research question is relevant or not, and checklist for abstract, then introduction, what is the study about, then methods, what is the methods we will, how many database, how many registers, and what will be the inclusion as well as exclusion criteria, and ultimately the results, and then discussion and other information includes like source of funding, sponsor, anything. So this is a 27 item checklist. Second is flow diagrams. So this is the importance of Prisma, that we will make flow diagrams reaching on from starting to ending, like how many studies will finally be selected. So it is a simple flow diagram in which only if the studies are taken from only databases like PubMed, Cochrane, Google Scholar, or registers like Clinical Trial Registry of India and WHO registries. And similarly, if in the Prisma 2020 update there is identification of studies via registers, and if we have taken sources or studies from websites, organizations as well as citations, then also it is included. So it is a combined diagram will be combined flow diagram will be made. And if we are updating our systematic review, for example we did in 2012 something and we are updating in 2015, so there is also an option of updating the studies again. And finally, if we are doing a systematic review which also had some previous studies done on that systematic review, and we also took studies from citations, organizations as well as websites, then this will be a combined flow diagram or the latest updated flow diagram for the doing a systematic review. So these are some extensions of Prisma, why they are needed and what are they. This is a extension first for abstract, the Prisma abstract checklist. It has 12 items. So why we need an abstract? What is an abstract? Anyone? Yes.
An abstract is a summarized piece of text. An abstract is a summarized piece of text through which we can know what are the content or the objectives and the methods of the research paper or the systemic review just from the beginning 1 or 2 paragraphs without having to read the entire systemic review or meta-analysis.
Yes, please, thank you. Sit down. Yes, that is a wonderful explanation for the abstract. Similarly, this abstract contains all the checklist again from title, background, methods, results, what is the study basically or what is the systematic reviews basically about, and some extensions. Prisma for protocol. So what is a protocol? Again, anyone? What is a protocol? It is an outline of study. So why a protocol will be made for doing a systematic review? So that we predefine the criteria, what will be the methodology, how many studies, and what will be the inclusion as well as exclusion criteria, and what will be the outcome of the study. So it ensures the transparency as well as smooth conduct of the systematic review. So it is again also a 17 item checklist. Next is Prisma for search. So what we will search? We will search the studies on database, registers, websites. So search is important because we will do the relevant search related to our topic. We will not do the search which is not relevant to our topic. And search will be there on databases, registers and organizations, website, every source where our topic is relevant. Next is Prisma IPD. IPD means individual patient data. So it is also again a checklist. So individual patient data means that if we want to do very smooth, very transparent research, we will not take the results of the research papers or the findings of that research paper. We will contact, for example, if we want to do research on hypertension, we will take the individual records of the patient data from the hospital records rather than taking the data which is already published on the papers. So it is individual patient data. So it is also again a 27 item checklist. And next is Prisma scoping reviews. Scoping review means that if already literature is available, we will map that available literature. For example, if we want to do a study on artificial intelligence in radiology, so we have to find that papers which are doing that kind of research or that use of AI in radiology to update the existing literature or to align with the existing literature. So it is again a 22 item checklist, and the main core points are same in all the checklist: introduction, methods, results, discussion, conclusion. Next, now these all guidelines and all the updated flowcharts have been shared on the group, and also that article which pertaining to our systematic review. Now let's do an exercise to see how we will make a flow diagram. I request everyone to kindly open your laptops and please start. So step 1 is, please kindly visit this website. This website link is also been shared. And please request me or please prompt me yes or no when you have opened that website. Yes? Everyone, yes? Done? Website opened? So coming on to the next step. Step 2. This kind of page will open. So you have to toggle to flow diagram. Kindly toggle to the flow diagram. Done? Everyone? Okay. So coming on to the step 3, you have to toggle to this part in which there is a link eshackathon.org, a shiny app available. Please refer to this part. Step 3. Everyone? Yes? Done? Okay, coming on to the step 4. So you will see a page like this and you have to, it will be a smaller font that follow this link to access. This is the step 4. Please click this part. Done? Everyone? Okay. Now coming on to this kind of page will open first. So this is the step 5. You have to toggle to create flow diagram. Done? Now coming on, how many? 3. Okay, and other searches for studies were none. Individual registers not included. We didn't search any individual registers. So how many databases? 3. 0 registers. So what specific database we searched? PubMed, Cochrane and Google Scholar. And duplicates removed? 0. Duplicates removed on the basis of identification of studies, not screening, only identification. That's why it is 0. And automatically excluded 0, and other exclusions 0, because they have not given any reasons for the exclusion. Now coming on to the screening part. So records screened 1208 articles. So initially they searched about 1208 articles. It is all on the basis of study. Kindly see the methodology part. Records excluded 263. Now why they were records excluded? Because they were duplicates. Reports sought finally. So on subtracting from 1208 263, it came 945. And from 945 also we excluded 895 reports. Why? Because they were either a clinical trial, they were either a review, they were either a cohort study. So in our study we only included RCTs. So final reports assessed 50, and from 50, in final 50 also we excluded, because in 50 they were either a clinical trial cohort or a review. So final studies included 4. Now as you can see, when you did this, you will see this kind of flow diagram, which is also available in the paper. So this is how we create a flow diagram, starting from beginning, that we search this much studies and finally reach to our endpoint studies which we wanted to include. We can download this as a graph, or as an image, or as a PDF form. Any doubts in this, that how can we create a flow diagram for any study? It will vary from individual study to study, depending on the type of study and type of databases and type of sources we are referring to. Any doubts? Okay, this is the final flow diagram. Yes, please. This, yes. For example, which term, specifically which term?
For example, wherever we are putting the data,
Yes.
so sir, on what basis we are putting the particular value? For example, why we are putting 1208 over there?
Yes, see, in article they searched initially. Screening means record screen. Initially they searched about 1208 articles, but they excluded 263. Why? Because they were in 1208, 263 articles were duplicate. So how many remaining? 945. In 945 also they excluded 895. Why? Because they didn't fit our inclusion criteria. Why? Because they were either a clinical trial, cohort study, or a review. So final inclusion came to 50, and then in 50 also they were either a clinical trial, cohort, and a meta or a review. So final studies we included 4. That's why. So this is the final flow diagram. Thank you.
Thank you, Dr. Karan, for simplifying the Prisma 2020 guideline for us.
After selecting the right studies, the next critical question comes to our mind. Can we trust them? Because sometimes studies look perfect on the outside, but who will help us see what's happening behind the scene? For this query to get solved, I would like to call Dr. Diksha to clear our doubts.
Good afternoon, respected and dear all. Good afternoon. सोना नहीं है अभी, बहुत बचा है अभी. So continuing the workflow of SRMA. Continuing the workflow of SRMA, next topic we have is ROB. So, what is ROB tool? What is ROB? Risk of bias. It is a tool devised by Cochrane to assess the risk of bias in the studies. So, for what studies it is used? RCTs, only RCTs in meta-analysis. For other studies, we have other tools. तो ROB टू क्या बताता है? क्वालिटी नहीं, सिर्फ बायस. What is the risk of bias in the studies? अब now we have ROB 2, तो ROB 1 भी रहा होगा कुछ ना कुछ. तो ROB 1 was the original tool which was devised by Cochrane in 2008. ROB 2 is the updated version. Difference क्या है दोनों में? ROB 1 में there used to be 7 domains. ROB 2 is better and has 5 domains. अब नाउ व्हाई आर वी असेसिंग द रिस्क ऑफ बायस? तो अब सुबह से बहुत सारा SRMA पढ़ लिया, लेट्स हियर अ स्टोरी नाउ। अकबर बीरबल सबने सुनी होंगी कहानियां। तो एक बार अकबर के मन में आया कि क्यों ना मैं अपने सिटी के जितने भी सिटीजन थे उनकी ऑनेस्टी चेक करूं। तो किसको बोलेगा अकबर? किसको बोलेगा? बीरबल को। तो बीरबल ने क्या किया? आइडिया लगाया, एक टेस्ट डिवाइस किया। उसने सोचा कि उसने अकबर को बोला कि आप सबको बोलिए कि एक नया पॉन्ड बना है सिटी में, उसमें सब लोग उसको मिल्क से भर दे। ठीक, तो सबको क्या करना था? दूध से पॉन्ड को भरना था। एक आदमी ने सोचा सब तो दूध डाल ही रहे यार, मैं थोड़ा सा पानी डाल देता हूँ, क्या ही पता पड़ेगा इसमें। बट सबने यही सोच लिया। सुबह क्या हुआ? अकबर ने पॉन्ड देखा, क्या निकला उसके अंदर? सिर्फ पानी, नो मिल्क। सबने पानी डाल दिया। तो क्या समझ आ रहा है इससे? अब क्यों मैंने सुनाई कहानी? हाँ तो क्यों सुनाई मैंने? क्या अच्छा अकबर क्या कर सकता था कि उसको सुबह सरप्राइज नहीं मिलता? एनीवन? जब सब लोग पोर कर रहे थे कंटेंट्स अपने उस पॉन्ड में, तभी चेक कर लेता कि भाई कौन पानी डाल रहा है, कौन दूध डाल रहा है। तभी उसको आइडिया लग जाता। अगर वो तभी देख लेता कि 10 में से 9 लोग पानी डाल रहे हैं और एक जना कोई दूध डाल रहा है, तो उसको पता पड़ जाता कि सुबह वो पानी ही देखने वाला है, तो उसको सरप्राइज नहीं मिलता। अब मैंने ये यहाँ क्यों बताया? कुछ तो रीजन रहा होगा। मेटा एनालिसिस की क्वालिटी किस पर डिपेंड करती है? कि जो स्टडीज उसमें जा रही हैं, अगर वो स्टडीज की क्वालिटी खराब हो गई, वही अगर बायस्ड है, तो रिजल्ट अच्छा मिलेगा? यस और नो? नहीं मिलेगा। तो अगर स्टडी की क्वालिटी खराब है तो मेटा एनालिसिस अल्टीमेटली खराब हो गया। तो दैट इज व्हाई वी आर असेसिंग द रिस्क ऑफ बायस। तो कोई भी अगर स्टडी में बायस है, इट कैन अंडर एस्टिमेट और एग्जैजरेट द रिजल्ट ऑफ योर मेटा एनालिसिस। एंड इफ यू हैव चेक्ड द रिस्क ऑफ बायस, इट विल इंप्रूव द क्रेडिबिलिटी ऑफ योर कंक्लूजन्स। नाउ हमने क्या क्या करा? सुबह से आप लोगों ने क्या क्या पढ़ा? बताइए एक एक पॉइंट। सबसे पहले क्या पढ़ा आपने? स्पीक अप, सोना नहीं है, स्पीक अप। रिसर्च क्वेश्चन बना लिया, इंक्लूजन एक्सक्लूजन क्राइटेरिया लगा लिया, रेफरेंसेस भी ऑर्गेनाइज हो गए, टाइटल स्क्रीन कर लिया, एब्स्ट्रैक्ट स्क्रीन कर लिया और फुल टेक्स्ट स्क्रीनिंग भी हो गई। अब जो स्टडीज फाइनल आ रहे हैं हमारे पास, उनको हमें उसमें रिस्क ऑफ बायस चेक करना है। तो अब क्या डोमेन्स है? मैंने आपको बताया ना, रॉ 1 में 7 डोमेन्स थे, रॉ 2 हैज 5 डोमेन्स। तो क्या 5 डोमेन्स हैं रॉ 2 में? फर्स्ट इज रैंडमाइजेशन प्रोसेस, सेकेंड इज डेविएशन फ्रॉम द इंटेंडेड intervention, third is missing outcome data, fourth measurement of the outcome, and fifth selection of the reported results. अब यही 5 डोमेन क्यों लिए गए? कुछ और क्यों नहीं लिया? और भी तो बहुत सारी चीजें होती हैं आरसीटी में, पूरी चेकलिस्ट है हमारे पास। तो बट हमको देखना है कि जो हमारा पूरा ट्रायल चला, दैट वाज फेयर और नॉट। कब देखना है फेयर? कि शुरुआत में फेयर था कि नहीं, एट द स्टार्ट ऑफ ट्रायल, when we were doing the trial, was it fair at that time, and when we were at the end of the trial, was it fair that time? तो तीनों टाइम हमको जज करना है। तो what these domains are telling? रैंडमाइजेशन कब करते हैं? रैंडमाइजेशन ट्रायल के स्टार्ट में, ड्यूरिंग या एंड में? स्टार्ट में। तो ड्यूरिंग स्टार्ट हमने रैंडमाइजेशन चेक कर लिया कि इट इज फेयर और नॉट। नेक्स्ट, डिविएशन फ्रॉम द इंटेंडेड इंटरवेंशन एंड द मेजरमेंट ऑफ आउटकम कब करेंगे हम? ड्यूरिंग द ट्रायल, जब ट्रायल चल रहा है तब ये सब चीजें करें। एंड लास्ट, मिसिंग आउटकम डेटा एंड सिलेक्शन ऑफ द रिपोर्टेड रिजल्ट्स, ये कब करते हैं हम? लास्ट में। तो इस तरीके से हमने स्टार्ट, ड्यूरिंग एंड एंड तीनों टाइम पे देखा कि इज द ट्रायल फेयर और नॉट, इज इट बायस्ड और नॉट। नाउ एक एग्जांपल लेते हैं, क्रिकेट मैच सबने देखा है, सबको पता है क्या टीम, क्या प्लेयर्स, क्या रन, क्या बाउंड्री। ठीक, हम कंसिडर करते हैं क्रिकेट मैच हमारी आरसीटी है। अब इसके साथ हम एक एक डोमेन पढ़ते हैं। डोमेन 1 क्या था? रैंडमाइजेशन प्रोसेस। तो रॉ टूल अभी मैं दिखाऊंगी आपको डेमो में। तो देयर आर सेट ऑफ क्वेश्चंस। तो क्या क्वेश्चंस पूछते हैं? रैंडमाइजेशन में पूछते हैं रैंडमाइजेशन हुआ कि नहीं हुआ, वाज द एलोकेशन कंसीलमेंट, और रैंडमाइजेशन हुआ ग्रुप्स बने तो वाज द बेसलाइन ऑफ द कैरेक्टरिस्टिक ऑफ द ग्रुप वाज सेम, सिमिलर और नॉट। ठीक है, तो हम क्या इससे कौन सा बायस हम हटा रहे? सिलेक्शन बायस, बाय चेकिंग द रैंडमाइजेशन। अब मैच में इसको कैसे हम साथ में ले सकते हैं कि हम मैच के स्टार्टिंग से पहले ही देख लें कि जो टीम्स का डिवीजन हुआ है,
इज इट फेयर और नॉट? पता पड़ा एक टीम में सब बॉलर्स हैं, एक में सब बैट्समैन हैं, तो दैट इज नॉट फेयर। तो हमने मैच के स्टार्टिंग से पहले ही अपने टीम्स को इक्वलाइज कर लिया। नेक्स्ट डोमेन है हमारा डेविएशन फ्रॉम द इंटेंडेड इंटरवेंशन। मतलब क्या? सिंपल लैंग्वेज, हिंदी लैंग्वेज, हम जो करना चाह रहे थे उसमें हमने वही किया या कुछ अलग कर दिया, या कुछ हम जो करना चाह रहे थे वो नहीं किया। तो क्वेश्चंस विल बी रिलेटेड टू दैट कि सिंगल ब्लाइंडेड है, डबल ब्लाइंडेड है, कोई नॉन प्रोटोकॉल इंटरवेंशन किया, या जो इंटरवेंशन करना था उसको मेजर किया या नहीं किया। तो कौन सा बायस हटाएगा ये? विच बायस? परफॉर्मेंस बायस। मतलब क्रिकेट मैच में हम टीम्स को अलग ही ट्रीट करें, एक टीम को 20 ओवर्स खेलने को मिल रहा है, एक को 25 देंगे हम, तो ये नहीं करना है। दिस इज परफॉर्मेंस बायस। कमिंग ऑन टू द थर्ड डोमेन, मिसिंग आउटकम डेटा। मिसिंग आउटकम डेटा मतलब कि हमने सोचा था कि हमारे पास 100 पार्टिसिपेंट्स हैं, उनका रिजल्ट हम निकालेंगे 50-50 डिवाइड करके, बट हमने क्या किया, 20 पार्टिसिपेंट्स चले गए छोड़ के। आप या तो आपने कोई ड्रग दिया, उसका एक side effect was there due to that drug, so 20 participants left the study, so there will be no outcome data for them. So which bias it is removing? Attrition bias, like patient drop out due to the side effect of the drug or any other reason. How we compare it to the cricket match? You played unfair with any of the teams, so some players of the team left the match, कि नहीं खेला हमको। Next, measurement of the outcome. So the question related to it, कि when the measurement was being done, was the method appropriate or not? In the two different groups, was the same method used or not to measure the outcome? Were the outcome assessor aware of the intervention given to the patients, like triple blind, like was the study triple blind or not? So which bias does it remove? Which bias? Speed detection bias. तो मैच में कैसे स्कोर बोर्ड वॉज नॉट ऑनेस्ट, लाइक वन प्लेयर स्कोर 2 रन तो स्कोर बोर्ड शोड 4 रन, वन प्लेयर स्कोर 1 रन तो स्कोर बोर्ड शो हाफ रन। तो अगर स्कोर बोर्ड ही डिसऑनेस्ट है, या फिर इन मैच एक टीम के लिए बाउंड्री छोटी कर दी, एक के लिए बड़ी कर दी, तो दिस इज कि आपने अलग अलग तरीके से आउटकम मेजर किया। कमिंग ऑन टू द लास्ट डोमेन, selection of the reported result, like the plan which we pre-specified, was the data analyzed according to that or not? बस कि जैसे सोचा था वैसे डेटा रिजल्ट दिया या नहीं। तो which bias does it remove? Reporting bias. क्रिकेट मैच में समझे तो सिर्फ हाइलाइट्स दिखा दिया, पूरा जिन्होंने खराब खेला मैच वो दिखाया नहीं, ओनली द 6 runs and 4 runs are being shown in the highlights. So I hope the 5 domains are clear. So what were the domains? First is randomization. Second is deviation from the intended intervention. Third is missing outcome data. Fourth, measurement of the outcome. And fifth, selection of the reported results. So these 5 domains you have to keep in mind while using the ROB tool. Now coming on to the output of ROB. How will it look like? When you will do the ROB 2 demo, then the output something looks like this, like either one of this, either this or this. So what is that? That is traffic light plot. Looks like traffic light plot, red, yellow, green. That is why traffic light plot. And the second one is summary bar chart. Okay, let's learn to interpret it. So when we will make the ROB output, it will look like study 1, all the 5 domains. Like we will be checking all the 5 domains in all the included studies. So these are the studies and these are the domains. And accordingly we will mark them these red, yellow, green. So what is red, yellow, green? Before that, like after filling the 5 domains, there is an overall column. Like for the complete study, after filling all the 5 domains, what you will analyze, like low, high or medium. So what these signals show? Red means there is a high concern or high risk of bias in that domain. Yellow means there is some concern. Green means low concern or low bias. And the last, blue, is no information, if there is no information related to the particular point in that domain. Now what's the golden rule for judgment? If all the columns are green like this, what will be the overall result? green, like no bias. But if one or greater than one column is with some concern, what you will say? Some concern. And if one or greater than one column is with high risk, you will classify it as high risk bias, high concern. What you are not supposed to do. For example, in this, if you think there are 4 columns with low bias and one with high concern, so you think I can average it and majority are green, so we can put it as green. No. If there is a one bad domain, it can sink the complete study. So it will be finally overall result will be high bias, high concern. Now this is the raw output from the SRMA which have been shared in the group. This is what they have given. Why they have given 7 domains? Because they have used the raw 1, 2. That's why 7 domains. Now we have taken out the output. Now what to do with the output? We got the risk of bias of the study. It may be high, it may be some concern, it may be low. So this data will feed into the GradePro in the coming step. In GradePro, one of the column is risk of bias. So whatever result you are getting from this step, you will feed it into risk of bias first column. Got it? Are we clear? So this was all about it, crop tool. So mind-blowing presentation? Yes or no? Or your mind is blown completely? Okay, let's start with the demonstration. I'll request every one of you to please open your laptops. And the link has been shared previously in the group, ROP tool. Or you can write ROP tool in the Google. खोला सबने ROP2 tool? Are we on this page? There is a column current version. You are supposed to open that only. Please respond to move or not. Then on the current version you have a column Excel tool to implement ROP2. Click on that. And after clicking on that, something like this will appear on your screen. You will have to save that file. Save it on the desktop only. Saved? Yes or no? Okay, so after you will open that file which we have saved on the desktop, yes? This one? This? You have to open Excel tool. Saved it? Now when you will open the file, something like this will appear on your screen. Is it coming? Okay, so there is a column ROP2 assessment form. When you will click on it, something like this will open. ROP tool. And if it is not opening, you might be seeing this thing on your screen. Is it? So demo team, I request all of you to please help the members. You will have to go to the right click on the icon and go to the properties and unblock the security. There is a dialog box, unblock. Done? After unblocking, apply the properties and again open the file. Is everyone done with this? Like, can you see this page on your desktop? Yes or no? Should we proceed now? You have applied the properties and then you have to reopen the file. Karan? Fine. So on this page you can see assessment ID, then the assessor. So what will you put in assessment ID? You will put any alphabetical and numerical combination to give that unique ID to that study, whichever you are checking. Then in assessor you will put your name. Study ID, name of the study in which you are checking the bias. Experimental and the comparator group. Then you will check like are you checking for intention to treat or per protocol. So you will drop down the box and there will be option for ITT and PP. So you will fill accordingly. Next up we have 5 domains which we are supposed to check in this ROP tool. We will click on one box and the questions related to it will come downwards. So how can we respond in this? There are basically 5 options. Y means yes, PY means probably yes, probably no, no and no information. Also there is a description box behind in which you can specify the reason why are you marking a particular answer. Next we have an algorithm result, like when you will fill all the domains, the computer will assess itself what is the quality of the study. So and after clicking on that you can write your judgment as well. Now let's take an example. Your 4 studies have been shared into the group already. So we will take the warden study. So for domain 1, what is it asking? What's the question? Allocation sequence random tha ya nahi? So in the article it is written clearly the participants were randomized in 2:1 ratio. So what we will put? Yes. Next question is allocation sequence was concealed or not? So in article it is written it was done by an interactive web response system. This itself means it was done by a allocation concealment method. So what are you going to put in this? Yes. Are you putting along with it? Like you have to fill all these details. Then next question is, what's the next question? Baseline differences between intervention group. So in groups you will see this baseline table. In these you will check the like major criteria you can check. Body weight is almost same in both the groups. BMI is same. Waist circumference is same. Hemoglobin also is same approximately. So what you will put in this? What's the question? Ki baseline differences between interventions suggest a problem? No, because there were no differences. So after this you will go to the algorithm. You will click on it. It will show low. Now it is your chance to put your judgment in this column. So if you feel it is low, you can put low. If you feel no, you feel some concern still, you can put it at that. And then you have to save this data. Are we done with domain 1? Next, coming on to domain 2. What's the first question and second question both? Dr. Shalini, can you please read the first and second question?
Ma'am, I'm unable to see the questions on my screen.
Like, did you see this window or not yet?
There is this window of domain 2, but these questions are not visible. Means they are not coming.
You might have opened something wrong. You have opened current version or the crossover trial version.
Now I am able to see.
What's the question? First and second question, domain 2.
First question is, were participants aware of their assigned intervention during the trial?
And second?
Second question is, were carers and people delivering the intervention aware of participants assigned the intervention during the trial?
So what does it mean? It is asking for a blinding of the study. Was it single blinded or double blinded? Thank you, Dr. Shalini. So in this article it is written it was a randomized double blind study. So what will be the answer? No. Next question become ineligible itself. The three questions become ineligible because we have put no in that. Is there any problem there? Like, is anything when you are not able to move along with? Dr. Tripti? Okay, so coming on to the next question, was an appropriate analysis was used to estimate the effect of assignment? So it is basically asking for intention to treat. So in article it is written clearly that it was similar to an intention to treat analysis. So we will mark it as yes. And then again the algorithm result, it will show low and you can put your result as well. And after that you will have to save the, don't forget to save the result at each step. Coming on to the next domain, domain 3, missing outcome data. So it is asking कि data सबके लिए available था कि नहीं, जितने भी patient randomized किए was the data available for all or not. So the data was there for approximately all the participants as shown in this flow chart. So we will mark it as yes. And then again the algorithm result is low and you can also put it as low and save the results. Moving on to the next domain, domain 4. The first question is, was the method of measuring the outcome inappropriate? So what is the outcome we are measuring in these studies? Weight loss. So was the there's very low chance that they will use some inappropriate method. So what we will put here? Probably no. Like it is not clearly written, but there are less chances there will be inappropriate method. So we will put PN. Next question is, could measurement of the ascertainment of the outcome have differed between intervention group? Like the method they have used to measure outcome is different between two groups? This is also probably no. Third question asks about the triple blinding of the study. Like were outcome assessors aware? Yes, because study was not triple blind, it was double blind. Next question, assessment of the outcome have influenced the knowledge of intervention received? No, because they are measuring the weight. That is the objective value. It is not subjective that will differ if we know the intervention. So the answer to this will be no. And then again you will click on the algorithm result. It will show low, but still if you feel there are some concern, you can mark it as some concern like I have marked here. Is it clear till now? Next, save the result. Move on to the last domain. Last domain, it is asking the data. The outcome was according to pre-specified plan or not. So the answer to the questions are yes, no and no as read in the article. So you have to clearly read the articles, then only you can answer all these questions. Again algorithm result low and assessor's judgment, I also judge it as low. Then saving the result. Next comes the final column, overall bias. Has everyone come to this step till now? Overall bias. Are you guys able to see something like this after filling the answers? Dr. Savita, is something like this coming on your screen? Okay. So now again there is a algorithm result. You can again put it as, you can again click it and it will show some concern according to the results of single domain. Then again you will put your judgment, it will show low and then you will have to save it. Done with all the domains, came to the overall result. after saving the result, something like this will open when you will close the window. So are you able to like move with this, sir? Are you able to like move this with this, like you have the same window on your screen? Yes. Yeah. Dr. Tripti, Himanshi. Dr. Himanshi, please head, sir. After you close the window, you will get this Excel sheet. Okay, after coming on this screen, there is a column like below the intro. You will click on that, and then there will be a sign of figures. When you will open it, it will show the result of the output which you have feed for the first study. Can you see something like this? Dr. Amit. So this is the result of the one study of which data we have just fit. Like this, you will feed the data for all the studies, and the traffic plot like this would appear on your screen. Next, when you click on the summary button, something like this will appear on your screen. Summary button. There is a right column, you will have to zoom in on that. And a summary chart will be formed. Like that was the traffic plot, and this will be the summary chart. So both the results we can make via this tool. So this was all about the raw output. Like after detecting the risk of bias, this data will go into which app? GradePro. What are we assessing? Risk of bias here. Thank you.
Now we understand that identifying bias is not a criticism, it's a scientific responsibility. Thank you, Dr. Diksha. Your valuable inputs have enriched our understanding of the topic. After assessing bias, now it's time to convert individual study results into one powerful combined conclusion. But how? To clear this doubt, Dr. Vyaktika Shri is here with our next topic, RevMan.
गुड आफ्टरनून एवरीवन. कैसा लग रहा है? अभी तक कुछ समझ में आया? थोड़ा बहुत. देखिए, रेवमैन में आपको अपना लैपटॉप यूज करना पड़ेगा. विदाउट लैपटॉप कुछ भी समझ में नहीं आएगा. इट विल बी यूजलेस. सो प्लीज काइंडली ओपन योर लैपटॉप. आई हैव शेयर्ड द लिंक फॉर डाउनलोडिंग इट. इंस्टॉल इट. Dr. Tripti, Dr. Pratibha, Dr. Himanshi, Dr. Snehashri, Dr. Fatima, they will all help you for installing and running the app. Kindly install it first. अमित आगे चेक कर लो इंस्टॉल्ड है कि नहीं सब में। हाँ मैं भी आऊँ। स्टार्ट करो। Shall we start? Karan, can you help? Okay. Let's start. So we will start with the story. Silence please in the back. First, where this step fits in. This step is statistical analysis because we will use stats in this while filling the data in the RevMan. So just imagine you are standing in a jungle. आप सभी लोग एक जंगल में खड़े हो, ठीक है? In that jungle, there are different kind of trees. Some are apple, some are neem, कुछ बरगद के पेड़ हैं, कुछ अमरूद हैं, कुछ bushes हैं, ठीक है? So, for example, just imagine neem as a preclinical studies, banyan as a case reports, apple as observational studies, and mangoes are the RCTs. Now, assume कि आपको इस सीजन का बेस्ट मैंगो चूज करना है, यू वांट टू सेलेक्ट कि बेस्ट क्वालिटी मैंगो कौन सा है, ठीक है। और ये जो जंगल है दैट इज द ऑल पब्लिश्ड लिटरेचर। लेट्स अज्यूम दैट आवर ऑब्जेक्टिव इज टू स्पेसिफाई एसेस द क्वालिटी ऑफ मैंगोज। तो आप क्या करोगे, सारे पेड़ देखोगे या सिर्फ मैंगोज के पेड़ देखोगे? रिप्लाई करना है ऐसे ही, ठीक है, तभी वो समझ में आएगा। सो वी विल रिमूव दिस नीम, एप्पल एंड क्या बचेगा, सिर्फ मैंगो, दैट इज RCTs। सो SRMA में ऐसा नहीं है कि सिर्फ RCTs का होता है, ऑब्जर्वेशनल भी होता है, बट वी आर फॉर एग्जाम्पल टेकिंग हियर एज RCTs। नाउ टेल मी, इज एवरी मैंगो ट्री यूजफुल? क्या हम हर एक मैंगो के पेड़ को देखते जाएंगे जंगल में? यस और नो? नो। सो नाउ we walk inside the jungle with the filter, that is inclusion and the exclusion criteria, ठीक है। inclusion exclusion criteria लगाते हैं, आपने प्रोटोकॉल भी लिखे होंगे, सेम वैसे ही है, ठीक। now only mango trees matching the criteria will be selected, all others will be excluded। now we have started collecting the mangoes, each mango has one RCT, okay। कुछ मैंगोज बहुत मीठे होंगे, कुछ खट्टे होंगे, कुछ कच्चे होंगे, ठीक है। What I mean to say कि some studies have large effect, some studies have small effect, and some studies have no effect, ठीक भाई। So since one mango cannot represent the entire season, one RCT cannot represent the complete evidence. Getting my point? Reply yes or no? So if one study says semaglutide reduces weight by 13%, क्या आप इसको मान लोगे? No. Can we conclude the truth? No. So same, क्योंकि एक स्टडी लार्ज इफेक्ट शो कर सकती है, एक स्टडी नो इफेक्ट शो कर सकती है, and another may show small effect. So on average, what is the true effect? उसके लिए हम क्या करेंगे? For that we pool all the mangoes, that is we pool all the RCTs and we put it where? In the review manager. Review manager is a app, हम लोग उसको शॉर्ट में बोलते हैं RevMan। अब now जो RevMan मेन होता है दैट इज पोखरेन का होता है, वो वेब बेस्ड होता है, जो अभी करंट है रिव्यू मैनेजर 7, ठीक है, बट दैट इज पेड वर्जन। फ्री इज देयर, 30 डेज क्लिनिकल ट्रायल फ्री है, बट उसमें आप डाटा एक्सट्रैक्ट नहीं कर सकते, ठीक है। सो फॉर प्रैक्टिस पर्पज एंड फॉर एक्सट्रैक्टिंग द डेटा वी आर यूजिंग RevMan 5.4.1, that is a desktop based version which I have shared the link with you guys. So Review Manager is a software developed by the Cochrane collaboration for preparing and maintaining systemic reviews and conducting meta-analysis. RevMan 5.4.1 was the last Dept.of version based on Cochrane systemic review software. It allows users to perform meta-analysis, generate forest plot and assess risk of bias in systemic reviews. तो meta-analysis करने के लिए, forest plot generate करने के लिए इसमें आप ROB भी कर सकते हो, but this is old version, तो इसमें जो domain है ROB 1 है, 7 domain वाला है, ROB 2 वाला नहीं है। RevMan वेब कुछ ऐसा से दिखता है, यहाँ पे लिखा हुआ है दिस इज यू कैन नॉट एक्सपोर्ट रिव्यू डाटा फ्रॉम अ प्रैक्टिस रिव्यू, ठीक है। 30 डेज का फ्री ट्रायल है, बट आप इसमें से एक्सपोर्ट नहीं कर सकते डाटा। अब RevMan करता क्या है? सबसे पहले RevMan सब कुछ करता है, प्रोटोकॉल लिखने में भी हेल्प करेगा, आपके फॉरेस्ट प्लॉट बनाएगा ही, देन it will create review structure, add comparison outcomes, enter continuous and dichotomous data, generate forest plot, perform subgroup analysis, conduct sensitivity analysis, create risk of bias tables and generate summary of findings in RevMan web, not in this one. Now everyone has installed. So open करने पे ये आ रहा है सबका, प्लीज टीम जो भी टीम है वो हेल्प करे, ठीक है। अमित, तृप्ति, करण, स्नेहाशीष, ठीक है। इस पे सारा एक एक स्क्रीनशॉट है, बस आपको स्क्रीन पे देखना है एंड क्लिक करना है। आई विल रीड इट। सबसे पहले व्हाट वी आर डूइंग, क्रिएट अ न्यू रिव्यू, ठीक है। एंड बिफोर स्टार्टिंग दैट आई वुड लाइक टू नो कि हम लोग जो मैंने पेपर शेयर किया था SRMA वाला, उसमें एक आउटकम का हम सिर्फ देख रहे हैं, ठीक है, दैट इज परसेंटेज। पढ़ा है किसी ने पेपर? Anyone have read this paper? What we are looking for? Where percentage body weight reduction, ठीक है, just we are doing one outcome, उसका हम forest plot देखेंगे कैसा बन रहा है, we will make it here only, ठीक है, you have to enter the data in your laptops. So we will create a new review, click on a new review, then next then go to intervention review. What kind of study is this intervention phase? Now we are giving semaglutide. Next, now what is the title of the review? Anyone? Title of the review, sir? What is the title of the review? Anyone from the back? Safety and efficacy. Yes, Savita? It was efficacy and safety of semaglutide for obesity in non-diabetes patient. ठीक है? So we will fill semaglutide versus placebo for weight loss in non-diabetic obese. Kindly fill. Can we proceed? Done? Yes. Now next, which stage should we review the start in? Are we writing the protocol or are we writing the full review? We are writing full review. So you will click on the full review and finish. Something like this came up. ये आ गया. Now this side, this is outline pane. इसको हम लोग outline pane बोलते हैं. This is content pane. यहाँ पे आप सब कुछ टाइप कर सकते हो, from authors, abstract, background, objectives, aim, everything can be written here. Like you have made a Word file, you can paste it here. This thing, ये थोड़ा सा बता देती हूँ क्या होता है. First, ये वाला जो है, this is new file. This is open folder. Third one is save file. ठीक है, तो आप जब भी हर स्टेप पे प्रोसीड करेंगे, you have to save this file and ये प्रिंट करें. So we are here. So kindly save. Click on save. Go on save as. Are you not getting it? Save as semaglutide versus placebo on desktop. Everyone saved? Okay. Next, ये कीज दिखाई दे रही हैं आपको, the small keys. If this is vertical, if this key is vertical, it means कि आप जो है ये maximum आप में नहीं आ रहा. हिमांशु देखना. If these are horizontal, it means it is maximum open. If this is vertical, तो जब क्लिक करेंगे तो ये और ओपन हो जाएगी. ठीक. Next, we are going to add studies. Kindly click on tables. After that, characteristic of studies, characteristic of included studies, and right click on that. Right click on the characteristic of included studies and then add study. Is this coming? So our first study is ONEIL 2018. I have shared 4 RCTs with you guys. The first study is ONEIL 2018. Kindly type this name. Done? ONEIL 2018. Next, what is the data source? Which type of source for the study data obtained? Data हमने कहाँ से लिया है? That is published data. Next, Tripti. Next year अपने आप डिटेक्ट कर लेगा. You can enter manually also. 2018. Next, does the study have other identifiers you wish to add? अभी हम नहीं ऐड कर रहे हैं. You can add. Next, now it says wizard is completed. What do you want to do after the wizard is closed? We want to add another study because we have 4 studies. Continue. Now add all the studies like you have added with the ONEIL. Kindly do it within 5 minutes. Can we? सबका हो गया? सबने ऐड कर ली स्टडीज? नेक्स्ट, काइंडली क्लिक ऑन सेव. सेव करते जाइए सब. जस्ट क्लिक ऑन सेव. Next, coming to data analysis. So for filling the data, in the last, kindly maintain silence. For filling the data, you should have a little knowledge about stats. Basic stats you should know. So starting with data analysis, click on data analysis. Left click, add comparison. After, What is the comparison name? We are comparing semaglutide versus placebo. Next, what do you want to do after the wizard is closed? Add an outcome under the new comparison or add another comparison. So we are doing only one comparison. So we will add an outcome under the new comparison. Then continue. Now, what type of outcome do you want to create? Anyone, any have idea what is dichotomous, what is continuous, what is OE, GIV and other data? Anyone? Geometries? So, coming to dichotomous data. थोड़ा बताऊंगी मैं overview. So, dichotomous data are outcome in the two possible categories. Either event has happened or not happened. Yes or no. Next is continuous data. Outcome measured on a numerical scale. मतलब body weight हो गया, height हो गया. That is continuous data. OE and variance. It is used in time to event survival data. कब use करते हैं हम लोग? When it is given log hazard ratio, OE value और variance. ये आप लोग को घर पे जाकर खुद पढ़ना पड़ेगा तब ज़्यादा अच्छे समझ में आएगा. I can't explain it. Then GIV. GIV is used when study reports effect estimate, that is MDRR/OR, or standard error plus 95% confidence interval, और raw data नहीं है mean plus minus standard deviation का. तो किसी ने पेपर पढ़े हैं चारों? नहीं पढ़े हैं, मैं बता देती हूँ. उसमें mean plus minus standard deviation नहीं दिया हुआ है. So in this case we are going to use GIV because standard error और 95% confidence interval दिया हुआ है उसमें. ठीक है. And next क्लिक करें. GIV क्लिक करने के बाद next. Now, what name should the outcome have? Outcome का name क्या है? Weight loss. Group label 1 is semaglutide and group label 2 is placebo. Next. Now statistical method उन्होंने खुद choose कर लिया है, that is inverse variance. Now coming to analysis model. Analysis model कैसे use करते हैं? Anyone have any idea about fixed effect random effect? So fixed effect कब use करना है? When we have the same population, same dose, same follow up. 3 चीजें, same population, same dose and same follow up. Random effect कब यूज करना है? When we have different follow up, different countries या फिर different baseline risk, different dosage, then we will use random effect. अब fixed effect में जो confidence interval, जो डब्बा होता है, black box होता है, जो उसके बगल में line होती है, first part में आप पढ़ेंगे, that is narrower, and in random it will produce wider confidence interval. So in our study, we will choose random effect. Why? Because first dose अलग अलग है, कोई 0.4 दे रहा है, कोई 0.6 mg semaglutide दे रहा है. Then जो follow weak है, किसी में 52 है, किसी में 60 है. So that's why we will use random effect. Now coming to effect measures. अब कब क्या choose करना है? RR, OR, RD, mean difference, SMD. I am going to tell about MD and SMD. Rest मैं आप PDF share कर दूँगी. So, choose analysis model पे random effect. Okay, next is effect measure. So mean difference और SMD कैसे choose करना है? Mean difference is absolute difference between means of two groups measured on the same scale. जैसे कि यहाँ पे हम लोग weight loss है. Weight loss we are measuring in kg in all the 4 papers. If it was in pound or lbs, so we would have used SMD. ठीक है? Effect size, what is SMD? Standardized mean difference. Effect size used when studies measure the सेम आउटकम यूजिंग डिफरेंट स्केल्स. सो आपको डिसाइड करना है, तो अगर सेम स्केल है तो हम मीन डिफरेंस यूज करेंगे, डिफरेंट स्केल है तो हम क्या करेंगे, एसएमडी यूज करेंगे. गुड आफ्टरनून. पीछे अनूप एंड नितिन, गुड मॉर्निंग. हाँ, सो प्लीज अभी तो स्टार्ट हुआ है, ठीक है, थोड़ा स्ट्रेच इट आउट कर लो. ठीक, शुड वी कंटिन्यू? 2 मिनट ब्रेक. In effect measure, we will choose mean difference. Next, this screen will come. इसमें ऑटोमेटिकली अपने आप वो चूज रहता है. ऐसे नॉर्मली हम लोग 95% कॉन्फिडेंस इंटरवल ही लेते हैं. No one is going to take 99 and 90 is very less. So we take 95% confidence interval. In the last, you have to tick this tick box. Enter number of participants GIV for display only. Kindly click this tick box. हिमांशी सबको देख लेना, टिक करते हैं ना वो लोग, ठीक है. नेक्स्ट, दिस थिंग इज कमिंग. इसमें सिर्फ नेक्स्ट कर देना है. नाउ टू एडिट अदर प्रॉपर्टीज फॉर द आउटकम, ओपन प्रॉपर्टीज फॉर द आउटकम आफ्टर क्लिकिंग फिनिश. So what we want to do in this, we want to add study data for the new outcome. We are going to add study data for the new outcome. Click on this and then continue. ये खुला? Amit check. ये आ गया. Now you have to select all the studies. For that you have to hold control and drag all. अमित बता देना एक बार. Selected all. Now next, click on finish. डुप्लीकेट करना है इसको. This is filled one, you don't have to be filled. I'm just showing that these cursors can be moved. These cursors can be moved. you have to set this forest plot wala cursor in the center. Kindly set in the center. Now click on this. I mean यहाँ पे है ये दिख रहा है एरो, ये दिख रहा है ना, कर्सर दिख रहा है ना, यहाँ पे छोटा सा एक एरो बना हुआ, उस पर क्लिक कर दोगे तो पूरी स्क्रीन खुल जाएगी ऐसे। हो रहा है मांझी हेल्प? Now we will add, click on save, save कर लीजिए इसको प्लीज। Can you see these things? First is for add study. Second, you can change the model from here also. RE is for random effect. If you click it or don't click right now, if you click, it will come fixed effect. Next is for the generation of the forest plot. Next is for generation of the funnel plot. Next is the calculator, and next is for the ROB, risk of bias. Okay. Now we will fill the data. So अभी स्टार्ट का हो गया, अब मेन काम जो है अब शुरू होगा। ठीक है गाइस, इन द बैक शालिनी एंड दीपा, समझ में आ रहा है थोड़ा थोड़ा? ठीक है। Let's add study data. ठीक है। For that, what do we need? We need thoroughly read individual papers which you have not done. Right? Papers नहीं पढ़े ना किसी ने? Yes or no? ठीक है। So what we are going to look for in each paper. अगर पढ़ते भी तुम्हें क्या देखते? मैंने बोला था result and methods पढ़ने के लिए. So we are going to look for mean difference, standard error and number of participants in each group. These three things we want to fill. So first paper is O'Neill 2018. ठीक है, I have highlighted. इसमें लिखा हुआ है the estimated mean weight reduction from baseline to 52 weeks for participant receiving semaglutide escalated to final dose on 4 weekly schedule range from 6 to 13.8%. समझ में आया कुछ? नहीं. And 2.3% for those receiving placebo. 13.8% जो था वो semaglutide था and placebo के लिए 2.3%. दोनों का standard error is given 0.83 and 0.74. Now we have to do some calculation which I am not going to explain here. I have put the formulas. You can take screenshots or whatever. So mean difference standard error के लिए हमारे पास data ये है, semaglutide 13.8, standard error is 0.83, n is 102. Placebo के लिए mean is minus 2.3%, standard error is 0.74 and n is 136. So first we will calculate the mean difference. Mean difference simple है, subtract करना है intervention minus control. So you will calculate, it will come minus 11.5. ठीक. Next is standard error of the mean difference. This is the formula. You can calculate and it will come to 1.1. So now we have to fill it. So fill the values please. In O'Neill, mean difference is minus 11.5 and standard error is 1.11. In semaglutide, total number of participants is 102 and in placebo it is 136. डॉक्टर साहब आप कर रहे हैं, ब्लू शर्ट कर रहे हैं आप साथ में? ओके. नेक्स्ट इज रूबिनो. काइंडली क्लिक ऑन सेव. नेक्स्ट इज रूबिनो. रूबिनो में दिया हुआ है पेज नंबर 22. Estimated mean body weight change from 0 to 68 week was minus 17.4 with semaglutide versus minus 5 with placebo. and 95% confidence interval दिया हुआ है 13.7 to 11.0. So we will use the formula for calculating the standard error. This is the formula, upper limit minus lower limit upon 2 into 1.96, that is 3.92. ठीक है. So standard error is 0.69. ठीक. Mean difference was already given. Minus 12.5, 12.4 is the mean difference. Kindly fill it in Rubino. Minus 12.4 is the mean difference and 0.69 is the standard error. Number of participants in semaglutide is 535 and in placebo is 268. थोड़ा बहुत फॉल्स प्लॉट बना किसी का साइड में कुछ दिख रहा है? Yes or no? Next is Vadin. Kindly click on save. In Vadin paper, page number 15, they have given in tabular form that N is 407, the body weight percentage reduction is minus 16 in the semaglutide, in placebo it is minus 5.7, when you will minus it will come around 11.4, and the 95 confidence interval is minus 12 to minus 18.6. So standard error is 0.87. Now we will fill in Vadin. Kindly fill. Minus 10.3 is the mean difference in Vadin 21. Standard error is 0.87. Total number of participants in the semaglutide is 407 and in the placebo is 204. ठीक है? Can we proceed to the next study? Kindly click on save. Next is Winding 2021. इसमें दिया हुआ है percentage body weight change from baseline to week 68 is minus 14.85 and minus 2.41 for placebo. 95% confidence interval is 13.37 to 11.51. We will calculate and we will get the value. Standard error is 0.48. So for Vadin, for building 2021, fill 12.44. Standard error is 0.48. Total number of participants in semaglutide is 1306 and in placebo is 655. So the table is filled now. Can you see something like this? दिख रहा है ये? मैम पढ़ा के गई हैं अभी, दीक्षा मैम कुछ बताया था उन्होंने, हेट्रोजेनिटी क्या होती है, ठीक है? सो वही सब यहाँ पे आपको कैलकुलेट नहीं करना पड़ा, ये अपने आप ही हो गया. साथ में दिस थिंग मीन डिफरेंस, ये सब भी अपने आप कैलकुलेट हो गया. एंड द नेक्स्ट थिंग दिस फॉरेस्ट प्लॉट, ये बन गया. ठीक है? यू कैन नॉट मेक इट विद द हेल्प ऑफ AI, यू कैन मेक, बट कैसे पता लगेगा कि सही बना है कि नहीं सही बना है? इसलिए वी यूज दिस काइंड ऑफ एप्स. दिस इज द फॉरेस्ट प्लॉट. नाउ ये पूरा दिख रहा है आप लोग को, ये पेन विंडो पेन की दिख रही है पूरी, ठीक है? काइंडली क्लिक ऑन सेव. नाउ गो टू दिस फॉरेस्ट प्लॉट वाला आइकॉन, क्लिक ऑन फॉरेस्ट प्लॉट. यू कैन, यहाँ से आप इसको प्रिंट कर सकते हो, कॉपी कर सकते हो, सेव कर सकते हो एंड देन यू कैन पेस्ट इट ऑन योर आर्टिकल विच एवर यू आर राइटिंग. ठीक है? वहां पे आप इसको पेस्ट कर सकते हो. सो ये ऐसा आपको ब्लैक दिखेगा. ठीक? नाउ वी विल कंपेयर इट विद द स्टडी विच हैव शेयर्ड. SRMA वाली जो मेन स्टडी है उससे हम कंपेयर करेंगे. ठीक? नाउ टेल मी व्हाट इज द डिफरेंस. Yes sir, can you stand up please? Can you tell me the difference? Don't stand up, just tell me the difference between these two. So it's okay, कोई बात नहीं. इसमें हमने स्टैंडर्ड एरर यूज किया है एंड जो पेपर जिन्होंने मेटा एनालिसिस की है उन्होंने उसमें स्टैंडर्ड डेविएशन यूज करी है. व्हाई वी यूज स्टैंडर्ड एरर? बिकॉज हमें उनका रॉ डेटा नहीं मिला. उन्होंने किया होगा, उन्होंने ऑथर से लिया होगा रॉ डेटा, बट हमारे पास रॉ डेटा नहीं था. That's why use the standard error. As you can see, results are almost similar. ठीक है, heterogeneity is 0.39, यहाँ पे 0.40 है, chi-square is 5.2, यहाँ पे 5.2 है, and the forest plot is also somewhat similar. ठीक है. Now you can export this file as CSV file for further use in other apps like GradePro, but GradePro में अभी जो RevMan वाली फाइल चलती है जो मैंने आपको ऑलरेडी सेव करवा दी है. ठीक है. एक्सपोर्ट में जाके डेटा एनालिसिस, वहाँ पे डेटा एनालिसिस क्लिक करके नेक्स्ट जाके ये ऑटोमेटिकली फिल हो जाता है. नेक्स्ट and you have to click finish, save it on the desktop. This is the CSV file, comma separated files, and save. This file will be used further, so kindly save it. कर लिया सबने सेव, जो भी यूज कर रहे हैं सबने सेव कर लिया, yes or no? Saved? अब इट्स ओवर, खत्म हो गया. ये नहीं हुआ है, अभी नहीं हुआ है. दिस इज नॉट द एंड अभी. ठीक है. वी सेलेक्टेड द मैंगोज, वी कलेक्टेड इट, वी कंबाइंड इट, एंड वी हैव क्रिएटेड अ फॉरेस्ट प्लॉट, दैट इज अ डायमंड. वी हैव गिवन द वर्डिक्ट. सो फॉरेस्ट प्लॉट सबको आता है इंटरप्रेट करना? कैसे इंटरप्रेट करते हैं? No, we did not understand the verdict. Okay, so let's now understand how to interpret forest plot. For that, I will call Diksha Gupta, Dr. Diksha Gupta. Can you please continue? Thank you.
Good afternoon again. I'm back. Okay, so quite a brainstorming session. फॉरेस्ट प्लॉट बनाना सीख लिया? कर सकते हैं. बहुत difficult था, but still we can do it. बना तो लिया. Now can you interpret it? Can you read it? For that, I'm here to help you. So first, what is forest plot? क्या है? एक graphical tool, एक visual summary, meta analysis की studies की. Like हम एक बार में देखें, एक glance में, and हम उसका रिजल्ट को एनालाइज कर सकें. व्हाट इज मेटा एनालिसिस ऑल अबाउट, ऑल्सो नोन एज, व्हाट्स द अदर नेम, ब्लॉबोग्राम. सो लेट्स टेक एन एग्जांपल ऑफ दिस फॉरेस्ट प्लॉट व्हिच आई हैव टेकन इन द फर्दर स्लाइड्स टू एक्सप्लेन एंड टू इंटरप्रेट. सो स्टार्टिंग विद द इंटरप्रिटेशन. सो दिस we'll divide the forest plot in these areas. This is the main forest plot, the center part, this is the left and this is the right. So starting with the left side of the plot. What left side contains? This is the author name, like primary author of each study which is involved in the meta-analysis will go on the left side. Which side? Left side. What it is going? Primary name of the primary author of each study. Okay. Along with the, what is this? Publication year, in which year the study was published. Next we have cases and controls, like both the groups we have to specify the numbers. ठीक है, तो क्या क्या हो गया लेफ्ट साइड में? पहला प्राइमरी नेम, प्राइमरी ऑथर हो गया, पब्लिकेशन ईयर हुआ, एंड केसेस एंड कंट्रोल्स का नंबर हो गया. नाउ कमिंग ऑन टू द राइट साइड ऑफ द पार्ट. व्हाट डज राइट साइड इंडिकेट? राइट साइड, you can see in this example something is written out, some numbers are written outside the bracket and then in bracket two numbers are written. So it denotes the point estimate. The number outside the bracket denotes the point estimate. What is point estimate now? True effect of the result. किसी भी study का जो result आएगा हम उसको एक value दें तो वो क्या वैल्यू होगा? दैट वुड बी पॉइंट एस्टिमेट. एंड देन व्हाट इज इन द ब्रैकेट? दैट इज कॉन्फिडेंस इंटरवल. यूजुअली इन स्टडीज वी आर टेकिंग 95% कॉन्फिडेंस इंटरवल. अब कॉन्फिडेंस इंटरवल क्या होते हैं? एनीवन नोस? एक रेंज. 95% CI is the range in which the result will lie. मतलब true value is, like for first example, true value is 1.3, but the result of study can lie between 0.5 to 2.6. 95% of the time the result will lie between these two values. So this is the right side of the forest plot. Now coming on to the main interpretation area, the center part. Now इसमें क्या क्या है? इसमें एक vertical axis दिख रहा है, yes or no? फिर एक हॉरिजॉन्टल एक्सिस है नीचे, फिर ये मल्टीपल लाइंस दिख रही हैं, हॉरिजॉन्टल लाइंस, उनके ऊपर एक स्क्वायर या ब्लैक बॉक्स आप बोल सकते हैं वो बना हुआ है. एंड देन एक लास्ट में आपको क्या दिख रहा है? डायमंड. एक वर्टिकल एक्सिस, एक हॉरिजॉन्टल एक्सिस, मल्टीपल लाइंस हो गए, उसमें स्क्वायर्स हो गए, और फिर नीचे एक फाइनल डायमंड. फाइन. अब एक एक करके कि क्या है. अब वर्टिकल एक्सिस, वर्टिकल एक्सिस बताती है लाइन ऑफ नल इफेक्ट. ठीक है. अगर लाइन ऑफ नल इफेक्ट क्या है पहले, कि उस वैल्यू का मतलब कि कोई भी एसोसिएशन नहीं है बिटवीन एक्सपोजर एंड आउटकम. तो अगर हम रिलेटिव स्टैट्स ले रहे हैं अपनी स्टडी में, जैसे ऑड्स रेशियो या रिलेटिव रिस्क, तो वैल्यू क्या रहेगा उसका? 1. उस लाइन पे वैल्यू आएगा 1. और अगर हम एब्सोल्यूट स्टैट्स लेंगे, जैसे कि एब्सोल्यूट रिस्क रिडक्शन या स्टैंडर्डाइज्ड मीन डिफरेंस, तो वैल्यू विल बी 0. तो इट माइट वेरी 1 or 0 according to the stats. This is all about vertical axis. Coming on to the horizontal axis. Horizontal axis पे जो भी हमने stats लिया उसका scale होगा 1 2 3 4 -10 -20 whatever the stats we have taken, उसका scaling होगा. अब ये lines क्या हैं? Lines क्या represent करती हैं? Separate studies which we have taken in the meta analysis. मतलब जितनी lines का मतलब क्या होगा, उतनी ही स्टडीज ली गई हैं. इस एनालिसिस में कितनी स्टडीज ली गई हैं? काउंट द नंबर ऑफ लाइंस. 5. तो मतलब इस स्टडी में इन लोगों ने 5 RCTs लिए थे या 5 स्टडीज लिए थे जिनका उन्होंने मेटा एनालिसिस किया है. तो सेपरेट लाइंस हो गए. अब इस लाइन के दो कंपोनेंट हैं, एक तो लाइन है और एक उसके ऊपर क्या है? स्पीक अप. क्या है? लाइन है और उसके ऊपर क्या है? स्क्वायर या ब्लैक बॉक्स. ठीक है. तो अब इनका क्या मतलब है? ब्लैक बॉक्स की पोजीशन उस स्पेसिफिक स्टडी का रिजल्ट बताती है. मतलब उस स्पेसिफिक स्टडी का पॉइंट एस्टिमेट क्या था, उसका पोजीशन डिनोट करेगा. राइट में जाएगा तो वैल्यू चेंज होगा, लेफ्ट जाएगा तो वैल्यू चेंज होगा. एंड द साइज ऑफ द स्टडी ऑफ ब्लैक बॉक्स के साइज से पता पड़ेगा. जितना बड़ा स्क्वायर होगा मतलब मोर वेटेज टू द स्टडी, मतलब सैंपल साइज वॉर मोर, और जितना छोटा स्क्वायर होगा उतना सैंपल साइज कम है. नाउ लाइन क्या बताता है? लाइन बताता है कॉन्फिडेंस इंटरवल. लाइक स्क्वायर तो हो गया पॉइंट एस्टिमेट बताने के लिए, जो लाइन का रेंज है वो बताएगा 95% कॉन्फिडेंस इंटरवल. तो अगर लाइन लॉन्ग है, लॉन्गर लाइन मतलब कि रिजल्ट डिस्पर्स कर रहे हैं उस पूरे डेटा में, तो मतलब वो स्टडी लेस प्रिसाइज है. और अगर लाइन शॉर्ट है तो मतलब स्टडी इज मोर प्रिसाइज. फॉर एग्जाम्पल ये 3 स्टडीज हैं, तो क्या लगता है किसका सैंपल साइज ज्यादा रहा होगा इसमें से? बोलो बोलो. लास्ट वाले का. और कौन सी ज्यादा प्रिसाइज रही होगी? फर्स्ट या थर्ड? थर्ड. लाइन जितनी छोटी उतना प्रिसाइज स्टडी, उतना डिस्पर्जन कम है रिजल्ट्स का. तो एज वी मूव डाउन, वेट ऑफ द स्टडी इंक्रीजेस एंड द प्रिसाइजनेस आल्सो इंक्रीजेस. नाउ अगर कोई भी स्टडी वर्टिकल लाइन को क्रॉस करती है, लाइन ऑफ नल इफेक्ट, दैट वाज द वर्टिकल एक्सिस. So if any study is crossing that line, the study becomes statistically insignificant. For example, in this, the first study, the second study and the third study, all these studies, the line is, they are touching the vertical axis. So all these 3 are statistically insignificant. तो क्या क्या पार्ट्स पढ़ लिया हमने? लेफ्ट साइड, राइट साइड, वर्टिकल एक्सिस, हॉरिजॉन्टल एक्सिस, स्ट्रेट लाइंस विद द बॉक्स. क्या रह गया पढ़ने के लिए? Diamond. Now what is diamond telling about? Diamond is the pooled effect of all the studies. Like the individual's line were telling the effect of each study. Diamond tells the pooled effect of all the studies. So the vertical line which is passing through the vertical points of the diamond tells about the point estimate of all the studies average. and the horizontal distance between the diamond. Horizontal distance between the horizontal ends of the diamond tells about the 95% CI. Individual studies में confidence interval किससे पता पड़ रहा था? Length of the line से. Yes or no? Diamond में क्या पता पड़ते हैं? Horizontal ends के through हम पता करेंगे what is the confidence interval. Now, if diamond also crosses the line of null effect, the vertical axis, for example, if the diamond would have been at that place, the whole meta-analysis would have been insignificant. So if diamond touches the line of null effect, the entire study is waste. Now, does the size or shape of the diamond matter? For example, diamond could have been like this or like this. दोनों में से किससे फर्क पड़ता रिजल्ट पे? फर्स्ट या सेकेंड? सेकेंड. लेट्स सी व्हाई. तो अगर फॉरेस्ट प्लॉट में डायमंड फर्स्ट ऑप्शन की तरह होता तो वर्टिकल पॉइंट तो सेम ही जगह पे लाई कर रहे हैं, हॉरिजॉन्टल में डिस्टेंस चेंज ही नहीं हुआ, तो पॉइंट एस्टिमेट इज स्टिल द सेम. बट इफ द डायमंड वुड हैव बीन ऑफ सेकेंड काइंड, द हॉरिजॉन्टल एंड्स हैव स्प्रेड आउट, सो द कॉन्फिडेंस इंटरवल ऑफ द स्टडी हैज changed. So the size and shape of the diamond matter, but in only second case. Now coming on to the effects. So in studies it is usually written at the base, there's a line of null effect, and on the one side it says favors control and on the other side it says favors intervention. So on whatever side the squares, the boxes or the diamond is, it tells about that. Like in that study, in this study, it shows the whatever study has been done, it is favoring intervention, not the control. So there, this is the direction effect only, like one side control and one side intervention. Coming on to heterogeneity, so we can tell about the heterogeneity by just seeing the forest plot. कैसे? पहले तो heterogeneity होता क्या है? Anyone knows about heterogeneity? Like you can understand by the term itself, heterogeneous मतलब same नहीं है. जितनी भी studies include की गई हैं, the result of the studies is not similar or same. So जब आप उनको pool करोगे तो उनका effect, अगर बहुत heterogeneous studies है, like very different studies were including in the meta-analysis, the result will not be that robust. So how are we measuring heterogeneity? So there are two types, chi-square test and I-square. Chi-square measures if the heterogeneity is by chance. Chi-square is for if the heterogeneity is by chance. That depends on the p-value. If p-value is smaller, like as the smaller p-value goes, significant heterogeneity is there. If p-value is larger, the heterogeneity is by chance. Coming on to the next, I-square. I-square denotes the heterogeneity which is not by chance. It is due to real differences. So we will check for the values of I-square. If it is less than 25%, that means the study is low heterogeneity. I-square 25 to 50%, moderate heterogeneity, and I-square greater than 50% is, speak, 25% is, less than 25% is low heterogeneity, 25 to 50 is moderate, and greater than 50% is high. मतलब studies vary करते हैं आपस में ही. Now for example in this, the squares are spread along both the sides of the graph and they are widely spaced. तो मतलब ये high heterogeneity है इसमें studies में. Whereas in this case, the squares lie nearby only. So this is a study of low heterogeneous data. Now अब हम use क्यों कर रहे हैं forest plot? First visual summary मिला study को देख के ही. Then we can see the effect size of each study, like what is the point estimate of each study, what is the true result of each study. Next we can compare by the direction of the graph, like which is better, control is better or the intervention is better. And we can know the overall pooled effect and heterogeneity. For example, this was the forest plot given in our SRMA. तो इसमें क्या क्या हमने सीखा अभी तक? What was this? Primary author का नाम and year of publication. Then this cases and control number. जो भी cases include किए गए with the changes in weight in their study. Next, this one we studied in the right side. It can be at the left side as well. So what is this? This is the point estimate with 95% confidence interval. This is the real graph. So now by visually seeing it, what you can predict, like it favors the semaglutide. The whatever studies are favoring the semaglutide intervention. Studies are closely related, so heterogeneity is moderate kind of. You can see about the pooled effect. Next, it was a mean difference. Mean difference is which stats, relative or absolute? Absolute. So that is why line of null effect lies on 0 point. Next, we have this overall pooled effect value. Like Diamond is telling about the overall point estimate and the 95% say of all the studies. Getting it? Now, what's the take home message? Like, what's the minimum thing you should know about forest plot? That it is a visual summary of all the studies, and Diamond shows the pooled effect of all the studies, like final of the result. So this is the minimum thing you should know about forest plot, and definitely it is not some plot in the forest like its name. So thank you. This was all about forest plot. And one bonus tip, this is the Cochrane logo. Cochrane logo itself contains a forest plot in its logo. Thank you.
Thank you, Dr. Vyaktika and Dr. Diksha. After your wonderful lecture, we all understood that the forest plot has nothing to do with trees. Now, after such an intense and knowledge-packed session, I think our brain deserves a short tea break. So kindly move towards NLT for tea break.
Hello. Hello, hello. Good afternoon, everyone. Now we are going to discuss GradePro JDT. Settle down, please. So now we are going to discuss GradePro JDT, and I can assure you that it is an relatively easier software to use as compared to RevMan and Rob. Even if you have not learned those, if you have .rm file with you, you can easily learn it along with the demonstration only. Beginning with a thought experiment, imagine that an exhibition is going on. A diamond is on display. Unfortunately, many thieves are also in the parties. Some are trying to steal it through the roof, some are underground, some are in the ventilation shaft. All of a sudden, the light goes off. The light comes back and the diamond is missing. You are called in to investigate. You are provided with a lie detector machine. Now, unfortunately, since the people who are trying to steal it are proficient at lying, they can homeostasize, they can control their autonomic nervous system response. Their heartbeat and pulse rate does not rise when they tell a lie. Further, many people are in a state of panic. So everyone is giving his or her own version of truth, his or her own version of story. What will you do now? The best thing to do in such cases is to cross match all the evidences that you have and then tell which aspects of the event are certainly known and which are less certainly known, and then give an overall assessment. And that is where GradePro tool comes in. What have we achieved from RevMan? RevMan has systematically arranged all the quantities and given you ultimate absolute effect. But the question that remains now is certainty. How certain are we about the fact that this value is true? GradePro makes a summary of finding tables for us, which is necessary for systematic review and meta-analysis. And using that table, we can evaluate and assess the data we have achieved, and further, that data can be used to create guidelines and recommendations that XYZ domains are still unexplored and we need to research them more. Types of projects, summary of finding table which we need for SRMA. Evidence to decision framework is used in cases when we are doing SRMA for thesis. To be clear, in most of Indian medical colleges, it is not a valid thesis proposal, so it is irrelevant to us. Third thing is that guidelines and recommendations. All the huge guidelines you have heard, like GINA guidelines or guidelines made by WHO, all of them also pass through this same GradePro software only before being finalized. That is its importance. In the previous versions of GradePro, whenever you imported a project, it gave you the option that you have to choose one out of these three, but now it uses an integrated approach. So who knows that the analysis you do today may translate into a guideline on tomorrow. So I hope I have hooked your attention. The main thing is that it is a standardized method. It is not like you are sitting at your home and you are telling, I think I am certain, and the friend who is also working on meta-analysis, he is in college, he is saying something else. You have a fixed criteria on which you can make your claim. Further, once your research has been published, in case inquiry comes, you can export the file and tell them that these are the criteria on basis of which I told that I am certain or not, and then you can discuss conveniently. So hence, from now onwards, your research will not be just a quantified summation of Google. Risk of bias has already been discussed, and as Diksha ma'am had pointed out, that risk of bias is also a part of GradePro, and GradePro allows you to assess it on these metrics. Inconsistency. The error of inconsistency arises due to variability or heterogeneity. For example, let's say the light in the exhibition when it went off was slightly dim. So some people are, the 50% witness are 100% confident that the thief was a Bergman. But the other 50% people are also very confident that he had full hair. So what will statistics tell you in this case? So this is not possible. So what you should say instead is that we do not have consistent data over hair metric, and hence we cannot make a definite conclusion on this. Indirectness occurs in population, intervention, comparator or outcome. As example of population, we have take diabetic obese people between 18 to 65 years. But for some reason, if we have to compromise and one or more RCTs have diabetic people or people in excluded age group, what will it do? It will lead to indirectness of population. I hope some of you are aware of Captain America elevator fight meme scene, so I have included it. Participants in my 10-year-long clinical trial on cardiovascular mortality showed a dramatic improvement on grass-only diet. Grass diet. I studied cows. Indirectness of intervention. We have taken semaglutide versus placebo, but if in one study the other intervention was metformin. Indirectness of outcome. We are concerned with body weight change in kilograms, but if some study firstly takes BMI or body fat percent and then indirectly tries to estimate how it will translate into body weight in kilo, that will lead to indirectness of outcomes. This is how GradePro allows you to deeply assess these imprecision. मेरे को सब आता है, मैं expert हूँ. We send these to our friends when they are making huge claims, but their credentials are not enough to back up their claims. Similarly, in research, when a large claim is being made, but the sample size of study is very small, or if the confidence interval are too large to make it credible, that is when the error of imprecision comes in. Publication bias. As we all know that sometimes some journals are more enthusiastic towards publishing studies which show positive and new result, because obviously that is more exciting to publish. But life is all about positivity. I am HIV positive. So just like positivity is not always good in life, similar is the case with statistics. Now you must have seen this scene. Seen this scene already because this movie is so popular. A lot of laborers are trying to pull the statue, but it is not rising. Then Prabhas comes in, and since it is a South Indian movie, so he starts lifting and it starts rising. This effect in statistics is very relevantly named as large effect. Whenever there are many small studies, case report or case series for a rare disorder, and then all of a sudden someone conducts one single proper study That is when large effect comes in and it changes whole of the analysis. Plausible confounding, another Bahubali reference. The fight is going on. Tata asked Bahubali, will you be able to fight? Will you be able to survive? Bahubali says, मामा जब तक आप मेरे साथ हो मैं दुनिया में किसी को भी मार सकता हूँ, मुझे कोई नहीं मार सकता. मामा ने ही मार दिया. Similarly, if you have taken a study population, the population in this case is mama, or if you have taken rats, those are your mama. You are doing everything appropriately as per the protocol, you are randomizing, you are blinding, everything is perfect, but something inside the population itself happens unpredictably. Maybe let's say you are conducting a 10-year long study and then COVID comes in between, that changes everything all of a sudden, and that is totally unmeasured and also uncontrolled. You cannot even measure that what is the magnitude of the impact that it has caused. So that is plausible confounding. Dose response gradient, if in a certain case we are not proving that giving this drug, giving this intervention is showing efficacy, that's one thing, but we are also able to prove that when we increase the dose of intervention up to a certain plateau limit, there is a positive relationship. As the dose increases, so does the response. That is a positive dose response gradient, and obviously that is good for us. That is a positive evidence that increases certainty. So now how to access? I hope all of you have logged in already. GradePro.org. As soon as you will Google GradePro, this is the only result that will come at top. Still to be clear, it is .org. You have to click on Get Started, log in or sign up. How many of you have logged in? Okay, some of you. Now this step is important. At this step you do not have to click on new project, you have to click on import project. At this point you have to import the project we have downloaded from RevMan. If you will click on new project, what will happen is that you will have to manually add all the references, and then you will also have to manually add all of the data again, so that is useless. So simply the RevMan project we have downloaded, that has to be imported at this stage. Some of you may get this notification, we have to choose free version only. Fortunately $0, 3 team members, 25 question per SRMA, that is more than enough for us. Import project, then it will ask you for research questions, and the research question that were concerned in RevMan, those can be conveniently selected. This is another confusing step. Over here you may be confused, like I have to click here or here. No, the most boring button over here, the should semaglutide versus placebo, this long sentence, this has to be clicked. Then it will ask you what is the certainty. If you have opened it so far, in study design we have taken 4 RCTs, so all of those are RCTs, we have to tell it. You have to click in the gray portion and mark it as RCT. Further, we have chosen only high quality studies, so for smooth demonstration you can quickly mark it as non-serious, non-serious, non-serious in all the metrics. Further, you will get other consideration, in other consideration you will get the last effects like large effect, plausible confounding. In that you can mark undetected or anything insignificant. And after that, this is another new feature in GradePro, that is marking importance. If you think that the SRMA you have conducted is very highly significant for the world, for global academicians, you can yourself mark it as critical or important, or if it is not, then you can humbly show some humility and mark it as not important. Levels of uncertainty: high, moderate, low, very low. Exporting results, this door like button, this has to be clicked. It is on top right portion of the screen. Once you will do it, you will get something like this. In this, you will get an option to select MS Word or HTML or PDF, whatever you want to export it in. You can select that, and then you will get results like this. And the main thing is certainty. This is the final result we have attained by this exercise of GradePro. I will like to end with a quote. You can fool all the people some of the time and some of the people all of the time, but you cannot fool all the people all the time. Thank you.
Any question or comment? Anyone? So, thank you, Dr. Kaustubh. Now we understand that not all evidence is created equal. Some is strong, some is shaky, and it helps us to tell the difference. Now, we move on to essential step and last session of the CME, title and protocol registration by Dr. Kirti Rajan. Because in research, if it's not registered, it's like it never existed. Dr. Kirti Rajan?
Am I audible? Good evening. People on my left, good evening. People on my right, good evening. Good evening. Okay. So this is the last session. Everyone can relax. And offline participants can close your laptop and focus here. Okay. Before going into the topic, we will have some fun activities. So let's talk about Indian cricket. Which player comes to your mind first? Okay, some people are telling Dhoni, some people are telling Kohli. So who is the original Virat Kohli? Option A or option B? Online participants, you can also comment. Which one is original? Online participants, please comment on the YouTube. So obviously A is the original and B is the duplicate. So next activity will be, this one is very easy, right? So now find which is the original logo. This is a little difficult, I know. So B is the original. For original logo we have 3 lines and the spelling of first one is Abidas, not Adidas. Okay? So next activity, if I tell there is clear and pure water in this and I am telling someone to drink, they will drink, obviously, right? Why? Because I am telling there is a clear water. But if this glass is transparent, the water is not pure. It has some impurities. Okay, activity is over. Now we will go on to the topic. So why we are going to register a review title? Why do we register a review title? Okay, so first slide what is Virat Kohli, right? To avoid duplication. To avoid duplication, we register the title, and to improve the transparency of the research, we register the title, and to prevent some biases like outcome bias, publication bias, etc. and required by most of the reputed journals like Lancet, BMC, etc. So when to register? From morning you have been seeing the flow chart. Does anyone remember? You would have seen a point, register the title. So it is here, protocol writing and registration. Before going into this, most of you would have registered your thesis, right? Thesis or dissertation. What do you do first? You find a research question, then make the protocol, then send it to the institutional ethics committee so that they will register your title. So similarly, after developing the question and making the protocol, you have to register your title. So next, there are some registration platforms. We are not going to discuss about all of them. We will discuss mainly about Prospero today, and other platforms include Cochrane, OSF, that is Open Science Framework, InPlacy, that is International Platform of Registered Systematic Review and Meta-Analysis. Other platforms are not standard because they have some lacunae. So we will go into the topic proper, that is today we are going to discuss about Prospero mainly. So this is the website of Prospero. The name Prospero comes from the term prospective. This is a prospective register of systematic reviews, and it is managed by CRD, that is Center for Reviews and Dissemination, University of New York. The current version is running from February 2025. Okay, in Prospero there is two sections. Though it is a same platform, we can register for humans as participants and animals as participants. So most of the health outcomes are included in the inclusion criteria. So we will focus only on the exclusion criteria. If the data extraction is started at the point of registration, the study will be excluded from registration. Okay. Next, the indirect outcomes that impact on health, like educational attainment. If the parents are well educated, the health of the child is good. These kind of topics are not included in your systematic reviews. And reviews of sporting performance is not included. Traditional literature reviews, evidence and gap maps are not included. Critical appraisals and reviews for clinical practice guidelines. The guidelines are already published. If you appraise and review those guidelines, it cannot be included in your register. So some key points to note before we go into the demonstration. Not actual demonstration, it will be in the slides only. So the record is entirely the responsibility of the research team. The research team, those who are going to register the research, it is the entire responsibility of that team. Prospero will not take any responsibility of your lacunae. So named guarantor, that is either its principal investigator or the second investigator who are doing the research, they will verify the information before registration. And record may be withdrawn if there is clear evidence of misconduct. If you are giving any false information or any biased information, the research record will be withdrawn. There is some administrative procedures in Prospero, but not the peer review. Peer review is not provided by Prospero. Prospero will not send your review to anyone else and they will review it. You have to review your research, you have to review your protocol and then register in Prospero. Are you getting it? So we have come to the demonstration. This is not live demonstration, it will be in the PPT only. So before going into demonstration, how many of you done dissertation on clinical studies? Please raise your hands. Clinical studies. Okay. So have you guys registered in CTRA, Clinical Trial Registry of India? Have you guys registered? So Prospero process is little bit similar to CTRA process. So those who have already registered in CTRA may find it little bit easy compared to others. Though it's not that difficult for others also, I'm just telling for a reference. So after opening the website, the page will look like this. We will click on register your review now. If you are having an account, it will directly take into your account, or else we have to log in by joining us today. You guys can focus only on this click mark so that it will be very easy. So you have to fill your user details, title, first name, last name, everything, and your account will be formed. As I already have my account, I have mentioned my email ID and password. It will take into my account directly. So whatever terms and conditions they give in any platform, We don't read that much. You just click OK and proceed. Similarly, here also you click OK and then proceed. If you want, you can take your time and read. Then there will be option for human or animal studies. So if you are doing human, press select human as participants. If you are doing animals, animal as participants. So next will be, is this a live registration record or a training record? This is some thing for educational purpose. If you are selecting the training course, it will not be published on the public site. Like this is for academic purpose, for teaching the students. You can select this. But if you are going to register your original systematic review, then you have to select the first option. So this record is not being created as a part of training course. It will be published in the public site. So after registering, your record will be available for the public to view in the site. So what type of review are you planning? Till now only interventional review is available. So you have to obviously click that. So at last, you have to register your review. Till now it's clear? Any doubts? So we have a 12-point checklist for registering. In CTRA there is similar 22-point checklist. In this also there is more checklist. This is just a main 12 steps. Okay? We will see one by one. First step is review title and basic details. As you do for your thesis, we will enter the title, details of the title, everything, and the condition or domain being studied, that is what outcome you are going to study. Those things should be mentioned. Rationale for the review, like you write in thesis, what is the rationale for your thesis? You have to mention that. Similarly, the word column will come. Then review objectives, like aims and objectives you have for your thesis or dissertation, you have to type that. Keywords, you know well. Then country, which country you are going to do your review. So next will be eligibility criteria. We have the population intervention comparator as Pico criteria. Study design, mostly what we choose for systematic reviews. Speak up. What study we choose for systematic reviews? RCTs. So study design you have to choose RCT. Context, it's like why we are doing the study. It's similar to the rationale. So this is some inclusion criteria for the population. Which population we are doing the study. Similarly, for every column you will have the inclusion criteria and exclusion criteria. So next is similarly used. This is one of the important criteria for filling the form. So check for similar Prospero registration. Whether your topic is already used by someone or not. That you can check from here. If you select show similar records, it will show like this. There are some similar topics of your topic. Like what we are studying from the morning is semaglutide versus placebo. So if you don't want to check any similar records, you have to type the reason why you are not going to check. Like you can type you're updating the already present results or you're doing some new study. So review title question will come, is this review similar to your review? Like after the results are came, you have to select if your review is similar to the list. If it is different, you can select different. If it is similar, you have to again give your reasons. The reasons will be already present in that question. So you can select one of these, or if you have any other reasons, you can just type it. So timeline of the review. I have mentioned in exclusion criteria, when should we start the data extraction? After date of registration. So I have selected 28 February. Today is 26. So I have selected 28. You cannot select the before dates. If you select, the register will, like your study will be automatically withdrawn. So we have completed 4 steps. But this is halfway for the process. Other steps are very simple. Any doubts till now? What are the steps? First 4 steps? What are the first 4 steps? review the title and basic details, eligibility criteria, similar review column, that is very important. You have to check whether your topic is similar or not. Then timeline for the review. Timeline for the review is after your date of registration. So next, shall we proceed? Any doubts? Okay, availability of full protocol. Before registering, you will have a proper protocol already made with you. So you have to upload the protocol PDF to the Prospero. After uploading, you can select whether you want to make it publicly available or not. Then you can proceed. So searching and screening. Searching for unpublished studies. You have to select whether you will search for unpublished studies or published studies. Unpublished studies in the sense, there are many studies like thesis studies which are not published. So those can be obtained from thesis databases. So these are unpublished studies. Then selection process, you have to select studies screened independently by at least 2 people. If it is not at least independently screened by 2 people, you have to give valid reasons for that. Then language restriction. If you are having any language restriction, mostly what language you are using? English. So most researches are available in English, but some researches are available in other languages also. So if you have language restriction, you have to select only English. Then date restriction, like you have to select year, from which year you are going to search the RCTs. Then other methods for identifying studies, as I said, thesis databases, those things can be mentioned. Link to search strategy, selection processes and other relevant information about searching and screening can be mentioned if applicable. These are not mandatory. So next is data collection process. So data extraction from published articles and reports, study of risk, bias or quality assessment. What is the tool for risk of bias assessment? What is the tool for risk of bias assessment? ROP2. What is for certainty assessment? What is the tool for certainty assessment? GradePro. So you have to mention those things in these columns. So here also you have to select independently by 2 people. Then will study authors be contacted for further information? From where you are taking the reference, like which article you are choosing, you have to select authors will be contacted. So we have to select whether IPD data will be collected or not also. So next, outcomes. Like primary outcomes and secondary outcomes we have for thesis. You have to mention the main outcomes and additional outcomes. Next is planned data synthesis. This is one of the important process of meta-analysis. So data synthesis, here it is selected as no, but if you are doing a systematic review and meta-analysis, it is good if you select formal synthesis is planned. So what is data synthesis? We will discuss about that. Data synthesis will have all these 3, that is narrative synthesis, quantitative synthesis and heterogeneity. If all these three things are present, then only it is data synthesis and then only you can proceed for the meta-analysis, or else it will end up only in the descriptive synthesis or it will end up in systematic review only. So next is current review stage. Stage of the review at this submission, it will open as this. You would have already started researching about your topic. So that is pilot searching, then formal searching and study identification, like what you are going to search. Screening search results, you should select not started, because if you select screening, what will happen? That means you are already extracting the data, so you should not select started. Then data extraction, risk of bias, everything you have to select not started. So review affiliation, funding and peer review. So if you have published any papers, the journals ask for these details, right? Member details, affiliation of the members, funding source, if any present, like you are getting any funds from the outer source, peer review. Peer review is not provided by Prospero, as I said already. But you can mention someone you are going to review with in that peer review section. Like you can arrange your own peer review and then mention their details. Additional information has conflict of interest. So if you have any conflict of interest, you have to mention it clearly. If you don't have, you don't have to mention. Then mesh, medical subject headings, terms like keywords we have, those can be entered in medical subject headings. So after completing all these, now 12 steps are covered. Has anyone any idea total how many fields are there in these steps? I know it's difficult. Any guess? Total number of fields? There are 12 steps, right? So just guess how many fields will be there. 50. Anyone else? 30. Okay. There are total 38 fields and the mandatory fields are only 22. So when I said halfway there, we were here, field 13. That's why after 4 steps I told we are halfway there. So these are the 22 mandatory fields you have to fill, or else your topic will not be registered. You can take note of it later, it's not needed now. So this was the first, this is before doing all the process. So after doing, you can see everything is green. That means your process is 100% done. If you don't have this process 100% done, the submit option will not come. So when the process is 100% done, when you fill those 22 fields, then only you can submit the registry, submit in the register. Any doubts till now? How many steps are there? Total fields? 38. Mandatory fields? 22. Just remember these 22 fields, that is enough. And it will be very easy. In every step there will be instructions for you on the top of the page itself. There is nothing difficult in this. So summary, what is Prospero? Prospective register. It is an international prospective register of systematic reviews for both human and animal participants to avoid duplication, improve transparency. What we saw for duplication? Duplication, Virat Kohli. Okay. So process involved 12 steps and 38 fields in total, out of which mandatory fields are 22. Thank you. Any doubts? In every step you will have the instruction at the top. So you don't need to worry much. You just open, it will show itself. Thank you.
Thank you, Dr. Kirti, for such an informative session.
Now we have successfully completed all the academic sessions of today's CME. But research, however, does not end with the listening. It deepens with discussion, clarification, and exchange of ideas. With this spirit, we now move to panel discussion and question-answer session. Participants are encouraged to actively engage and seek clarification, followed by a post-test, as it will reinforce the concepts discussed throughout the CME.
All the speaker come forward, please. And so any doubt from the audience? Please clarify. Don't hesitate, because everybody starts with the 0. And if you have taken the first, it is more than enough. So any query, any doubt, please. Yes, yes. Mic दो बेटा.
For systemic review and meta-analysis, for making the research question, we had a protocol of Pico and others. So in case if we are doing a cohort, cross-sectional or a randomized study, then what would be the protocol for making the research question?
Please repeat your question.
For systemic review and meta-analysis, we had a protocol for making the research question like Pico, PEO or etc. So in case we are doing a cohort, cross-sectional or randomized study, then what will be the protocol for making the research question?
Okay. I have experience only in the interventional systematic review and meta-analysis. So other than this, I have little idea. Na? So I will.
Now, your question is, suppose you want to do some cohort study, okay? Cohort study and other studies, now they will follow the same thing. Like your one study will be cohort, na? Now, like that, there will be multiple studies. When they will be merged, then they will be like systematic review or something else, whatever you think. Okay? So one single study, any research project goes with the same steps. Okay? So don't think that research goes in different steps. Only thing is that whatever being taught today, whatever being discussed today, it is on the studies which have already been done. Now you are just getting the something extract from those studies. If you are conducting a new study with the cohort or with the case control or anything, now the steps are same. So don't worry that it will be like each and everything will be same. The difference is that you are going to do the new study. Here the study have been already been done. Now the extract from the extracts. Okay.
Actually, concept is the same of the research, but there is slight changes in the terminology, in the tools, like ROB2. ROB2 is for RCT, like Robbins for observational studies. Then again, Robbins E, Robbins I. So similarly, the tools may be changed, some terminology may be changed, just like Pico, PO है ना. तो ये थोड़ा change हो जाएगा, लेकिन concept वही रहेगा आपका.
Research is from known to known, from known to more known, from lesser known, more known, and from, having a gray to the black and white. And the steps are same in everything. Whether you are going to do the fresh research or the research over the research. So they have actually taught the research over the research.
अच्छा, in my first presentation I asked a question. तो क्या था लास्ट पे एक पिक्चर दिखाई थी मैंने आपको. तो how many of you are in do you feel that you are in my club? There were two pictures. Whether you know everything, otherwise you are invited to my club. So invited to my club means there were questions, there were queries. Means you want to know more. है ना? So it is better to have queries. Now it seems that you have so many queries. It's really good.
You are in his club and he will tell that which club you have to go. Successfully conducted, so naturally he will give some treat to you. तो पूछ लेना सर कहाँ जाना है, कौन से क्लब में जाना है. ठीक है. और कुछ? हाँ पूछो.
Respected sir, in the starting it was told that to perform a systematic review, we need at least 3 or more authors, and ideally it should be 6 to 8. But sir also told that in one of the studies it was around 1500 authors. So what could be the reasons of having such a major manpower, using so many authors and conducting a systematic review?
Court marriage needs only 3: husband, wife, and judge. And there are marriages which are having 200, 300, then thousands, then. So depending upon the gravity of the study, or depending upon the utility of the study, depending upon the cooperativeness from others, suppose you don't know anybody, so 1500 कहाँ से लाओगे? न्योता दोगे ना? तो न्योता किसको दोगे? जो एक्सेप्ट करेगा, तो एक्सेप्ट करने के लिए कोई है नहीं, तो at least you have to be within limit. When you have very, pertinent study and that needs large scale data and large population, large data and requirement of the multiple centers, multiple authors, naturally then you will collaborate. So collaboration is the key. So collaboration is not needed in each study. It is needed in the desired one. And it is the wiseness of the principal investigator to whom to collaborate. If your collaboration is wrong, you will end up into the, difficulty. So don't think that 1500 will be good every time. 1500 will be very bad if your collaboration is not appropriate. So 3 is good, 4 is good. Don't think that 10 or 20 will be required every time. No. Depending upon your project, depending upon your what you are going to do and what is your aims and objective and other things, and collaboration is needed. And you must be very focused over to whom to collaborate. Okay? Thank you.
Sir.
Nothing like कि 1500 वाला एकदम अच्छा है ना, no guarantee. ठीक है? No guarantee. Anything? Anything more you want? Clarification? उधर कुछ आ रहा क्या? Online आ रहा है? कर दिए, ठीक है. So if it is no further query, then I'll बैठ जाओ. Then I'll put the vote of thanks. कौन करेगा? हाँ, लो. तुम करोगे?
Thank you, respected dear all. We kindly request all participants to complete the feedback form shared with you, as your valuable suggestions will help us improve and organize future academic program more effectively. Today's CME has not only strengthened our understanding of systematic review and meta-analysis, but has also reinforced our commitment to evidence-based medicine and responsible research.
As we come to the end of this enriching and intellectually stimulating CME, it is my honor and proud privilege to express my heartfelt gratitude to all those who made this CME a grand success. I express my deep gratitude to our respected head sir for continuous support, visionary guidance, and for always encouraging us to think beyond textbooks and move towards meaningful research contribution. I sincerely thank to all our esteemed speakers for sharing their valuable knowledge. Also, I would like to acknowledge our entire organizing committee members and member of Department of Pharmacology and Therapeutics, whose dedication and hard work ensured the seamless execution of this program. A special thanks to all the delegates and participants for your enthusiastic involvement. With your presence, the CME would not have been meaningful. On the behalf of Association of Community Pharmacotherapeutics, I thank each and every one of you for being the part of this academic journey.
Let us continue to work together to promote regional therapeutics, responsible research and community services. Thank you, respected and dear all. Have a wonderful day ahead.
This program is on hybrid mode. And what is the most important when you actually organize anything in hybrid mode? A technical support, IT support, and we are indebted with the support by the IT cell. Thank you, thank you. Because, because those who are not here, they are also enjoying the same content. They are also taking the messages in the same way. And it is because of your, continuous support from the IT cell. And I give my thank to IT cell from the core of the heart. And always, thankful to the administration for encouraging us and giving us support in any form. Just I said once, and the support is being provided. So once again, and please convey my thanks to in charge, madam. Thank you, thanks a lot. And before we disperse, we will have national anthem, and then we'll.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Here's the reaction.
This is not my birthday, this is the birthday of CME under the aegis of Association of Community Pharmacotherapists. So hip hip, hip hip, hip hip. And you ask Dr. Rahul which club he wants to.